Good morning. Good morning, everyone. So we are going to start e-research paper session. I would like to invite Chairperson Dr. Lalit Gupta and Dr. Jhula Kanti Madhav.
Good morning, everyone.
Good morning, everyone. It's Madhavi, not Madhav.
Sorry, ma'am.
It's okay. Sir, good morning, Lalit sir. I'm Dr.
Good morning,
Madhavi
everyone.
from Usmania Medical College.
So good morning. I'm Prateek from the technical team. Do we start? Dr. Lalit Gupta sir and Dr. Madhavi sir.
Yeah, please, from my side, you can start.
All right, sir. Thank you. We'll just start. We'll start the video.
Good morning. Myself, Dr. Himali Vinayak. My co-author, Dr. S.P. Gangadhar sir. My topic is ketamine eliminates propofol pain but does not affect the hemodynamics during induction. Pain during injection of anesthetic agents is very distressing to the patients and can reduce the acceptability of agents such as propofol for short cases and daycare surgeries. Propofol injection is known to cause pain during induction of anesthesia. Ketamine has shown to reduce this pain, but ketamine increases secretion production and hemodynamic responses, which will induce pulmonary and hemodynamic adverse effects. The aim of the study is to determine whether ketamine can safely reduce propofol injection pain during induction of anesthesia. Our objective is to compare the effectiveness of ketamine injection as a pre-medication eliminating propofol-induced pain in comparison to when propofol injection is given alone. In my study, I have included all patients belonging to ASA Class 1 and Class 2. Age group of 18 to 60 years was included. Patients gave valid information risk consent. My exclusion criteria was all patients belonging to ASA Class 3 and Class 4, patients having history of exposure to any of my study drugs, in hemodynamically unstable patients, patients having psychological disorders, pregnant female, any patient having intracranial lesions, documented coagulopathy, coronary or vascular diseases. This study was conducted in the Department of Anesthesiology and Critical Care in Sri Siddhartha Medical College, Tumkur. Ethical clearance was taken and approved. Written informed risk consent was taken. A proper pre-anesthetic checkup was done, including a detailed history taking general physical examination and systemic examination. Proper airway assessment and spinal column examination was done. All relevant and necessary investigations were done. I divided my patients into two groups, Group A and Group B. Group A included the patients receiving only propofol 1 to 2 mg per kg for induction. Group B included the patients which received ketamine 0.5 mg per kg followed by 1 to 2 mg per kg of propofol which was given 30 seconds later. A note of pain score was done during induction as well as hemodynamics and secretion production was noted during anesthetic management. Comparison of the pain transition and gender among the two groups were performed using chi-square test of Fisher exact test. In my study, it was noted that there was no significant difference in the blood pressure and the heart rate in the two groups. In Group A, which included only propofol, patients experienced some pain on the dorsum of hand. In Group B, where a pre-treatment of ketamine was given along with propofol, pain was significantly reduced. It was also noted that pre-treatment to propofol with ketamine does not increase secretion and also significantly reduces pain. The exact mechanism of how propofol causes pain is still unknown. There are two theories regarding this. The first theory is that it causes direct irritation, and the second theory is that there is an indirect effect on the kinine cascade that results in kinogen release from the vein wall causing pain. The reduction in propofol-induced pain with ketamine may be due to peripheral local anesthetic agent which will attenuate afferent pathway rather than causing central analgesic effect. Both ketamine and propofol when given together have hemodynamic stabilizing property. Low cost, ease of administration, effectiveness, and the ease of availability has made ketamine a very attractive option. So, our study has proven that low-dose ketamine was more effective in reducing the incidence and the severity of pain when compared to propofol being given alone. Ketamine also preserves hemodynamics even after administration of propofol and do not produce emergent agitation with low-dose usage, making it a better option than when propofol is given alone. These are my references. Thank you.
Next, please.
Sir, can I ask one question?
Yeah, please.
Doctor, what is the advantage of ketamine if you compare with lignocaine or xylocaine? Can you hear me?
Yes, you are completely audible, madam, but I think participant is not listening.
Okay, sir, you continue, sir.
Yeah, ma'am. Please, the next one then. Can you have the next one, please?
Yes, sir.
सेकंड का होगा
2 मिनट का डिस्कशन है बस हो ही नहीं पाया इसका
Dr. Archana BH, final year postgraduate student in ESI Medical College, Rajajinagar, Bangalore. My presentation is a study comparison of equiconcentration of bupivacaine fentanyl and ropivacaine fentanyl for epidural labor analgesia, and the guide for my study is Professor Dr. Prasad CGS. Introduction. Central neuraxial analgesia is gold standard for pain relief during labor. Bupivacaine and ropivacaine are widely used to provide epidural labor analgesia along with adjuvants. But the use of bupivacaine is limited by the risks of motor blockade and its toxicity. There has been conflicting comparison of bupivacaine and ropivacaine for labor analgesia. Hence, the present study has been taken to compare the equiconcentrations of low dose 0.125% bupivacaine fentanyl and ropivacaine fentanyl. In the methods, after the ethical clearance was taken, this prospective randomized double-blind controlled study was undertaken in our hospital in 60 primigravida parturients divided into 2 groups by computer-generated randomization table. Group B received 0.125% bupivacaine with 2 micrograms per ml fentanyl. Group R received 0.125% ropivacaine with 2 micrograms per ml of fentanyl. The following were the inclusion and the exclusion criteria. Inclusion criteria was primigravida with ASA1 physical status. Exclusion criteria was primigravida with comorbidities and multigravida. 12 ml loading dose of the drug was injected after inserting the epidural catheter. After 20 minutes, 5 ml of the drug given if there was no analgesia. If there was no analgesia even after 30 minutes, patient was excluded from the study. Analgesia was maintained by intermittent bolus of 5 ml every 40 to 60 minutes. Additional supplementation of 5 ml solution was given when the VAS score was more than 4 to a maximum of 10 ml per hour till the delivery of the baby. VAS score was recorded every 5 minutes till the end of the procedure. Hemodynamics, patient satisfaction, total dose was recorded. In the statistical analysis, sample size was calculated using the software www.open.epi.com. Sample size was calculated from the study of Mr. et al. With alpha error of 0.05 and the power of the study was 80%. The sample size was calculated to be 24 in each group. To allow for dropout, the sample size was taken as 30 in each group. The mean value of both the groups, bupivacaine and ropivacaine, was compared with unpaired t-test, and for comparing attributes, chi-square test was used. P-value less than 0.05 was considered significant. In the results, demographics were comparable. The trend of mean VAS score was similar and was comparable at different intervals of time. Patient satisfaction, hemodynamics, and total dose between the groups were comparable. Discussion. The confounding results in various studies is because of variation in concentration, volume used, potency, and the adjuvants used. Relative potency between the two drugs are conflicting. Some studies have found 0.125% concentration were comparable. To conclude, both the drugs bupivacaine and ropivacaine are effective for labor analgesia, but because of cost, bupivacaine is preferred. These are my references. Thank you.
Dr. Archana, may I have a question, please? Hello, Dr. Archana. Dr. Archana, may we have a question, please? There seems some problem.
Sir, she will join shortly.
Okay. So do we have Archana here? No.
Sir, why are they not joining for questioning, sir?
Hello, Dr. Archana? No.
Sir, can we move on the next?
Yeah, please.
अनम्यूट कर लेना अपना, ठीक है?
Good morning, everyone. My topic of presentation is an original article, a randomized control study comparing dexmedetomidine midazolam with fentanyl midazolam for sedation during awake fiber optic intubation and the anticipated difficult airway. Awake fiber optic intubation is associated with increased sympathetic response during the management of difficult airway if the sedation is inadequate. Dexmedetomidine, which is an alpha-2 agonist, induces sedation and analgesia and is effective for use during awake fiber optic intubation. Fentanyl and its congeners have been widely used to reduce the hemodynamic stress response to intubation and also in awake fiber optic intubation in various clinical studies. Hence, this study was undertaken to compare the sedation score and ease of intubation with dexmedetomidine midazolam and fentanyl midazolam during awake nasal fiber optic intubation under topical anesthesia. This study was undertaken after the approval of the Institutional Ethical Committee, and this was prospective randomized double-blind study. Sample size calculation was done, and this is the inclusion and exclusion criteria. All the patients were randomly assigned with computer-generated randomization schedule into either dexmedetomidine midazolam group or fentanyl midazolam group. Group DM received an infusion of 1 mic per kg dexmedetomidine in 50 ml saline over 10 minutes, and group FM received an infusion of 2 mic per kg fentanyl in 50 ml saline over 10 minutes. Written and informed consent was taken, and the preoperative nostril with greater potency was prepared. Topicalization was done, and transthecal injection of 3 ml of 2% lichenocaine was done. In the operation theater, ASA standard monitors were applied. The patients were premedicated, and thereafter the infusion of the study drug was started. The level of sedation was assessed by an anesthetist doing awake fiber optic intubation by modified observer assessment of alertness and sedation scale. After adequate sedation achieved, the fiber optic scope loaded with appropriate size tube was inserted through prepared nostril into the hypopharynx and advanced into the trachea. Thereafter, general anesthesia was administered. The parameters assessed were primary outcome measures in the form of intubation score, recall, satisfaction score, intubation time, first end-tidal CO2 after intubation, and secondary outcome measures were heart rate, blood pressure, and saturation. A statistical analysis was done. The data analysis was performed using SPS version 20. This is the observation and the result. The demographic data in both the groups was statistically not significant. The score of modified observer assessment of alertness and sedation scale in both the study groups at the end of infusion of loading dose, before intubation and post intubation, was statistically not significant. And when the quality of awake fiber optic intubation was compared between both the groups, the values were found to be statistically not significant. And the time for intubation and first ETCO2 after intubation was lower in dexmedetomidine midazolam group. Hemodynamic parameters were also compared. Awake fiber optic intubation has been well recognized as one of the best techniques for the management of anticipated and unanticipated difficult airway. In the present study, the score of modified observer alert assessment for alertness sedation was comparable between the group. This was contrary to the study done by Lee et al., who observed significant lower score in dexmed midazolam group compared to sufentanil midazolam group. In the present study, there was no statistically significant difference in intubation condition, tolerance, comfort, and satisfaction score during fiber optic intubation. This is similar to the study done by Saeed et al., Zhu et al. In the present study, dexmed midazolam group showed less incidence of recall, which was similar to the findings observed by Shane et al. In our study, the mean time to intubation was comparable to the observation done by Shane et al. And Lee et al. During intra-group comparison, hemodynamic parameters were observed to be statistically significant difference from the baseline. Similar observation has also been reported by Mandal et al. And Saeed et al. In the present study, less incidence of desaturation and lower ETCO2 values seen in dexmed midazolam group. This has also been reported by Yusuf et al. And Shen et al. We conclude dexmedetomidine midazolam and fentanyl midazolam infusion provide good conscious sedative condition for awake fiber optic intubation. There was no financial support and any kind of sponsorship. There was no conflict of interest. These are my references. Thank you. Good morning, sir. Sir, I am not able to hear you, please. I am not able to hear you.
Okay, Jay, am I audible?
Yes, right now.
Yes, sir.
Okay.
You are at.
So the question is that did you did some oral preparation before giving the dexmed or midazolam infusion?
Actually, I have not given any kind of oral preparation, sir. I have pre-medicated the patient.
So the dose should be high for the sedation for the awake intubation, and your patient must be sedated, completely sedated.
As we have planned, sir, 2 mics fentanyl in 50 ml saline. That was to be infused for 10 minutes, and 1 mic per kg of dexmedetomidine in 50 ml saline. And that was again to be infused for 10 minutes. And we observed the various scores.
There was no episode of bradycardia with dexmed?
Sir, among the complications in dexmedetomidine midazolam group, only one patient was having the episode of hypertension, and in next group, in fentanyl midazolam group, only 2 patients having episodes of desaturation. Nothing more. These were the only.
Madam, please, Dr. Madhuri.
Okay, sir. What was the exact ETCO2 with when you compare with midazolam and fentanyl? How much it went up or down?
Actually, ma'am, in fentanyl midazolam group, the ETCO2 was around 44 as we have compared, and in dexmedetomidine midazolam group, that remains around 40.
That was not significant.
Yes.
Okay. Any other side effects could you make out with dexmedetomidine?
Only the side effects, ma'am, just were there was hypertension initially and desaturation in fentanyl midazolam group and hypertension in dexmedetomidine midazolam group. Nothing, any other complication was not there, in my study.
Thank you. Thank you, Jay.
Thank you, ma'am. Thank you, sir.
Next, please.
Respected seniors and my friends, presenting my topic, perioperative myocardial infarction and myocardial injury after non-cardiac surgery in patients undergoing cancer surgeries, a retrospective observational study. In cancer surgery, there is high risk for cardiac events. High sensitivity troponin well correlates with these cardiac events. Myocardial injury at non-cardiac surgery is defined as myocardial cell injury during the first 30 days after non-cardiac surgery due to an ischemic etiology associated with mortality. Short-term and long-term mortality significantly increase in patients with perioperative increase in cardiac troponin. Our aim was to find the incidence of myocardial infarction and myocardial injury after non-cardiac surgery in patients undergoing non-cardiac surgery in tertiary cancer center. The objective is to study the effect of elevated high-sensitive cardiac troponin on 30-day mortality after surgery for cancer in Malabar Cancer Center during the period from November 2017 to January 2008. Secondary objectives was to find the incidence of cardiac ischemia in patients who had postoperative ECG changes and to compare the median ventilation time in patients who had means with patients having no myocardial injury. The study design was retrospective. Settings was in Malabar Cancer Center, a tertiary care cancer center. Study period from 1st April 2020 to 31st June 2020. Inclusion criteria: patients undergoing cancer surgery at Malabar Cancer Center during the period November 2017 to January 2018. All patients having postoperative ECG changes. Patients in whom high sensitivity troponin was done in postoperative period. Exclusion criteria: patients in whom troponin T was done. Patients with incomplete data. All patients undergone cancer surgery who had postoperative ECGs. In them, the cardiac high sensitivity troponin was done. If it was more than 99 nanogram per liter, they were diagnosed with myocardial infarction. And in those patients, HS troponin was less than 99 nanogram per liter. Divided into two groups. HS troponin more than 90 nanogram was means positive patients, and HS troponin less than 90 nanogram was means negative patients. Data collected from patients' records and prospective observation study was done. Statistical analysis: all data assessed for normal distribution. Continuous variables such as age summarized in terms of mean plus or minus standard deviation. Comparison between two independent groups done by man-made U test and the p-value of less than 0.05 was considered statistically significant. Results: 28 patients underwent surgery. 26 patients had ECG changes. Mean age was 55.74. Females were 20 and males were 6. The means positive patients were 26.9% and means negative patients were 73.07%. There was no case of mortality after 30 days following the surgery for cancer. The median ventilation time when compared between means negative and positive patients was found to be insignificant. The incidence of MI was 0.33% and that of means was 2.34%. Coming to discussion, our study was compared with similar large cohort studies done in different parts of the world. In one such study, like Bota et al. Done in Canada, the incidence of means was 8%, myocardial infarction was 15.8%, and 30-day mortality was 9.8%. A study done by Pulitzer et al. In Switzerland, the incidence of means was 16%, myocardial infarction was 18%, and 30-day mortality was 8.9%. Such similar study was done in India by George et al. The means incidence was 7.5% and 30-day mortality was 11.7%. Compared to these studies, our study had a low incidence of means and low incidence of MI. Most studies have measured perioperative high sensitivity cardiac troponin. In our study, high sensitivity cardiac troponin I was done. Limitations: small sample size. Preoperative high sensitivity cardiac troponin was not measured. Conclusion: a lower incidence of means was observed in our patients undergoing non-cardiac surgery.
Madam, any question? Dr. Jasmine, you are there?
Yes, sir.
So how did you calculate the sample size for this retrospective analysis?
So actually, I did the study from November 2017 to January 2018. So all the patients who had postoperative ECG changes was taken into the study. So this then I got about 298.
Okay.
Jasmine, do you
Yes,
have troponin to know the troponin values at your institute? You will send
yes,
outside.
yes, ma'am. We have high sensitivity troponin I that we are doing here.
Okay. What is the normal troponin value?
Ma'am, actually, troponin value like from 14 to from 14 nanogram to 99 nanogram. It's if the troponin value comes more than 90 nanogram, it is said as myocardial injury after non-cardiac surgery. And if the values goes more than 99 nanogram, it is diagnosed as myocardial infarction. If the value is less than 90 nanogram, it's regarded as negative.
What do you think? Troponin is better or pro-BNP is better to know exactly about the myocardial injury?
Pro-BNP, we can have a prognostic value. like but troponin will help to diagnose the condition.
Okay. Thank you.
Thank you, ma'am.
Next one, please.
Myself, Dr. Trishna Rao Talware, President of Dr. Vasantra Power Medical College, Nashik, and my topic is measures to reduce the carbon credit in operation room. After looking at this topic, many of us might be thinking, what is carbon credit? Carbon credit is a permit which allows a country or an organization to produce a certain amount of carbon emission and which can be traded if full allowances is not used. The global health industries is responsible for 2 gigatons of carbon emission each year. Anthropogenic climate changes is happening, and the hospital and the operation room have major opportunity to mitigate the climate change and the effect of global warming both directly and indirectly by reducing their own carbon emission and influencing others in the society. This is another important definition. Rich gas flow is high. Large amount of the gases are vented into the atmosphere. All the gases vented into the atmosphere remain in the atmosphere for longer time, and they also contribute to the ozone depletion. These waste gases can be managed by turning off the fresh gas flow during intubation, properly inflating the endotracheal tube and laryngeal mask cup to prevent leak, properly maintaining the anesthesia machines and valve to prevent the leak, not employing high gas emergency unless the vaporizer and nitrogen oxide are turned off. The PBT index, persistent bioaccumulation toxicity index, is useful in determining the polluting potential. The PBT of propofol is highest, that means it remains in water for a longer time and is also toxic for aquatic animals living in the water. These intravenous drugs and non-drug waste can be managed by following ways: by using small vials of propofol and avoiding drawing of extra drug. Reloading of the drug is avoided in non-emergency conditions. Encouraging the manufacturer to promote greener packaging. Not allowing the plastic bag in operation room. As an anesthesiologist, we can encourage the regional anesthesia over general anesthesia. We can educate the health personnel regarding the segregation of the waste. The gold standard technique for estimation of the carbon footprint analysis, the economic input-output life cycle assessment analysis hybrid. Waste minimization in operating room can be done by removing 5 R's: reduce, reuse, recycle, rethink, and research. In this study, we deal with the overall reduction in carbon emission in operating room by simple technique, gas flow management, and reusing the endotracheal tube and three-way extension after treating them with ethylene oxide will help to reduce the cost per patient and also solid waste emitted from the operation room. As we are not using the disposable gown, plastic strip, disposable anesthesia circuit, we have reduced clinical waste at significant level. We are doing PTO of the anesthesia circuit, flexometallic endotracheal tube, and nasopharyngeal and oropharyngeal airway. We are reducing the carbon intensity per operation. On conclusion, at our tertiary care institute, the carbon dioxide emission is reduced as follows: judicious use of ozone depleting gases like isoflurane, nitrous oxide, avoiding desflurane completely, considering total intravenous and regional anesthesia for most of the patient, avoiding drug preloading in non-emergency condition. These are my references. Thank you.
Dr. Trisha there?
Yes, sir.
So do you have any indicator to measure the carbon emission in your OT, or it's just as per the literature that you are doing?
So there are devices to measure the carbon emission, but if there is not, we have not that device in our OT currently.
So what you are doing is you are not using the disposable items mainly.
Yes.
Okay, fine. So do you find any change in your patients? Since you are using it reusable items, are you using it as per the company recommendations? Like this cannot be used twice, then you are getting an autoclave.
Sir, we are if the if this, for example, if it's CT tube, if it's given one time use, we are using only for after ETO is only using for one time. That flexometallic, if we can use only 2 times or 3 times, not more than that. So that we can reduce the cost.
Okay, fine.
Krishna, what do you think? Scavenging system is better not to avoid this all. To better to get scavenging system other than this such all during pandemic situations like COVID. Did you get me?
CO2, yes, ma'am. That CO2 absorbers. Hello. Hello, ma'am.
Yeah, tell me.
Hello. Ma'am, that CO2 observer you're talking about, scavenging system.
Ma'am is asking about the scavenging system, not the
scavenging systems. How do the scavenging system help than doing all this?
No idea.
No. Okay.
Thank you, ma'am.
Okay.
Very good morning to all of you. Today I'm speaking on the topic randomized comparative study of ondansetron and combination of ondansetron and dexamethasone as a prophylaxis of postoperative nausea and vomiting in adults undergoing electrolaparoscopic surgeries. PONV is quite associated with laparoscopic surgery, and in spite of advances in surgery and post-surgical care, nausea and vomiting still has a high incidence. This study was planned to explore the efficacy of a combination therapy of ondansetron with dexamethasone against PONV and compare the results with the efficacy of ondansetron only. A randomized clinical trial study was conducted in the Department of Anesthesia, GMC Jammu, over a period of 6 months on 50 patients in age group of 18 to 50 years of either gender, ESA 1 and 2, undergoing elective laparoscopic surgeries under GA. Patients were divided into 2 groups of 25 each. Group A received 4 mg of ondansetron IV, while Group B received 4 mg of ondansetron and 8 mg of dexamethasone IV soon after intubation. Patients below the age of 18 years and above 50 years, ASC grade 3 and 4, pregnant women, patients with history of motion sickness, those on chronic steroid therapy, and those who had received antiemetic within 24 hours, patients with diabetes mellitus, intestinal obstruction, hiatus hernia, renal hepatic diseases were excluded. In the operative room, anesthesia was induced with 5 mg per kg STP and relaxed with vicuronium 0.1 mg per kg and maintained with oxygen nitrous at 50-50% with isoflurane 0.5 max. Muscle paralysis was reversed on completion of surgery with 0.05 mg per kg neostigmine and 0.015 mg per kg glycopyrrolate. Diclofenac sodium was given for post-op pain. Duration of surgery and anesthesia was noted. Patient was observed for 24 hours post-operatively. Nausea, vomiting, and pain were recorded hourly for 4 hours and then at the end of 24 hours. Any other complications were also noted. PNV were evaluated using nausea and vomiting score and categorized as severe, moderate, and mild. The anticipated incidence of PNV taken as 30 to 70%, anticipated difference of PNV between two groups 20%, margin of error 5%, power 70%, minimum sample size came out to be 36. Ethical clearance was received from Institutional Ethical Committee and statistical analysis was carried out using MS Excel 2010 software. Chi-square test was performed with p-value less than 0.05 considered as significant. The demographic variables like mean age, mean weight, gender were quite similar. The mean duration of surgery and anesthesia were also similar between the groups. PUNV was significantly higher among group A patients. However, 24% did not complain about any kind of nausea and vomiting in group A either. While 19 patients showed post-op nausea in group A, only 8 patients experienced nausea in group B, which was very significant. Similarly, 11 patients showed post-op vomiting in group A, and only 2 complained of vomiting in group B. No complications of any kind were observed during this study. In the present study, mild nausea was observed in 60% patients in group A, while among only 32% patients in group B. Similarly, mild vomiting was observed in 28% patients in group A and 8% patients in group B. The combination therapy therefore proved to be useful and quite in agreement to other studies. And a resource-strived country like India, cost-effective alternatives like this combination therapy can be very helpful. The efforts concluded that ondansetron and dexamethasone administered intravenously after intubation in laparoscopic surgery is safe and quite effective in preventing nausea and vomiting, and has shown better results than that of IV ondansetron administered alone. Thank you.
Madam, please, your questions.
Good morning, sir.
So, doctor, I would like to ask you, see, dexamethasone itself has a antiemetic property, and you are using ondan versus ondan plus dexa. So, is not it is a bias that you are doing the double emetic agent in one group and the single emetic agent in another group?
Yes, so that is for the comparison that we are doing, because many a times we have to use 2 drugs also in high-risk patients, and that is why, because initially we have to start with the first line, which is ondansetron, and at times in high risk we have to compare with the combination therapies.
Laparoscopy is not a high-risk surgery, no? It's a simple surgery.
Yes, sir. But there are more chances of because of carbon dioxide insufflation, pneumoperitoneum, and also because of that manipulation, it increases the chances of nausea and vomiting, these laparoscopic surgeries. So.
Madam?
Disconnected. What she said, I couldn't hear exactly. See, if you use propofol itself, it does not
exactly
cause PONV. Then why are you using thiopentone, which is liberally useful everywhere? And for daycare for surgeries, why do you opt thiopentone? What is the thiopentone off-life? What you said? Patient can get it done and go away home, no?
Yes,
what do you think?
Yes, ma'am, you're right, because it itself has antiemetic properties. So just to avoid that confounding variable, so that's why I avoided this propofol in this study and used STP itself, because it also has its.
My advice is thiopentone. It does not eliminate from body for 72 hours. 72 That's why to get laparoscopic surgery is better to go propofol is better. Okay, thank you.
Okay, ma'am. Thank you. Thank you so much.
Our study is a comparative study between intravenous dexmedetomidine 0.6 microgram per kg body weight and intravenous labetalol 0.25 mg per kg body weight to attenuate the hemodynamic stress response to laryngoscopy and intratracheal intubation. Author myself, Dr. Sindhu S. and Dr. Viva Srinivas. Direct laryngoscopy and endotracheal intubation are both unpleasant stimuli leading to hemodynamic stress response in the form of tachycardia, hypertension, cardiac arrhythmia. Dexmedetomidine is an alpha-2 adrenergic agonist with unique effects like analgesia, sympatholysis. Labetalol is alpha-1 and non-selective beta-1 and beta-2 adrenergic antagonist. Thus, the present studies are undertaken to compare between the two. The main objective is to study the effect of study drugs on hemodynamic parameters. After obtaining ethical committee clearance, informed consent was obtained from all the patients. Duration of study was 1 year. So, adults aged between 18 to 55 years, essay class 1 and 2, Mallapatti 1 and 2 are our inclusion criteria. Exclusion criteria: subjects with heart rate less than 60 beats per minute, systolic PP less than 100 mm of Hg, cardiac, renal, and cerebral disease were excluded from our study. The final study sample was fixed at 30 patients in each group. Analysis experiments was done using ANOVA test. A p-value less than 0.05 was considered statistically significant and less than 0.01 was considered as highly significant. 60 patients were allocated into two groups based on shuffled opaque seal envelope containing name of the group. After recording the baseline readings, group DD received injection dexmedetomidine 0.6 microgram per kg body weight diluted to 10 ml of normal saline IV over 10 minutes using syringe pump. Subjects in group LL received injection labetalol 0.25 mg per kg body weight diluted to 10 ml of normal saline IV over 10 minutes using a syringe pump. Pre-medication was done using injection midazolam and injection ondansetron. So general anesthesia procedure was done for all the patients. Heart rate, systolic, diastolic blood pressure were recorded at baseline 258 minutes after drug infusion, before induction, after induction, and 1, 2, 3, 5, 8, 10, and 15 minutes after intubation. Results: demographic variables were comparable with respect to age, sex, and weight. The basal hemodynamic parameters were comparable and was statistically insignificant between the groups. The dexmed group showed a better decrease in hemodynamic parameters compared to labetalol group at all the study time intervals, which was statistically significant. In dexmed group, the mean heart rate had decreased by 8 beats per minute, whereas in labetalol group, the mean heart rate had increased by 3 beats per minute compared to basal value at first minute after intubation, which was statistically highly significant. In dexmed group, there was a decrease of mean systolic blood pressure by 17 mm of Hg, and in labetalol group, there was a decrease of 6 mm of Hg compared to basal value at first minute after laryngoscopy and intubation, which was statistically highly significant. In diastolic blood pressure, the dexmed group, there was a decrease of 12 mm of Hg of mean diastolic blood pressure, whereas in labetalol group, there was a decrease of 6 mm of Hg compared to basal value at first minute after laryngoscopy and intubation, which was statistically highly significant. These are the graphs showing comparison between labetalol and dexmed group. The blue color indicates dexmed group, which showed a better decrease in hemodynamic parameters compared to labetalol group. The rapid administration of dexmed will leads to transient rise in blood pressure and decrease in heart rate. That's why we choose to administer slow IV over 10 minutes using syringe pump. The distribution half-life of 5-year dexmed is 6 to 8 minutes, whereas labetalol peak effect occurs between 5 to 15 minutes. Our study results were on par with the study conducted by Keval Ramani et al., who used 0.5 microgram per kg of dexmed and 0.25 mg per kg of labetalol. Our study results were also correlated with the study done by L. Shma et al., who used 1 microgram per kg of dexmed and 0.25 mg per kg of labetalol. The hemodynamic parameters in both the groups remained below the basal level even after 15 minutes post-intubation, but dexmed showed a better decrease compared to labetalol, which was statistically significant. There were no statistically significant side effects in our study. Conclusion: our study demonstrates that single dose of injection dexmed 0.6 microgram per kg body weight given IV over 10 minutes was better compared to injection labetalol 0.25 mg per kg body weight given IV over 10 minutes, just 10 minutes before induction, effectively attenuated the hemodynamic stress response to laryngoscopy and intubation. These are our references.
Doctor,
Good morning, ma'am.
good morning. What is exactly the heart rate to be decreased to show the hemodynamic variation? You were telling about 8 beats, 6 beats, 17 mm Hg, 6 Hg. What exactly that?
Ma'am, actually, it is that comparison of heart rate and hemodynamic parameters after laryngoscopy at first minute after laryngoscopy and intubation compared to the basal value, ma'am.
No, ma'am, what is the significant value? What is the significant?
What is the significant heart rate to be decreased to know about your efficacy of your drug?
See,
how
you
much
have told it was significant, statistically significant, but how it was statistically significant? What was the baseline? How did you compare that?
Sir, actually, we took the heart rate, the minimum baseline value of all the patients between 80 to 100, sir.
No.
Okay. How much it got decreased? You said that it's 7. 6.
Yes, ma'am. Yes, ma'am. After first minute.
How did you?
Yes, ma'am. After first minute after laryngoscopy and intubation, if suppose the heart rate was between 80 to 100, it was decreased to 70 or 67 beats per minute in dexmed group, whereas in labetalol group it was increased by 3 beats per minute compared to their basal value.
Ma'am has asked if it was 10% or 20% decrease from the baseline, that is put as significant.
What I'm asking.
Sir, okay, the decrease was about 10 to 15%, sir. We took as
See, 10 to 15% means it will never come 8 beats beat per minute, 6 minutes, or 3 beats per minute. That means minimum 10 beats per minute to know about your significant value for your drug. Okay. Okay. Sir, you want to ask?
No, thank you. Next, please.
Okay, thank you.
Hi, I am Dr. Lakshman Singh Jatavarajan, Doctor Department of Anesthesia and SMS Medical College, Jaipur. My topic for paper presentation is a comparative study of metoclopramide versus ondansetron for postoperative nausea and vomiting in elective lower segment cesarean section under spinal anesthesia, a randomized double-blind interventional study. Introduction. Postoperative nausea and vomiting is a very common postoperative period causing discomfort to the patient and also delay discharge. Antiemetic drugs are beneficial for treatment of postoperative nausea and vomiting. We have selected IV metoclopramide 10 mg and IV ondansetron 4 mg to compare their efficacy and safety for prophylactic use in postoperative nausea and vomiting in lower segment cesarean section under spinal anesthesia. Method. A hospital-based prospective randomized double-blind interventional study was conducted after obtaining the permission from Institutional Ethical Committee in Department of Anesthesiology and Critical Care at Janana Hospital, Mahila Chikitsalayah, SMS Medical College, Jaipur. After obtaining written informed consent in 84 patients aged above 18 years belonging to the ASA grade 1 and 2, scheduled to undergoing elective lower segment cesarean section under the spinal anesthesia. 42% were received ondansetron 4 mg 5 minutes before the spinal anesthesia, known as a group A, and 42% were received metoclopramide 10 mg 5 minutes before the spinal anesthesia, known as a group B. Outcome variable were mean number of the vomiting episode, mean number of the nausea episode, mean number of the retching episode, mean nausea grade, and side effects. The incidence of the nausea was significantly more in group B than group A from first hour starting. Incidence of the vomiting decreased in group A than group B, and the incidence of the retching was significantly more in group B than group A at 2 hours. Discussion. Postoperative nausea and vomiting is described as a big little problem, and from the patient perspective, postoperative nausea vomiting is among the most distress complication of the anesthesia and surgery. Early study reported incidence of the postoperative nausea and vomiting as high as 75 to 80%. The etiology of the postoperative nausea and vomiting is complicated and multifactorial. Female gender has been associated with higher incidence of the postoperative nausea and vomiting compared to the male patient. The incidence of the emitting symptom is high during the pregnancy because of increased the concentration of the progesterone in the body. The increased progesterone level during the pregnancy decreased gastrointestinal motility and reduced lower esophageal pressure. The aim of our study to anesthetic management and prevention of the postoperative nausea and vomiting in women undergoing the elective lower segment cesarean section under spinal anesthesia. Robert Clarkson described the use of olive oil before any specific antiemetic agent become available. Various techniques including olive oil and insulin glucose infusion were reported to be effective in reducing the incidence of postoperative nausea and vomiting. Paxton et al. Has observed in their study that nausea occurs in 25% of patients who receive ondansetron as compared to the 59% of patients who received metoclopramide. Valin et al. Have observed 59% nausea in ondansetron group and 63% in metoclopramide group. Average age for postoperative nausea and vomiting in present study was 26.10 in group A and 26.02 in group B. Average weight for postoperative nausea and vomiting in patient study was 59.95 in group A and 63.50 in group B. Side effects were more common in metoclopramide compared to the ondansetron. Conclusion. We concluded from our study that IV ondansetron 5-hydroxytryptamine 3 antagonist in the dose of 4 mg has proved to be a better prophylactic drug when compared to the IV metoclopramide 10 mg in prevention of the postoperative nausea and vomiting in lower segment cesarean section under spinal anesthesia. Thank you.
Hello.
Yes, sir. Good morning.
Lakshman, you there?
Yes, sir. Good morning, sir.
Good morning. So you told there were significant more side effects with the metoclopramide group. What were those side effects?
Sir, there is a headache and restlessness, and sometimes means severe side effect is not there, but some like this dizziness, this normal side effects are there.
So they were the part of the extrapyramidal symptoms or just like simple side effects?
So they are the simple side effect actually.
Okay.
See, there is not there.
They were not a single side effect with the ondansetron group.
No, sir, some headache, minimum side effect is there, like headache and some patients with constipation.
Antiemetics do not have a side effect of headache.
Yes, sir.
Antiemetics usually do not have a side effect of the headache. It is mentioned they can cause sometimes the dizziness, but not the headache.
Yes, sir.
Okay. Madhuri, Ma'am, any question? So, from your point of view, androstenedione is better than the metoclopramide.
Yes.
Is that so?
Sir?
Okay. And with the equivalent dose of your androstenedione dose of 8 mg or 4 mg?
4 mg, sir. 4 mg.
4 mg. So, but the dose of the androstenedione in an adult is 8 mg. Is it not that?
Yes, sir. Point.
Okay, no problem.
0.05 to 0.15 actually. This is the dose.
And the dose of metoclopramide?
But metoclopramide 0.02 to 0.2 like
0.2 means
range.
Okay.
Mg per kg.
Okay. Next one, please.
Thank you.
To compare the efficacy of dexamethasone versus dexamethasone plus lignocaine on post-operative sore throat in lower abdominal surgeries. Sore throat is the most common complication, accounts in general anesthesia, and its incidence about 30 to 70%. Various strategies have been employed to attenuate the response, like IV opioids, IV lignocaine, IV dexamethasone, intracuff dexamethasone, and gargling and drugs to gargle. We determine the combined effect of these drugs. Aim to compare the effect of dexamethasone versus dexamethasone plus lignocaine on post-operative sore throat in lower abdominal surgeries. Primary objective is to determine the difference in percentage of cases developing sore throat at first and 24-hour post-operatively. Secondary objective to determine the difference in percentage of cases developing cough and hoarseness at first and 24-hour. Determine the difference in severity scores in first and 24 hours. Methods: design was randomized and double-blind. CTRI and ethical review obtained. Randomization done with opaque seal envelope. Double blinding was done, and sample size of 37 in each group was required. Group A was given injection dexamethasone 0.2 milligram per kg, and group B was given dexamethasone 0.2 milligram per kg plus lignocaine 1.5 milligram per kg. Eligibility criteria: inclusion of age of 20 to 50 years, patient of either sex, ASA grade 1 and 2, and non-smokers. Exclusion criteria: patient with pre-operative sore throat, cough, and hoarseness, history of respiratory infection in last 2 weeks, treatment with steroid, Mallampati grading 3 and 4, and more than one attempt for intubation. Patient is taken up in the OT with routine checkups, IV line and routine non-invasive monitors attached. Pre-medication of the patient was done. Study drug according to the group was given 5 minutes before the induction. Induction was done, and after induction, atracurium was given, and patient was intubated under direct laryngoscopy with appropriate tube size, ET tube size. Patient maintained on nitrous oxide and oxygen, sevoflurane, and atracurium. Surgery completed, and the reversal of the patient is done with neostigmine and glycopyrrolate, and patient is shifted to the recovery area. Mean time for the intubation and recovery. Percentage of cases in intubating parameters done. Percentage of cases developing sore throat, cough, and hoarseness, and their median severity scores are the outcome variables. Statistical analysis. Difference in the percentage of cases developing sore throat, cough, and hoarseness at first and 24-hour is done by chi-square test, and their difference in median severity score was done by t-test. Demographic and intubating parameters were found to be non-significant, and complications like sore throat, cough, and hoarseness were found to be less in group B than in group A at both first and 24 hours. The decrease in complication is seen at 24 hours than in first hour in both the groups. Decrease in the severity of grading is seen in sore throat, cough, and hoarseness from first hour to 24 hours, and severity was found to be less in group B. Discussion. Our study shows that the combination of dexamethasone and lignocaine was better in decreasing the post-operative complications, as in support Chu et al. Studied 75 patients and found dexamethasone plus lignocaine when combined was more effective than dexamethasone alone. Subedin et al. Conducted a similar study and found that combination of dexamethasone and lignocaine was far better in decreasing the incidence of post-operative sore throat. Bagchi and et al. Studied 96 patients and found that prophylactic intravenous dexamethasone decreases the post-operative complication effectively. In conclusion, the combination of dexamethasone and lignocaine is more effective than dexamethasone alone in decreasing the post-operative complication in first and 24 hours in lower abdominal surgeries. These are my references. Thank you.
Ankit, you there? Hello? Ankit?
Sir, I'm there. I was little busy, sir. You asked the questions.
Ma'am, the candidate is not there.
Not there, sir. There was one difficult intubation, sir. That's why I was busy.
No problem, no problem. But Ankit seems not to be there, so we cannot ask anything.
Okay, sir. అరే అయిపోయిందా ఇక్కడ అయిపోయిందా chairing the session, sir.
We move on the next. Can we move on the next?
Yeah, please.
Okay, sir.
Hello everyone, I am presenting my paper titled Comparative Evaluation of Propofol and Ketamine Midazolam as Procedural Sedative Agent for Ease of Induction of Spinal Anesthesia in Patients Undergoing Abdominal Surgeries. As we all know, positioning difficulties can cause both discomfort to the patient and also anesthesiologist. It may also lead to autonomic fluctuations. Providing procedural sedation may alleviate those undesired difficulties. There is an evolving trend towards the judicious implementation of the sedation during regional anesthesia. In this study, we are evaluating propofol and ketamine midazolam as procedural sedative agents for ease of induction of spinal anesthesia. So it's a prospective randomized control study conducted in our institution after obtaining the ethics committee clearance, and informed consent were taken from all the patients. Inclusion criteria being age physical status 1, 18 to 60 years of age group, including both males and females. Elective surgeries under spinal anesthesia were considered. Sample size was 60 based on previous studies, and the patients were randomly allotted into two groups with 30 patients in each group. Pre-anesthetic evaluations and pre-medications were given as per standard care. In the OT, baseline vitals were recorded and also good flowing IV line was also secured. Oxygen was administered via ventimask for all the patients at 6 to 8 liters per minute. Group A patients received propofol 0.7 mg per kg with increments of 20 mg till they achieved Ramsay sedation score of 4. And Group B patients received injection ketamine 0.5 mg per kg with injection midazolam 0.02 mg per kg along with IV increments of injection ketamine 10 mg till they achieved Ramsay sedation score of 4. Time to achieve Ramsay sedation score was also noted, and it was considered as the onset of sedation in Group A. Spinal anesthesia was administered in left lateral position. Following parameters were observed and analyzed. Ease of identification of space on an ordinal scale of easy, difficult, impossible. Number of attempts of successful spinal. Appearance of CSF was taken as successful spinal. Time to induce spinal anesthesia. Needle prick to appearance of CSF was considered. Patient comfort score from 0 to 10. Patient satisfaction score from 1 to 100. These are the results. Demographic data were comparable among the two groups. Ease of identification of space, there was no significant difference among them. Time to induce spinal anesthesia was longer in group A. Number of spinal attempts were also higher in group A. More than one attempt was higher in group A. There was a statistical significant better score in terms of patient comfort score and patient satisfaction score in group B compared to group A. So there was no significant difference between the two groups in terms of hemodynamics. Most anesthesiologists may omit the procedural sedation to avoid side effects of drugs. But in our study, none of the patients had any respiratory depression, hallucination, or delirium, or any other behavioral changes, as we had used lower doses of sedative agents and addition of midazolam. The number of attempts were significantly higher in patients who received propofol than ketamine midazolam, as patients would have moved while spinal is pricked due to pain in the former. To conclude, ketamine midazolam provides better comfort and satisfaction to the patients when used as procedural sedative agent compared to propofol. It also eases the induction of spinal anesthesia by reducing multiple attempts and the time to induce spinal anesthesia when compared to propofol. Thank you.
Dr. Mansa, you there? Dr. Mansa there?
Good morning, sir. Yes, sir. I'm here.
I have a question. Why
Yes, sir.
there should be a procedural difference in putting the spinal in both when you are sedating both the patient? One is the propofol, one is the ketamine group. Then why
Yes.
there is a difference in the procedural timing? Since you are saying there 16 and 32 in the propofol and 16 the ketamine group.
Yes, sir.
Meantime.
Sir,
Right?
actually, in propofol group, the patients they used to move, sir. Like when I had pricked the spinal, because the propofol doesn't have any analgesic property. Because of
You were not using the local before putting the spinal?
sir, for both I didn't put for both the groups I didn't give the local, sir, just to assess the differences between the two.
Okay.
Intentionally, we didn't give the local, sir.
Okay, fine. So you found that ketamine group is much better. But didn't you find any problem in positioning the patient
Yes, sir.
for the ideal spinal?
No, sir. So first only we used to keep them in the left lateral position and then inject the drugs.
Okay, fine. You means you had the positioning of the spinal with the leg bented and head down before putting the
Yes, sir.
sedation.
Yes, sir.
So you did not have the airway compromise in any of the cases?
Sir, one patient in propofol group had it, sir, the snoring kind of sound and all. With the nasopharyngeal airway, we could manage it, sir.
Okay, no person had the spasm with the ketamine group?
No, sir. No, sir. Nobody had it.
Okay.
Yes.
Mansa?
Yes, ma'am.
Mansa?
Yes, ma'am.
See, it's not every time possible to get spinal anesthesia in lateral positions. Okay?
Okay. Yes, ma'am.
What did you do for people who didn't get spinal anesthesia under ketamine, midazolam, and propofol? Whenever we don't get, we make it sitting
position. Yes.
Yeah. What did you do when you gave this such sedative agents?
Ma'am, actually, I didn't come across such.
You postponed the case?
No, ma'am. Like I would rather wait till they're okay and then make them sit and then give the spinal, because patient safety is more.
See, Manasa, this is anesthesia.
Yes,
In
ma'am.
lateral position, if you don't get, you get good position in sitting positions. It's
Yes.
not possible always to sedate the people before anesthesia. Okay?
Okay, ma'am. Okay. Okay. Thank you.
Thank you, Mansa. Next,
Thank
please.
you, sir.
రకరకాల పేపర్స్
Operative transdermal buprenorphine patch 12 hours versus 24 hours in postoperative analgesia following major abdominal surgeries. Major abdominal surgeries are associated with moderate to severe postoperative pain, which leads to increased hospital stay. Multimodal analgesia techniques can be invasive and non-invasive. Transdermal drug delivery system is simple and non-invasive, which offers the advantage of sustained drug delivery, increased bioavailability, and avoidance of first-pass metabolism. Buprenorphine is highly lipophilic, semisynthetic derivative of thebane, shows a partial agonistic activity and can be given by different routes. hours. Its onset of action is between 12 to 24 hours and peak effect is between 48 to 72 hours. The aim of the study was to compare the efficacy of preoperative transdermal buprenorphine patch 12 hours versus 24 hours on postoperative analgesia following major abdominal surgeries. Primary objectives are to measure the post-op analgesia in terms of VAS score, time to first rescue analgesia, total number and doses of rescue analgesia. Secondary objectives are to measure hemodynamic variables, adverse effects, sedation score, and quality of recovery score. After obtaining the approval from IRC and informed consent from the patient, I conducted the study between January 2020 to June 2021. It's a prospective, double-blinded, randomized study. Power analysis showed the sample size of 66. Total of 66 patients belonging to American Society of Anesthesiologists, grade 1 to 3, age between 18 to 70 years, of either gender, posted for major abdominal surgery between 3 to 6 hours were included. Patient with history of allergy to study drugs, severe comorbidities, chronic pain syndrome, pregnant lactating women were excluded. In group 1, buprenorphine patch was applied before 12 hours, placebo patch before 24 hours. In group 2, buprenorphine patch before 24 hours and placebo patch before 12 hours. Applicant not involved in the study applied the patch. Sample size was of 66 patients and analysis was done by using student t-test and chi-square test. 33 patients in each group. Total 6 patients were withdrawn by the reasons like epidural catheter blockade, failure to follow up, accidental epidural catheter displacement, inoperable condition. 60 patients were analyzed, 13 each group. Patch was applied before 12-24 hours. Epidural catheter inserted, general anesthesia given as per standard protocol. Hemodynamic monitoring done, bupivacaine 0.125%, bolus by epidural catheter. IV for internal bolus is given for analgesia. Epidural infusion started by bupivacaine 0.125%, 3 to 4 ml per hour. Rescue analgesia, PCM 1 gram was given on VAS more than or equal to 4. Post-op monitoring was done by VAS and Ramsey sedation score to 72 hours, QR 15 at 24 hours. VAS score group 2 shows the lower VAS score at rest at all time intervals in group 1 except at 12 hours due to the use of rescue analgesic drug. There's a comparison. Time to first rescue analgesia was earlier in group 1 as compared to group 2. Total number and doses of rescue analgesics in 72 hours were higher in group 1 as compared to group 2. These are my 3 graphs. This shows the adverse effects like sedation, nausea, vomiting, itching, drowsiness were compared and found to be higher in group 2 as compared to group 1, but statistically insignificant. Quality of recovery score was better in group 2 as compared to group 1. My present study have compared it with Yadav from the Journal of Anesthesiology and Clinical Pharmacology. He took 50 patients, applied buprenorphine patch on all the patients, and the patients undergoing hip and knee replacement surgery under combined spinal epidural analgesia received the patch 12 hours before the surgery. Post-op epidural infusion was started. Total 22% of the patient had no pain at all. Saikat Neoji from Indian Journal of Anesthesia compared the placebo patch with the buprenorphine patch and found the higher VAS score in placebo patch. In conclusion, post-operative analgesia in major abdominal surgery was found to be better when buprenorphine patch was applied 24 hours preoperatively as compared to 12 hours in terms of decreased VAS score, delayed time to first rescue analgesia, decreased total number and doses of analgesic with superior quality of recovery score. These are my references. Thank you.
Dr.
Good morning,
Amal,
sir. Good morning, ma'am.
so how much concentration you use the buprenorphine patch?
Sir, I've used 10 milligram patch.
Is it in milligram? Are you sure?
Yes, sir. Releasing at the rate of 10 microgram per hour.
Okay.
Yes, sir.
And what are the other strengths of the buprenorphine patches?
Sir, from 5 to 75 milligram, but actually, sir, we should use only up to 20 milligram because higher doses can lead to adverse effects like respiratory depression and it gives a ceiling effect.
Okay, and you have not mentioned any case of the urinary retention with the buprenorphine in your study? Was there no incidence of buprenorphine 10 mic as a significant cause of the urinary retention? Your patient did not have the urinary retention?
Sir, in my 66 patients, none of the patient had urinary retention. They had other side effects like minimal nausea, a slight headache, and pruritus at the site of the patch application.
Apart from that, patients are usually sedated with the 10 microgram.
Yes, sir. Mild sedation were there. Ramsey sedation score was mildly higher post extubation as we had applied the patch preoperatively. But it was higher, the sedation level was higher in the patch which was applied before 24 hours rather than.
Okay. And when did you stop your epidural infusion?
Sir, I stopped my epidural infusion at 72 hours.
But you give the additive effect of the epidural plus buprenorphine patch to all your patients.
Sir, I have given only, as an analgesic, I have given only, I've started epidural infusion by bupivacaine 0.125%, and I have not given any other analgesics other than that. Only patch and epidural infusion.
Okay, fine.
Anand, what would have been done if patient develops fever post-operatively with the patch?
Ma'am, in that case, I would have given paracetamol, ma'am.
No,
Because
what would have been
I've,
done with
I've
your patch which you applied to the patient?
Do you
ma'am,
use the patch
then
with
it would
fever?
be excluded from the study, ma'am.
Did you?
Ma'am, then it would be excluded from the study, but ma'am,
Why
patient
do you
comfort
exclude
would
from the
be,
study? Why do you exclude from the study? Abdominal
because
surgery
ma'am,
fever is very common post-operatively. What would have been done with the patch if patient develops temperature?
ma'am, in that case, my study criteria would not be met because paracetamol I would have given, and in my study I did not use any other analgesics or any other opioids other than buprenorphine and local anesthetic, that is bupivacaine, which I've used. So, ma'am, in the case of VAS more than or equal to 4 or in other side effects, I would have given a paracetamol because keeping in concern the patient's comfort. But ma'am, then I would not have included in my study that.
See, Anand,
remove the patch, ma'am. Hanji, ma'am.
if any patient develops fever, you should remove the patch immediately. That is the answer.
Yes, ma'am.
Why?
Yes, ma'am.
Why?
Yes, ma'am.
Why?
Yes, ma'am.
Why?
Why?
Because ma'am, it can also lead to patch can also lead to allergic reactions in pruritus, so it can increase the.
No, patch will release more than 10 to 20 mics. It's indefinite release of drug during temperature. That's why. Yeah, that is the answer. Okay, all the best. It's okay. Good.
Thank you, ma'am. Thank you.
Next, please.
Greetings. My topic for presentation is a preliminary study of ozone therapy on blood sugar levels in COVID-19 patients. Till date, there is no definitive treatment for COVID-19 viral infection, where many treatment modalities like antivirals, corticosteroids, oxygen supplementation, and plasma therapy are being used for managing the symptoms. Common side effects of corticosteroids varies widely with fluid retention, changes in glucose tolerance, behavioral and mood alterations, weight gain, etc. Due to lack of definitive treatment for management of COVID-19, there have been a lot of interest in exploring the role of adjuvant therapies along with the complement mainstream care. Medical ozone is one such complementary therapy used as adjuvant to standard treatment protocol because of its immunomodulatory and antioxidant effect on humans. Stress hyperglycemia is common in critically ill patients and appears to be marker of disease severity, where the use of ozone was started in medical community in mid 19th century, and very few studies are available to know the effect of ozone on glycemic levels. Hence, this preliminary study was conducted. Aim is to know the effect of rectal insufflation of therapeutic dose of ozone on glycemic levels in insulin and insulin requirement in non-diabetic patients on steroid therapy. A prospective experimental case control study was conducted at Adi Chinchandgiri Institute of Medical Sciences, Vijayanagar, after obtaining the institutional ethical committee clearance. The study included 20 participants with moderate to severe COVID-19 pneumonia admitted in our hospital with RT-PCR positive and for SARS-CoV. Initial evaluation, the objectives of treatment, procedure, indications and contraindications were explained to the patients and legal representatives, and informed consent is taken before the treatment. Inclusion criteria were men and women between ages 18 and 80 with positive RT-PCR status with moderate to severe pneumonia and hospitalized due to severe respiratory symptoms and who are willing to participate in this trial.
Exclusion criteria includes pregnancy, G6PD deficiency, patients in other clinical studies, and not willing to participate. Procedure, the patients were placed in supine position or lateral decubitus position with lower limbs flexed based on patient's condition. 250 ml silicone syringes of ozone were loaded with corresponding concentration of 35 micrograms per ml and were slowly injected rectally through 14 French rectal probe after lubricating with medical gel. Ozone was prepared by using the ozone generator, which is connected to anesthesia workstation from where oxygen is obtained. Insufflation time, the rate of insufflation was 1 ml per second, and after 5 sessions of ozone protocol, final evaluation was performed among GRBS levels. The same analysis was performed among Group A patients during the follow-up period. After obtaining the data and statistical analysis, these are my results, which shows there is significant reduction in the insulin requirement among the patients receiving rectal ozone. Ozone is a strong oxidizing agent and a molecule with high reactivity and is unstable form of oxygen. Various infections like autoimmune and degenerative diseases are treated by ozone, it being immunomodulatory, anti-inflammatory, and analgesic agent. The two components called ozone messengers, which are reactive oxygen species and lipid oxidation products, are responsible for biological and therapeutic properties of ozone. The endothelial dysfunction linked to hyperglycemia is associated with reduced production of nitric oxide, which is seen in oxidative stress, which is aggravated in COVID-19 pneumonia patients who are on steroid therapy. There are similar other studies showing the better glycemic control with ozone treatment. Conclusion: hyperglycemia and its immediate biochemical sequelae have been shown to directly affect endothelial function. Further studies are required to validate the study. As our study shows, there is decrease in the insulin requirement among those patients who received ozone therapy along with standard treatment protocol. These are my references.
Ma'am, please.
Who's this? Rohi, really we appreciate that you have used ozone rectal, but do you think that a patient COVID pneumonia in ICU, you are applying rectal ozone? Is it safe for the ICU other patients and you and the staff who are working here? We would have been increased insulin doses. No, what is there? We most of the times taper the steroids. What do you think? Is it safe for you and other environment of ICU and staff? How it's safe?
Ma'am, this ozone was used in very low doses, ma'am. Within the therapeutic range, as it has wide therapeutic range. And it was used only in COVID ICU, which is dedicated to only COVID patients, and all the medical staff were in PPE kits. And it was only 35 micrograms per milliliter, ma'am, which is 3.5 mg per liter, which is within the range of therapeutic dose. And it doesn't cause any skin irritations or anything when touched accidentally on the hand also. So it was initially tried to see the inflammatory response in COVID pneumonia patients. But we found that there is decrease in the blood sugar levels also. So we conducted a preliminary trial with a very small patient group to know if its effects on blood sugar levels also.
So what I meant is keeping the position and contaminating with such conditions. If you wear PP also, is it really safe? And is it really helps? And with the means, whenever you want to get a proper results, the sample size should be very adequate. With the small study, you cannot say. But okay, during postgraduate period, you have done good. Okay.
Yes, ma'am.
Okay, thank you.
Rohit, one more question.
Yes, sir.
Did you observe the long-term side effect with the ozone? Because ozone is a free radical producer. So did you follow it for the long time for any other?
No, sir. All these patients will be discharged like we have taken moderate cases. Most of the patients in the study group were of moderate.
What I'm asking, did you follow them at your home? Did you have a telephonic conversation for any side effect they had later on with the ozone?
No, sir. No, sir. Okay. We could not follow it up.
You should have added in your follow-up.
Okay, sir.
Okay. Thank you, sir.
Next one, please.
Very good morning to all. The title of my paper is a randomized controlled study of low-dose intravenous ketamine infusion, that is 0.2 milligram per kg per hour for post-operative analgesia in upper abdominal surgeries. As a part of an effort to develop opioid-free pain therapy, renewed interest is being focused on use of ketamine. By using ketamine, we can reduce the opioid consumption and also its side effects like hyperalgesia, constipation, and respiratory center depression. Though the analgesic effect of ketamine has been extensively studied, its optimal dosing and duration of administration still remains unclear. And hence, we took up this study to demonstrate that ketamine at a dose of 0.2 milligram per kg per hour is adequate enough to decrease pain and at the same time low enough to avoid its side effects. Our aim was to study the effectiveness of low-dose infusion, that is 0.2 milligram per kg per hour for postoperative analgesia in patients undergoing upper abdominal surgery under general anesthesia. The primary objective was to evaluate the efficacy of low-dose ketamine infusion in reducing postoperative pain, whereas the secondary objective to see if this infusion can also reduce the total dose of opioid analgesics required. The sample size was calculated to be 90. And after obtaining approval from the Institutional Ethics Committee, patients with age between 18 years to 70 years of ASA physical status 1 and 2 undergoing any upper abdominal surgery under general anesthesia were included and randomly categorized into two groups of 45 patients each. Group 1, the postoperative analgesics were administered as prescribed by the surgeon, which was IV tramadol 100 mg TDS, whereas in Group 2, IV bolus of 0.2 mg per kg of ketamine was given at the time of induction, followed by an infusion of 0.2 mg per kg per hour of ketamine given 48 hours post-operatively. Both the groups were observed on a VAS score at 4, 6, 12, 24, and 48 hours. The total dose of opioid, it being tramadol, consumed in both groups were noted. In Group 2, the patient's request for first dose of analgesia was also noted, and any side effect to ketamine was also recorded. All of this was done for a period of 48 hours. The groups were similar in age, sex, and type of surgery. The VAS scores were significantly lesser in Group 2, in which ketamine infusion was given, when compared to Group 1. Whereas the mean dose of opioid, that is tramadol, consumed was also considerably lesser in Group 2 when compared to Group 1. Out of the 45 patients to whom ketamine infusion was administered, 2 of them had double vision and 5 had nystagmus. Any noxious stimuli can cause central sensitization, which results in transition of the acute time-limited pain into chronic pathological pain. Though opioids also act on NMDA receptors, it only delays the process, unlike ketamine, which completely abolishes it. Himmelshire and Durex proved that an intraoperative bolus of ketamine should be followed by prolonged infusion or serious boluses of ketamine in order to maintain the plasma levels. Stubborg et al. Proved that clinically insignificant accumulation of ketamine and non-ketamine occurs after 72 hours infusion. McNichol et al. Proved that ketamine group had reduction in risk of persistent post-surgical pain, whereas Laskowski proved that in pediatric patients, it did not aid in reducing the post-operative opioid consumption. Therefore, it can be concluded that a post-operative ketamine infusion of dose 0.2 mg per kg per hour for 48 hours provided good analgesia by improving pain scores and significantly reduced the dose of opioid consumed with only minimal physiological impact. These are my references. Thank you.
Dr. Nishita, I have one question with you. Hello there. Dr. Nishita there.
I think she's not there, sir.
Tag team, please move to the next one.
Respected judges, teachers, and my dear friends, myself, Dr. Parvati from Baroda Medical College, and my topic of presentation is perioperative management of patients with post-COVID rhino-orbitocerebral mucormycosis, a prospective observational study. Mucormycosis is a life-threatening, locally invasive, rapidly progressive opportunistic fungal infection. It affects both immunocompromised and immunocompetent patients
and also most recently seen in COVID-19 patients. If surgical intervention is needed, it is a challenging task for anesthetists as it can lead to difficult mask ventilation and intubation due to fungal debris and supraglottic edema. Primary objective of our study was to report our experience with perioperative anesthetic management as well as post-operative outcome in patients undergoing surgical intervention for mucormycosis at our center. Secondary objectives include to study the relation of mucormycosis with comorbidities, intubation difficulties, post-anesthesia recovery status, and perioperative complications. Coming to materials and methods, it was a prospective observational study done in mucormycosis ward of SSC Hospital, which started from June 2021 and 160 cases were enrolled. Ethical clearance and CTRA registration number were obtained. Inclusion criteria were patients with previous history of COVID with confirmed diagnosis of rhino-orbitocerebral mucormycosis on biopsy and requiring surgical intervention from 18 to 70 years of age of both gender, and ASA criteria 2, 3, and 4 were included. Coming to methodology, pre-anesthetic evaluation and preoperative optimization of patients were done, written and informed consent were taken, trolley preparation was checked, and all baseline parameters were noted. Pre-medication was given with injection ondansetron, glycopyrrolate, pantoprazole, fentanyl, paracetamol, and magnesium sulfate according to dosage. Induction was done with injection propofol after pre-oxygenation, and after check ventilation, injection choline or atracurium was given according to patient's need. Patients were intubated with conventional laryngoscope, or if any difficulty in intubation was anticipated, video laryngoscopic or bogie-guided intubation was done. After intubation, patients were kept on pressure-controlled mode of ventilation. Maintenance was given with a mixture of oxygen and air and inhalational agent, either desflurane or sevoflurane. Reversal was given with injection neostigmine and glycopyrrolate according to dosage. Statistical analysis was done with Met-Calci statistical software. These are the results. Coming to demographic data, these are the demographic data of our study. In our study, 10% of the patients required video laryngoscope for intubation and bogie-guided intubation was done in 3% of the cases. Delayed recovery was observed in 9% of the cases. Desaturation, oropharyngeal trauma, arrhythmia, delayed recovery were observed in 15, 5, 10, and 6 patients respectively. Coming to discussion, in our study, we have noticed high association of mucormycosis in diabetes patient, which may be due to innate ketone reductase system present in this organism, which helps them to thrive in high glucose condition. In few patients, we face difficulty in mask ventilation and intubation because of facial swelling and trauma due to NIV mask or epiglottitis, airway edema, restricted mouth opening, and diabetes-induced joint stiffness were there. As patient had history of COVID-19, diabetes, administration of amphotericin B and corticosteroids, there were multiple systemic side effects like renal dysfunction, post-COVID adrenal suppression, myocardial dysfunction, and electrolyte disturbances, which led to perioperative hypotension, arrhythmia, desaturation, oropharyngeal trauma, and delayed recovery. Coming to conclusion, patients with diabetes had higher chance of developing rhino-orbitocerebral mucormycosis, and the possibility of difficult intubation, delayed recovery, and ICU admission were found to be higher among these patients. These are my references. Thank you.
Parvati, are you there?
Yes, ma'am.
Parvati, what do you think? Mucormycosis was only for diabetes. How many cases did you do in your center?
Ma'am, 160 cases, ma'am.
Among them, how many were diabetics and how many were non-diabetics?
Most of the patients, most of the comorbidity was found to be diabetic, but there were also other comorbidities associated with it, like hypertension, IHD, all kind of comorbidities were there. But the most common comorbidities seen with mucormycosis was diabetes in my study, ma'am.
See, so many young people during second phase got mucormycosis.
Yes, ma'am.
What was the reason for that? Exactly.
Mostly it was because of more usage of steroids, I think. During cytokine storm, we used more steroids like prednisolone and dexamethasone, which can lead to diabetes later on. And then some studies have shown that more usage of oxygen can also lead to mucormycosis.
Okay, one more question. Where did you find more people who were on home isolation or who were admitted in the ICUs, mucormycosis according to statistics?
Ma'am, it was actually found to be more in patients who were admitted to hospital, but there were many patients who were mostly in home isolation also. But in our study, it was found that more of the mucormycosis cases were seen in ICU admitted patients, ma'am.
Sir, you can proceed.
Okay, I have a question, Parvati. Do you think a mucormycosis has an impact on the anesthesia?
Sir, sorry, sir.
Does it have any impact on the anesthesia plan?
Does it has
Mucormycosis has any impact on the anesthesia plan?
Sir, planning?
Anesthesia management, intraoperative anesthesia management, is it affected by the mucormycosis?
Yes, sir. Actually, in case of rhino-orbitomycormycosis, we saw airway edema mostly in some of the patients, and because of airway edema, the intubation difficulties were faced. Some of the patients have like we used either boogie guided or video laryngoscopic intubation. So,
any impact on the recovery?
Recovery, sir. Most of the patients actually recovered very fast, and around 9 patients required ventilatory support, sir. 9% of the patients.
Reason being?
Sir, mostly
invasive mucormycosis or your something different?
So mostly those patients were actually went on to ventilatory support, had very much complications pre-operatively.
Okay, fine. Thank you.
Thank you, sir.
Next, please.
Study was on ultrasonographic diaphragmatic parameters as predictors of extubation outcomes in mechanically ventilated adult patients. The process of discontinuing or weaning remains one of the challenging steps throughout the period of mechanical ventilation. Diaphragmatic dysfunction as a result of disuse atrophy is commonly seen in mechanically ventilated patients and may be a cause of weaning failure. Commonly used weaning parameters are as follows. Rapid shallow breathing index or RSBI has been acknowledged as one of the most important predictors of weaning failure. Sonographic evaluation of lungs and diaphragm has gained popularity in the intensive care unit. Various studies have been conducted to assess the role of diaphragmatic parameters in predicting prolonged weaning and extubation outcomes. The following parameters have been most widely described: diaphragmatic excursion, diaphragmatic thickening fraction, and diaphragmatic contraction velocity. The primary objective of our study was to evaluate RSBI and the ultrasonographic parameters as predictors of weaning and extubation outcomes in mechanically ventilated patients. We tried to compare these parameters with each other and with RSBI in order to identify the most suitable parameter to predict extubation outcomes. We tried to establish a relationship between the number of ventilator days and ultrasonographic diaphragmatic parameters. Ours was a prospective observational study conducted on the patients admitted in the intensive care units of JSS Hospital. Sample size was estimated to be a minimum of 73. The inclusion and exclusion criteria were as follows. Patients on mechanical ventilator support for a period of greater than 24 hours were assessed by the Apache 2 score. The decision to wean patients from ventilator support was taken by the critical care physician, and patients were put on a spontaneous breathing trial. The criteria for SBT and the ventilator parameters of SBT were predetermined. Right hemidiaphragmatic parameters were measured by the primary investigator 30 minutes into the 2-hour SBT. RSBI was also calculated at this point of time. The critical care physician was blinded to these measurements. The criteria for failure of SBT was predetermined. All patients who successfully passed the SBT were extubated and followed up for a period of 48 hours. Extubation failure was defined as patients who required reintubation or non-invasive ventilatory support within 48 hours of extubation. Based on the above observations, patients were divided into 2 groups. Success group comprising of patients who were successfully weaned off ventilator support. The failure group comprising of patients who do not pass SBT or pass SBT but require NIV support or reintubation within 48 hours of extubation. Statistical analysis was done using standard tests. 19.7% of the study population were in the failure group. The mean age of the failure group was higher. The ratio of females failing extubation or weaning was higher. RSBI was the best predictor of extubation outcomes. of the diaphragmatic parameters, it was seen that the mean diaphragmatic parameters was much lower in the failure group. Of the diaphragmatic parameters, diaphragmatic contraction velocity was the best predictor of extubation outcomes. Diaphragmatic excursion was the poorest indicator of extubation outcomes. There was a significant negative correlation between the duration of ventilation and the diaphragmatic parameters. Weaning indices are critical in providing an objective marker to free a patient from mechanical ventilation. They serve as a valuable tool to the novice physician. Our study found that merely measuring the extent of diaphragmatic motion or diaphragmatic excursion was not adequate in predicting extubation failure. A combination of diaphragmatic excursion and contraction time measured by DCV was the best predictor of extubation outcomes. RSBI continues to be the foremost indicator of extubation outcomes, but diaphragmatic contraction velocity can serve as a valuable adjunct to RSBI in predicting extubation outcomes. Thank you.
Hello, are you there?
Yes, ma'am. Good morning,
Doctor, are you there?
Good morning, ma'am. Yes, ma'am.
Morning. How did you plan for that DCV?
DCB is measured as diaphragm. Ma'am?
Yeah. How did you plan and how did you do it?
First, we measured diaphragmatic excursion, ma'am. In the M-mode ultrasonography of the diaphragm, when we measure excursion on the y-axis, the x-axis will give us the contraction time. So it's basically the formula of velocity, ma'am, displacement by time. So DCV will be diaphragmatic excursion by contraction time.
Okay. Are you trained?
Ma'am?
Are you trained to do it?
Ma'am, training means no, as such, like I learned ultrasound diaphragm and ultrasonography of the lung, we routinely learn it, ma'am, in the intensivist teachers in the ICU. Formal training with some recognition is not there as such. But I am the primary investigator. I have done all the ultrasound.
Okay. What do you think? See, people who does not have ultrasound and they didn't get trained up, which is better? Really, do you think that RSBI is better than DCV or DCV is better than RSBI?
Ma'am, DCV
Being
requires
a student of
DCV requires an ultrasound to do it, ma'am. But if you do not have an ultrasound, then since 1991, RSBI and crop index, ma'am, two indices can be used to predict weaning outcomes, ma'am. Those are clinically, ma'am. Yes.
Okay. Sir, you asked.
No, thanks. Most of the things, ma'am, you have asked already.
Okay.
Okay. The next one, please.
Hello everyone, this is Dr. Tulika Vinayak presenting e-poster on topic baseline pulse oximeter perfusion index as a predictor of intraoperative hypotension in parturients undergoing spinal anesthesia for cesarean sections. Elective LSCS is commonly performed under spinal anesthesia as it has advantage over general anesthesia, but it can cause hypotension due to sympathetic blockade, which may be deleterious to parturients. An ability to identify those who would suffer from hypotension will help the clinicians to prevent it. Perfusion index is one such non-invasive method that can be used. In our study, we have used a cutoff of 3.5 based on the study done by Toyama et al. Perfusion index is defined as the ratio of pulsatile blood flow to the non-pulsatile blood flow in the peripheral vascular tissue that is measured using a pulse oximeter on the amount of the infrared light absorbed. And one such pulse oximeter is Massimo MightySat RX finger pulse oximeter that is used in this study. The aim of our study is to evaluate the baseline perfusion index of greater than 3.5 as a predictor of intraoperative hypotension following the spinal anesthesia in LSCS, with primary objective to predict the number of parturients developing decrease in the systolic BP of greater than 20% of the baseline value. Secondary objective being the total amount as well as the frequency of heparin administered, as well as the APGAR score of the neonate at 1 and 5 minutes. Inclusion as well as the exclusion criteria are as follows. Sample size was calculated using this formula and 28 subjects per group were allowed. Considering the dropout, we took 30 parturients in each group. After the informed consent, the baseline perfusion index was calculated in supine position with the wedge under the right buttock to prevent the aortocavir compression, and the pulse oximeter was placed on the left index finger of all parturients to ensure the uniformity based on the baseline perfusion index group 1 with less than 3.5 baseline perfusion index, and the group 2 was divided based on the pulse perfusion index being greater than 3.5. Spinal anesthesia was administered with 25 gauge Quincke spinal needle and 10 mg of bupivacaine, 0.5% hyperbaric at L3 L4 interspace, following which the hypotension was noted as decrease in the SBP greater than 20% of the baseline or 90 mm of Hg, and was treated with intravenous bolus of ephedrine 6 mg. The number of incidences of hypotension and total amount of ephedrine required were noted, as well as the APGAR scoring at 1 and 5 minutes was noted. This is the concert flow chart. Statistical analysis was done using the SPSS22 version. The results showed the mean perfusion index in group 1 being 2.24, while in group 2 being 6.73, with more episodes of hypotension in group 2 compared to group 1 and more use of ephedrine in group 2 as compared to group 1. Thus, the mean total amount of ephedrine used in group 1 was 2.4 mg, while in group 2 was 12.6 mg. No statistical significant outwards was there recording the mean APGAR scoring. In this prospective comparative study, we demonstrated that the higher baseline perfusion index was associated with higher incidence of hypotension and larger doses of ephedrine administration, which was similar to the findings of the study done by Toyama et al. And perfusion index potentially can be used as a non-invasive useful monitor for early prediction of hypotension in LSCs under spinal anesthesia and treating promptly to avoid undesirable effects on the fetus, as shown by Prasad et al., Dugappa et al., as well as Toyama et al. Higher baseline perfusion index is associated with higher incidence of hypotension following spinal anesthesia in parturients undergoing LSCs. Hence, in conclusion, perfusion index can be used as a tool in predicting the intraoperative hypotension in parturients undergoing elective LSCs and help in preventing it. These are the references.
Dr. Tolika there?
Yes, sir. Good morning, sir.
Good morning. Ma'am, I have a question. What all the factors may affect the perfusion index?
Sir, actually, the sympathetic activity is the main thing that we are trying to measure from the perfusion index. So more the sympathetic activity, more will be the perfusion index. But along with that, perfusion index is basically arterial pulsatile activity, sir. So, but infrared rays is being used in that. So slight effect can be there because of the light transmission, but because mainly depends upon the pulsatile activity. So these factors we have seen according to the Massimo being so specific to it, that they have tried to come down with these nail paint or any color.
But the pulse oximeter you show, ma'am, was not Massimo compatible, if I am not wrong.
Sir, we have used Massimo. In the slide, it was Massimo fingertip RX. We bought that, sir. Specifically for the study.
Okay, fine.
Yes, sir. So it is very specific, sir. It has a very high specificity for this, and it reduces all the nail paint or any other color on the henna or anything.
Okay, fine. Please.
Hello, Tulika.
Good morning, ma'am.
See, other than Massimo, which monitor gives good perfusion index? All monitors does not give. Do you think
all monitors?
Yeah.
So, ma'am, actually,
Massimo is very difficult. Everybody in different institution to get Massimo. And what do you think? Other than that, which is better?
Ma'am, in our hospital, we have seen perfusion index being measured only on Philips monitor. And any other monitor doesn't even show perfusion index as the parameter.
Yes.
But ma'am, we have seen that. But we have seen a lot of variation, ma'am. Once we were using Massimo and Philips, we saw that Philips is not that specific, ma'am.
That's what. Yeah, you can measure perfusion index only with Massimo, not other than other.
Yes, ma'am.
Okay.
Thank you, ma'am.
Thank you. Okay, thank you. Sir, do you have any other, sir, Lalit sir? I
No,
think,
I don't think so. The thing list is complete. The tag team can tell.
yeah, oh, yes. Okay.
We have
Hello?
done the 16 years.
Hello, sir. Hello.
Hello.
Yes, yes. Yes.
Yes, you are audible.
Hello.
Hello, you are audible.
I'm Dr. Archana, sir.
Yeah, Archana.
Yes.
Sir,
You
actually,
didn't
I
attend
missed
the
my
first.
session. Yes, ma'am. Please, ma'am, if you can
You are
play. Now I'm there.
second member. Yeah. You are allowed to ask the questions.
Yes, ma'am.
Yours was labor analysis, no?
Yes, ma'am.
Fentanyl and buprenorphine was fentanyl and buprenorphine with fentanyl.
Yes, sir. Yes, sir.
Okay. So I had a question for you at that time. The ropine that you used was is isobaric or hyperbaric?
So isobaric, sir.
Okay. So did you find any difference in the motor?
So a motor blockade, no, sir, we have used very low concentration, sir, diluted the 0.125%, sir. There was no
Okay.
motor blockade, sir.
Okay, fine.
Sir, can I play
Sir,
video
when
again?
did you start exactly?
Ma'am?
When did you start your
Hello?
labor analysis exactly? When did you
Ma'am,
start your labor analysis?
The exact time of
ma'am,
using
actually,
this.
when there was yes, sir. When there was 3 centimeter dilatation, ma'am, then we started it, ma'am.
Okay.
Okay.
How did you get 1.125% of propivacane?
We used 0.75% concentration, ma'am.
Yeah. How did you get it? How
1:6, ma'am. Ma'am, 1:6. 1, and if we take 2 ml, it becomes 12. We have to make it 12 ml, ma'am. Or if we take 1 ml, we have to make it 6 ml. 1 ml of propivacane or 5 ml of this, or 2 ml of propivacane, make it into 12 ml plus 2 micrograms per ml of fentanyl, ma'am. Hello, ma'am.
Do you get exactly 0.125 you mix like that?
With that concentration we get, ma'am.
Do you get exactly 0.125? Exactly 0.125. Sir, what do you think?
I'm really surprised.
It's to get
Yes,
0.125 from 0.15 is
6 times, ma'am.
It's easy, sir. 0.5 of bupivacaine, but 0.125 from 0.7 little difference. It's okay. Okay. Thank you.
Yes, ma'am.
Thank you.
Thank you, ma'am. Thank you, sir. Thank you so much, sir, for asking me. Thank you, sir.
Anyone else? Is there any other candidate? Tag team?
Sir, what to do? To wait or to
I am
wait?
waiting for the tag team for any response.
Yeah, that's
Seems
what.
like they are busy takes next.
Yes. Sir.
Anyone from the tag team there?
Yes, sir. Yes, sir.
Yeah. Is there anyone else?
No, sir.
Okay.
Shall we end the session?
Yes, ma'am.
Okay, fine.
Sir, thank you.
Thank you, ma'am. Thank you. Thank you, Isacon.
Sir, happy to
Yeah.
share with you sessions.
Yeah, anyone from the tech team?
Hello.
Hello.
Yes, sir.
Yeah. Should we end the session?
Yes, sir. Yes, sir. Fine.
Okay, fine. Fine.
Okay. Thank you all,
Thank
sir.
you.
Thank
you, ma'am.
Thank you, sir.
Now we are going to start our next session, Jaipur Award pain presentation, acute pain or perioperative pain. I would like to invite judges Dr. Kamla Mehta, Dr. Suresh Chandra Dulara, and Dr. Chintalal Kishan.
Can I play the video?
Good afternoon, respected all. Myself, Dr. Dipanshu Dung from All India Institute of Medical Sciences, Jodhpur, am here to present our study titled Comparison of Human Cadaver and Blue Phantom for Teaching Ultrasound-Guided Regional Anesthesia to Novice Postgraduate Students of Anesthesiology, a randomized controlled trial. My co-authors are Dr. Manoj Kamal, Dr. Mrityunjay Kumar, Dr. Pradeep Bhatia, and Dr. Bharat Paliwal from AIIMS, Jodhpur. With the advent of ultrasonography in the armamentarium of anesthesiologists, regional blocks are performed more precisely. Simulation-based ultrasound-guided regional anesthesia training helps a novice gain motor skills, correct errors, and allows time to develop expertise before performing regional nerve blocks on the patients. In the past, various types of phantom models like water, tofu, gelatin, elastomeric rubber, blue phantom, and human cadavers have been used. But till date, no study is available that compared human cadaver and blue phantom for training of ultrasound-guided regional anesthesia. Hence, present study was intended to compare human cadaver and blue phantom model for training of regional anesthesia to novice postgraduate students of anesthesiology. Hypothesis of our study was human cadaver model and blue phantom model are equally effective for training of ultrasound-guided regional anesthesia to novice postgraduate students of anesthesiology. The study aimed to compare the efficiency of human cadaver with blue phantom for teaching ultrasound-guided regional anesthesia to novice postgraduate students. Primary objective of our study was to compare the block performance time. Secondary objectives were image acquisition quality, transducer orientation to target, identification of ultrasound artifacts, errors related to the procedure, complications, and success rate of the procedure. Our study was done with Institutional Ethics Committee approval, CTRI registration was done for the same, and informed consent was taken from all the study participants. It was a single center randomized control study done at AIIMS Jodhpur from August 2019 to March 2021. And novice first year postgraduate students were included in the study. A 20 minutes didactic video lecture on ultrasound knobology and transducer movement was shown to all study participants. 50 novices were recruited and randomized into two equal groups of 25 each by computer-generated random table. Allocation concealment was done using sealed opaque envelope method. Group Blue Phantom was trained on Blue Phantom to hit the target, and Group Cadaver Phantom was trained on fresh human cadavers at the wrist to hit the median nerve. Expert feedback was given after each attempt during training. All the participants were given a maximum of 30 attempts to practice on their allocated training phantom model. After training on the phantom model, a video demonstrating sonoanatomy of the supraclavicular area and inline short axis technique of the supraclavicular brachial plexus block was shown to all the study participants. The participants were finally assessed on patients undergoing upper limb surgeries under supraclavicular brachial plexus block. Our sample size calculation was based on a previous study by Chuan et al. Using the estimated mean block performance time in the two groups with a power of 90% and two-tail significance level of 0.05. Sample size was found to be 23 in each group, and we included 25 participants in each group to cover for any contingency. Statistical analysis was done using SPSS version 20. Quantitative data was analyzed by independent t-test and man-Whitney u-test, and qualitative data was analyzed using chi-square test and Fisher's exact test. P-value of less than 0.05 was considered significant. Coming to the results, the mean block performance time was found to be less in the cadaver phantom group compared to the blue phantom group, and this difference was statistically significant. The median image quality score was found to be 3 in both the groups, with an interquartile range of 2 to 3 in group blue phantom and 3 to 4 in group cadaver phantom, and this difference was statistically significant. The median number of needle passes were found to be 2 in both the groups, with an interquartile range of 2 to 2.5 in group blue phantom and 1 to 2 in the cadaver phantom, and this difference was also statistically significant. This figure represents on the x-axis are the groups coded, the cadaver and the blue phantom, and on the y-axis is the mean procedure time. Coming to transducer orientation to target, it was found to be higher in the cadaver phantom group compared to the blue phantom group, and this difference was statistically significant. And among the USG artifacts, acoustic shadowing and reverberation artifact were found to be higher in the cadaver phantom group compared to the blue phantom group, and this difference was statistically significant. In the discussion, Chuan et al. Compared meat-based model with human cadaver for teaching ultrasound-guided regional anesthesia, and they observed time taken to perform sciatic nerve block was comparable in both the groups. Organic phantom model was used in this study. Inorganic material blue phantom model used in our study can be used to teach procedural techniques, dexterity, target structure identification, and needle visibility, but they often lack a true tactile feeling and haptic feedback, as well as the inability to inject liquid solutions into them. In contrast, the organic phantom models like cadaver arguably produce a more realistic sonoanatomy and tactile sensation, and also allow for injection of solutions. Cadavers are more easily accessible and closely replicate the clinical experience. In our study, we observed that the time taken to perform supraclavicular brachial plexus block was less in cadaver phantom group compared to the blue phantom group, and it was statistically significant. Hence, we conclude that the human cadavers offer a better training model in terms of less block performance time and number of needle passes, with a better quality of image and transducer orientation to target compared to blue phantom model. And training on both these models proved to be effective in reducing the complications and are highly successful for performing supraclavicular brachial plexus block for upper limb surgeries. These are my references. Thank you.
Okay. What is your name, beta?
Good afternoon, sir. My name is Dr. Dipanshu Dung.
Dr. Dipanshu.
Yes, sir.
Dipanshu. So you use blue phantom and cadaver, no?
Yes, sir.
You mentioned median block performance time significantly different with both the groups.
Yes.
If you change the unit from second to minute, then what will be happen to your this statistical comparison?
Sir, if it is changed from second to minute, I don't think there would be a significant difference in comparison.
There will not be, because it comes to around 8 or 7 minutes in both the groups.
Yes, sir.
When we change it to the seconds, it becomes like 400 or 500. It means the difference of 100. But otherwise, it's not a much difference.
Yes, sir.
So it's only a numerical difference, we can say, when we use the unit of seconds.
Yes, sir.
But when we use the unit in the minutes, it is not a matter of concern of the time. And to teach the technique, how do they, the novice, you got the use novice anesthesia residents, no?
Yeah.
Novice means your first year residents?
Yes, sir. The newly admitted residents in the department.
how many residents are admitted in AIIMS Jodhpur per year?
Sir, in an year, around 16 candidates get admitted. Like every 6 months, there are 8 to 10 candidates.
My question is, we had 2 groups of 25 each.
Yes, sir.
Was there any difference between the these novice residents?
No, sir, there was no significant difference. While in our study, sir, the minor drawback was the aptitude of these novice residents was not considered. The previous learning aptitude.
Yes.
Yeah.
तो मेरी चीज को आप समझ गए हैं कि
Yes,
अपन को जो नोवाइस अपने जो फर्स्ट ईयर रेजिडेंट्स हैं,
yes,
उनका क्या एक्सेप्टेंस रहा, उन्होंने किस practiced on the cadaver or on the blue phantom, na?
Yes, sir.
You got it? But
yeah, yes.
ठीक है, तो we have to divert ourselves to this also, not only this, that patient group, because the practicing, who are the practicing, who are the participants in the study?
Residents.
When we talk about them, novice residents.
Yes, sir.
है ना? So who are the participant? Residents. We have to consider them. Some may take, आपके जैसे समझाते समझ गए, बिना कैडेवरी लगाए हमने तो, हमें तो कोई सिमुलेशन नहीं था बेटे.
Previous aptitude was not measured, sir. Yeah.
But we learned, है ना? तो learning एक अलग process है. तो उसकी स्टडी इसमें भी लेंगे आप.
Yeah, this we didn't include.
डिस्प्ले नहीं किया कि उनमें से कितने बच्चे जो 16 आए थे, उनमें से कितने बच्चे कितना जल्दी सीख पाए और किस पर जल्दी सीख पाए.
Yes, sir. So basically, according to the previous studies, a maximum number of attempts were given to each participant. Like the number of attempts were limited to 30, in which they attained around 80 to 90% of their proficiency in training, during training. In previous studies, it is mentioned, so the maximum number of attempts to be limited to 30 while training.
To each novice resident?
Yes, sir. To each novice resident, it was considered that in maximum 30 attempts, a novice is considered to be trained.
Then they are considered to be trained.
Yeah.
So, matlab, we trained all the novice, all 16.
Yes, sir. All of them.
All of them were trained. They were given chance for 30 times. Now.
Yeah. Yes.
Each and everyone was given 30 times.
Yes, sir.
On
their respective models.
Cadaver also.
Yeah, on their respective models.
On their respective models. So yes. It is the person who participants are residents.
Yes, sir.
Residents also. Okay? Please, madam.
Dr. Dipanshu.
Good morning, ma'am.
Good morning. Can you tell me the cost effectiveness of cadaver and blue phantom?
Ma'am, the cadavers are considered to be cost effective while because they are easily accessible in a setup of an institution because of an anatomy lab they have in a dissection hall. They are easily accessible while a blue phantom model costs around 85,000 plus GST. So it is more costly, ma'am, I consider it to be.
Okay, dear Dipanshu, thank you. Who is the next?
Thank you, sir. Thank you, ma'am.
Okay.
Thank you.
अरे कोई सीरियल लिस्ट भी है क्या? कौन कौन पार्टिसिपेंट्स हैं? चलो फिर हम देखते हैं.
Second participant कोई coordinator होगा?
ये आ गया ना? ये आ गई अनुष्का गायत्री 1071. Yeah.
Good morning, everyone. My topic is on the comparison of 3 different volumes of local anesthetic and incidence of hemidiaphragmatic paresis in ultrasound-guided interscalene brachial plexus block, a randomized controlled trial. Our study has been registered in Clinical Trial Registry of India. The incidence of transient hemidiaphragmatic paresis following the interscalene block is almost 100%, where the drug volume plays an indispensable role. It is asymptomatic in healthy population and deleterious and fatal in patients with pulmonary pathology. The diaphragmatic paresis has a major concern where more randomized controlled trials are needed to determine the performance of the block with lower volumes of local anesthetic doses. The primary objective is to compare the incidence of hemidiaphragmatic paresis using 3 different volumes of local anesthetics, and secondary objective is to compare the onset of sensory blockade, duration of postoperative analgesia, and adverse effects. The inclusion criteria was a patient aged between 18 to 60 years of ASA class 1 and class 2, weighing between 50 to 100 kg. Exclusion criteria being patients with pregnancy, drug allergy, patient refusal, coagulation disorder, pre-existing diaphragmatic paralysis, and patients with severe respiratory illnesses. Ours is a prospective randomized observer blinded study, and after getting informed written consent, 90 patients were randomly allocated into 3 equal groups by computer generated random numbers and sealed opaque envelope. An independent experienced anesthesiologist will prepare the study solution and administer the block using the ultrasound guidance and will no longer participate in the study. Group A patients received 10 ml of 0.75% ropivacaine. Group B received 15 ml of 0.75% ropivacaine, and Group C received 20 ml of 0.75% ropivacaine. 50 microgram dexmedetomidine as additive was common to all 3 groups. Anesthesia was standardized to all the patients, and all the evaluations, including the diaphragm excursion measurement, was performed by another blinded independent anesthesiologist. And before and 30 minutes after the block, the ipsilateral diaphragm movement was measured on deep inspiration by ultrasound using the curved array transducer, which will be placed inferior to costal margin, an anterior axial line on the left side and mid-clavicular line on the right side. An ultrasound beam is directed medially in cephalad to visualize the hemidiaphragm using the spleen or liver as acoustic window. Once the curved hyperechoic diaphragmatic line has been obtained, the M-mode ultrasound will determine the extent of diaphragm excursion with the patient on deep inspiration. More than 70% reduction in diaphragm excursion was taken as complete paralysis, 25 to 70% was taken as partial paralysis, and less than 25% was taken as mild paralysis. The sensory block was assessed for every 5 minutes till 30 minutes, and the onset of sensory block was taken as a time between the end of block procedures and the moment of reaching a score of 2. Failure to reach a score of 2 was considered as block failure. A post-operative monitoring was done for 24 hours, and the duration of post-operative analgesia was taken as the time from the administration of the block to the time for first request for post-operative analgesia. When the VAS is more than or equal to 4, tramadol 100 mg was given as rescue analgesic. And occurrence of adverse effects were also monitored. Sample size. Based on the study by Riazi et al. And taking into account 80% power and alpha error of 0.05, we obtained 27.16 as sample size. For statistical analysis and considering 10% of dropouts, we included 30 patients in each group. Statistical analysis was done using chi-square test and ANOVA test. The consort flow chart. Here, no patients was lost to follow-up throughout the study. Age distribution, gender distribution, weight, ASA classification, diagnosis and procedure, duration of surgery were all considered as statistically insignificant in our study. The diaphragm excursion percentage of reduction, the group A patients receiving 10 ml had more of less than 25% reduction in diaphragm excursion, and 20 ml group had more than 70% reduction in diaphragm excursion, and 15 ml group had more of 25 to 70% reduction in diaphragm excursion, and it was statistically significant. So less than 25% diaphragm paralysis was observed more with the 10 ml group compared to 10 and 15 ml group, where only minimally reduced diaphragm excursion was seen. And 25 to 70% group, it was more common with 10 and 15 ml group, and where here also only minimal reduction in diaphragm excursion was observed. More than 70% diaphragm paralysis was only observed in patients with 20 ml group, where the diaphragm excursion was nil, depicting a flat line in the ultrasound. The onset of sensory blockade was faster when 20 ml is given, and it was statistically significant. The duration of postoperative analgesia was statistically insignificant. However, the group C patients had more hours of postoperative analgesia comparing to group A and group B. The rescue analgesic consumption, it was less with the 20 ml group compared to the other two groups. However, it was statistically insignificant. The block success rate was 100% in all the three groups, and hemodynamics was stable throughout the procedure. And the 5 patients in group C had hoarseness of voice, which was managed conservatively. The VAS score was significant in the 24 hours, insignificant in the 24 hours post-operative period. And coming to the discussion, the quantity is not always synonymous with the quality. So this interscalene block is usually contraindicated in patients with pulmonary pathology. However, this low volume interscalene block can make the administration of GA as unnecessary. Ultrasound can minimize the needle trauma, and it has more sensitivity compared to pulmonary function test and saturation. Based on a study by Riazi et al., he used 0.5% ropivacaine, 5 and 20 ml, and he had the diaphragm excursion as significant, which is similar to our study. And the sensory onset was slow in low volume and fast in large volume group in both of our study. And total analgesic consumption and pain score was not significant in both of our study. And 8 patients receiving 20 ml had complications. However, we had 5 patients in 20 ml receiving complications. Zai et al., he used a fixed dose ropivacaine as 0.75% ropivacaine, 0.5 and 0.25% was taken into account, And he had the sensory onset time of 5 minutes using 0.75% ropivacaine, 6.7 ml. However, we had 7 minutes of 0.75% ropivacaine using 10 ml. Diaphragm paralysis, however, was insignificant in Zai et al. And it was significant in our study. Adverse effects, only one patient developed hoarseness of voice using 0.25% ropivacaine. We had 5 patients developing hoarseness of voice using 0.75% ropivacaine. The pain scores was insignificant in both of our studies. Limitations was the block was performed by an experienced anesthesiologist and the diaphragm paralysis was not confirmed with CT imaging, taking into account of cost factor. And coming to the conclusion, the low volume of local anesthetic when combined with ultrasound guidance can reduce incidence of hemidiaphragmatic paralysis without compromising the postoperative analgesia and success rate with stable hemodynamics, and this can be safely administered in patients with pulmonary pathology. These are my references.
What is your name?
Anusha Gayatri, sir.
Huh?
Good morning, sir. Good morning, sir. Anusha Gayatri, sir.
Aisha. Anusha.
Anusha Gayatri.
Anusha. You had comparison of the volumes, huh? 10 ml, 15 ml, 20 ml.
Yes, sir. Yes, sir.
And you had compared the hemidiaphragmatic paralysis.
Yes, sir.
There is
Yes.
rise in hemidiaphragmatic paralysis up to more than 75%.
Yes, sir.
Yes. क्या कर रही है? अरे दूसरा लगा लेकर आ ना बेटे. हेलो, आवाज आ रही है?
Yes. Yes, sir. Yes.
Here? हाँ. So if we increase the volume, there
Yes,
is more
sir.
diaphragmatic paralysis, है ना?
Yes, sir. Yes, sir. Because this more local when we are providing more amount of volume, this can go and can spread to the nerve roots above C5, and this can also compress the via anti-scalene sheath. This can cause phrenic nerve paralysis also, sir.
हेलो, हाँ बेटे, आवाज आ रही है? हेलो, अनुषा, can you hear?
Yes, sir.
हाँ.
Yes, sir. I mean.
Can you hear it?
The higher. Yes, sir. Yes, sir.
ये इवेंट वाले कमजोर हैं, इन्होंने आवाज भी इधर से उधर नहीं आने जाने दी. अच्छा सुन, मुझे बता कि when we increase the volume of the LA, there is more
Yes,
in
sir.
the hemidiaphragmatic paralysis, है ना?
Yes. Yes, sir.
Question is why? You told above
Because
C5
of-
level, na?
Yes, sir.
Above
And
C5 level.
yes, sir. Because it can also via the anterior scalene sheath, this can cause paralysis of the upper nerve roots, and there is a chance of sparing of the phrenic nerve also, sir.
Question is you use which block? कौन सा block?
Interscalene break. Interscalene break.
Interscalene brachial plexus block. Then why
Yes,
is there hemidiaphragmatic paralysis in interscalene block? Question is this one.
Yes, when large volumes are used, this can go and compress the other nerve roots also, and the drug volume plays a major role where it can affect the other nerve roots, and via the anterior scalene fascia, this can cause the phrenic nerve paralysis, sir.
Phrenic nerve. You have to come to the phrenic nerve, है ना?
Yes, sir.
Phrenic nerve
Yes.
किससे बनती है? How is it formed?
It is mainly formed from C4. Yes, it's mainly formed from C4 nerve root. It also gets contribution from C3 and C5, and this at the origin it lies medial to the anterior scalene muscle, and as it descends further, it comes it is first lateral and it comes medial to the anterior scalene muscle, and as it lies in close proximity to the anterior scalene muscle, this has a probability of getting spared when given interscalene block, sir.
So question is this one: when if we change the unit of this one onset, you had mentioned the p value very significant, less than 0.001. If we change the unit from this onset is 7 minutes, 6 minutes, 4 minutes, I doubt when HD
Yes,
is
sir.
0.72, it will not be highly significant. Which test you had used? Because
Why
huh?
we have used ANOVA test, sir.
ANOVA.
Yes.
What do you mean by ANOVA test? ANOVA test की inference क्या निकलती है इसमें? If we apply this ANOVA test in this, then what is the inference?
Here
Regarding onset of
when
time.
having yes, we are having if when comparing more than two groups, so we normally use the ANOVA test for categorizing and categorical data and continuous data. So since our main onset time we had a continuous data, so we use the ANOVA test, which is more than two groups we can apply, sir.
So what is the inference? You told p value less than 0.001. So what is the inference in these three groups?
So the inference is when given large volume, we could attain a sensory onset time a little faster when compared to the 10 and 15 ml groups, sir.
Listen to me, bete, Anusha. The inference is that all these two groups differ from each other. है ना? एक की वैल्यू है 7, एक की वैल्यू है 6, एक की वैल्यू है 4, है ना?
Yes, sir.
अगर इस 4 है ना तो
since there was the major difference from 10 ml they had around 7 minutes, and whereas in 20 ml they had some 4 minutes, so there was a huge difference and it was turned to be highly significant, sir.
From 7 to 4 minutes it comes to huge. No beta, no, it's not like this. They differ. Inference is this: they differ from each other. All three groups differ from each other. है ना? 7, 6 and 4. It's like this. It's not like this. है ना? समझ गए आगे से? But इसको रिवाइज करना, न्यूमेरिकली ऑल्सो हो सकता है कि ये सिग्निफिकेंट ना हो. प्लीज डॉक्टर कमला.
Dr. Anusha,
yes,
can you hear me? What is your sample size?
Yes, ma'am. Yes, ma'am.
What is your sample
Good morning,
size?
ma'am.
Good morning. What is your sample size?
Sample size was 30 in each group, ma'am. 30 patients in each group, ma'am.
How did you derive your sample size 90?
From previous study by the Riazi et al, we have taken their objective as duration of analgesia, and taking into account the mean and standard deviation in groups, we have derived the sample size using the formula of substituting more than two groups.
Next participant.
Who is next?
Thank you.
Thank you, Anusa. Please.
Thank you. Thank you, sir.
Hello everyone, my name is Dr. Revati Nair. I am from PGIMER Chandigarh. My topic is a randomized comparative evaluation of ultrasound guided classical versus parasacral parallel shift technique of sciatic nerve block combined with femoral nerve block as a sole anesthetic modality for orthopedic lower limb surgeries. My co-author is Dr. Tanveer Samra, who is also my PG guide. Conference registration number is PGV 1878. So, posterior approach to sciatic nerve block can be performed at 3 locations. From up below, it is parasacral, transgluteal, and subgluteal approach. Parasacral approach further can be divided into 2. First, described by Benary et al., which is the classical approach, in which the posterior border of ischium is used as a landmark and the nerve is visualized in the short axis. And the second is parasacral parallel shift approach, new approach described by Bernstein et al., in which ischium is identified and the nerve is visualized in the long axis. No study till date has compared the success of localization of the nerve with the two techniques. We hypothesize that the success of localization will be better with the PSPS technique because Bernstein et al. Claims that searching the target sacral plexus below the PSIS between sacrum and ischial bone may be this approach. It is easy to identify the iliac bone contour and work off the iliac bone with the ultrasound beam to identify target sacral plexus easily. The primary objective of the study was to compare the success of sciatic nerve block using classic and parasacral parallel shift approach. Successful block was defined when both motor and sensory block was established. Secondary objectives included time taken for performance of the block, time to sensory and time to motor blockade, time to first rescue analgesia, average pain at 6, 12, and 24 hours post-operatively, additional opioid, non-opioid supplementation, motor block regression time. The IEC and CTRI registration was obtained before starting the study. IEC registration and CTRI registration number are given above. Inclusion criteria included patients between 18 to 80 years of age undergoing traumatic orthopedic lower limb surgery of ASA 1 to 3. Exclusion was patient refusal for nerve block, allergy to amide local anesthetic, chronic opioid therapy, patients with thrombocytopenia or coagulopathy on anticoagulant thrombolytic therapy, morbid obesity, neurological distress, infections in the intervention site, and psychiatric illness. Two groups were allocated using computer generated random number table and using sealed envelope technique. First group was classical, second was PSPS. Blinding was achieved by doing the following. The anesthesiologist who performed the block was not involved. The anesthesiologist collecting the data was not aware of the technique, and patient was blinded to the technique selected. Sample size estimation. Previously, Dello et al. Was able to establish the gluteal artery visualization in 89% of their patients. Benston et al. Had described successful surgical anesthesia in all 7 of their patients by PSPS approach. So, using the 2 studies, we assume that the technique will have a 89 to 99% success rate. Clinical sample calculator was used, and 70 patients were to be included. Keeping in mind the dropout size, 72 patients were taken. With an 80% power and 0.05 alpha level. So this is the flow diagram. 155 patients were assessed for eligibility, and 11 were excluded for not meeting criteria, refusal to participate, difficulty with lateral positioning, morbid obesity, multiple myeloma, and history of pathological fractures. 144 were randomized into 72 in each group. All the patients were followed up, and all the patients received intervention. Demographics. Duration of hospitalization was 2.16 days mean in classical, 5.8 days mean in parasacral. A significant p-value was obtained in successful first needle pass in the number of patients. That is, 32 patients only had a successful first needle pass in classical group, whereas 65 out of 72 patients had a successful first needle pass in the PSPS group. Complications were more or less comparable, except for nausea vomiting. Classical group had a higher rate of nausea vomiting. Comparison of the success of block. A block was accepted as successful if modified Bromid score of 3 with NRS less than 3 was achieved prior to commencement of surgery. Successful block was achieved in 90.27, that is 65 out of 72 patients in classical group, which was significantly lower than 98.61% in the PSPS group. Only 1 person was converted to GA in the PSPS group. The time to USG localization to drug administration in minutes. Here also a significant difference was observed, with classical group requiring a mean of 9.5 plus 2 minutes between ultrasound localization to drug administration, whereas PSPS group had 3.2 plus 1 minute. Time to rescue analgesia was comparable in both the groups, with mean duration being 10.9 hours in PSPS compared to 10.01 hours in classical group. Intra-op sedation requirement was significantly higher in the classical group, with 23.6% people requiring morphine, 22.2% requiring fentanyl, and 45.83% people requiring dexmedetomidine intraoperatively. So the discussion. Use of classical approach by Ben-Ari et al. Was successful in localizing the sciatic nerve in all 17 patients. Chan et al. Used the classical approach and were successful in visualizing in 87% of the patient. Taha et al. Used the same study, classical approach, involving 50 participants with combination of ultrasound guidance and neurostimulation, and were able to give a successful block in 96% of the subjects. With respect to the above, our study was able to identify the nerve via classical approach in all 72 patients. In addition, we were also able to assess the success of motor and sensory block and time to administration of the block. Benston et al. Used the parasacral parallel shift in 7 patients undergoing hip fracture surgery, ASA 3 and 4. Piriformis muscle and sacral plexus was identified in all patients. Successful surgical anesthesia was also given in all 7 patients. In our study, we were able to identify sacral plexus in all 72 patients via PSPS approach, and successful surgical anesthesia was established in 71 out of 72 patients. Time to motor and sensory blockade, time to rescue analgesia, and complications were also assessed. The limitations of our study include difficult patient positioning because some patients may find the lateral decubitus extremely painful in cases of mangal extremity especially, and a pillow below the knees may help in some cases. The second is longer time to blockade as larger myelinated sacral fibers contribute to the sciatic nerve, larger cross-sectional area of the nerve, and greater correlation between the volume and concentration of the drug administered and time to onset of block. As a result, the onset time may be delayed to up to 45 minutes after administration. Such a delay may cause unnecessary conversion to GA as it may be mistaken for a failed block. One way to tackle such limitation is to administer the block in the pre-recovery area under basic hemodynamic monitoring where strict asepsis is possible. It may also form the basis of using this block as an on-arrival block for acute trauma patients on account of ease of administration, longer duration of action, and safer side effect profile as compared to the neuraxial blockade. The other limitation is nerve sparing, more so with femoral nerve block, because there will be sparing of the lateral cutaneous nerve of the thigh or the obturator nerve, which may need conversion to GA. This may be seen during taking split skin grafts from the thigh. Patient may complain of excruciating pain over the lateral or medial aspect of thigh, especially. This is a problem which can be overcome by replacing the femoral block by fascia iliaca block, but the patient is susceptible to developing local anesthetic systemic toxicity. Conclusion. So we conclude that our hypothesis was true because parasacral parallel shift approach was able to elicit better success rate. The advantage of the parasacral approach is posterior cutaneous nerve block reliability, potential for hip joint analgesia, lesser nerve depth at the parasacral region, hence ultrasound guidance is easier. Advantage of USG guided parasacral approach is quicker onset of motor and sensory blocks, increased duration, improved block quality, reduced volume of local anesthetic. The posterior border of ischium is the lower lateral border of the greater sciatic foramen, characteristically curved, hence easily identifiable on USG. The sciatic nerve is the most lateral structure exiting the sciatic foramen, visualized just medial to the posterior border of ischium. The relation to sciatic nerve to the piriformis and gluteal vessels in the parasacral area facilitate its identification here. These are my references. Thank you very much. Hello. Sir, just a minute, I'll rejoin.
Ek minute. Can you hear? Revati,
Yes, sir.
can you
Yes,
hear?
sir.
Okay.
Yes, sir.
You submitted the abstract, then data are different. Huh? You submitted total 160 patients. Huh?
Yes, sir. The study was
Then
underway.
why is there change?
Once
Why is there change? You submitted in your abstract total
160.
160
No, sir.
patients, 80 in each group. 80 in each group. Then there in
The
your
study is
presentation it is
still
changed.
underway, sir.
Huh?
The study is still underway, sir. That is why.
It's still undergoing.
The study is still ongoing. Yes, sir.
Oh, then you didn't mention
So the
it that
data was
still
analyzed for
undergoing.
the completed.
Not still completed.
Yes, sir.
Oh. But ये बताओ बेटे. You mentioned duration of hospitalization of the patients in group 1 and group 2. Why was so difference, so delay in the group B?
Yes, sir.
Second group. Why was so delay in the time to hospitalize? Why? Intentionally or unintentionally?
No, no, sir. Incidental finding. It was unintentional.
Then why were they kept hospitalized
It
for
was
7 days?
unintentional,
Whereas in
sir.
the group 1, they were hospitalized only for 2 days. In your table.
Sir, some of these patients are undergoing second or third surgeries. So their duration of
It's not the block which makes the
hospitalization is
difference.
also taken into
So
account.
it's not the block which makes the difference regarding hospitalization.
No, sir.
Oh, yes. Please, madam.
No, sir. No, sir. That is purely incidental.
Coincidence.
Dr. Revati, what is
Yes, sir.
Dr. Revati? Can you hear me?
Yes, sir. Yes, ma'am. Yes,
What is
ma'am.
the onset of sensory block between two groups?
Onset of sensory block. Ma'am, 1 minute. Ma'am, onset of sensory block, mean of 17 minutes has been seen in the classical group, whereas a mean of 22 minutes was seen in the PSPS group.
Is it significant?
Yes, ma'am.
Which test have you used for the statistical analysis?
Ma'am, for the qualitative variable, I've used chi-square. For quantitative data, I've used unpaired T. And for skewed data, it was checked using Kolmogorov and Smirnov test.
Which are the various statistical tests? Do you know the statistical tests used for analysis?
Ma'am?
Various statistical
Ma'am,
tests.
paired unpaired T test.
Any other?
Yes, ma'am. Ma'am, Mann-Whitney U test.
And is ANOVA and chi-square test used?
Ma'am, when there are more than 2 groups to be analyzed, you use ANOVA. Chi-square is used for qualitative variables in 2 groups.
Okay, thank you. Next participant. Thank you, Revati.
Purti from Kentakana Institute of Medical Sciences, Bangalore. Today I am presenting my paper, a comparative study of bupivacaine versus ropivacaine in preoperative fascia iliaca compartment block in patients posted for proximal femur fracture surgeries under spinal anesthesia. Femur fracture is a common orthopedic injury which causes severe pain and distress, especially in elderly patients. Anesthesia for femur surgeries is usually provided by subarachnoid block, where proper positioning is essential for a successful procedure. Alleviating pain increases patient comfort and also provides better patient positioning for spinal anesthesia. Providing effective analgesia in these patients is complicated due to their advanced age and concomitant comorbidities. Various drugs have been used to reduce pain preoperatively and also improve positioning in these patients. Peripheral nerve blocks have come up as an effective and a safe alternative to provide pain relief without the side effects of systemic analgesics. The fascia iliaca compartment is a potential space lying between the fascia iliaca anteriorly and iliopsoas muscle posteriorly. Earlier, nerve blocks was performed using landmark techniques and also using nerve stimulators, but they were associated with high failure rates and caused injury to the surrounding structures and nerves. But now, ultrasound has come up as an effective alternative method for identification and safe blockade of the nerve fibers. Bupivacaine and ropivacaine are long-acting amide local anesthetics, which are most commonly used analgesics for peripheral nerve blocks. Although few randomized studies have investigated the efficacy of fascia iliaca block for alleviating pain in femur fractures and also have been compared with intravenous opioids, but there are no studies directly comparing the above two local anesthetics for fascia iliaca block. Here is the anatomical representation of fascia iliaca. The site of injection will be between the fascia iliaca and iliacus muscle. Our primary objectives were to compare the onset of fascia iliaca block among both the groups. The analgesia obtained for patient positioning for the spinal anesthesia in terms of VAS score. The quality of patient positioning for administering spinal anesthesia using numerical scoring. Our secondary objectives were to compare the hemodynamic parameters after the fascia iliaca block, the total duration of analgesia, and 24-hour opioid consumption postoperatively. This is a prospective randomized control study conducted at Kentakana Institute of Medical Sciences, Bangalore. Our sample size was calculated using the following formula. Our total sample size obtained was 70 with 35 in each group. Patients of either sex between age group of 18 to 70 years of ASA grade 1, 2, and 3 posted for elective proximal femur fracture surgeries who gave informed consent were included in the study. The following were our exclusion criteria. After obtaining ethics committee approval and after taking informed consent from the patient, a total of 70 patients were included in the study. They were preoperatively evaluated and clinically examined. Our selected patients were randomly allocated into 2 groups, Group B and Group R. Group B received 30 ml of 0.25% bupivacaine and Group R received 30 ml of 0.25% ropivacaine. After shifting the patient, the baseline hemodynamic parameters like heart rate, SBP, DBP, and mean arterial pressure, SpO2 were recorded. Under sterile aseptic precautions, ultrasound landmarks were identified and fascia iliaca block was given after negative aspiration using 23 gauge twin case lumbar puncture needle. Here is the image which shows the fascia iliaca block under ultrasound guidance.
Here on the left, we can see the ultrasound image of fascia iliaca and the surrounding structures before giving the block. And on the right is the image after the spread of local anesthetic after giving the block. Hemodynamic variables were recorded at 5 minutes interval after the block till positioning. Onset of fascia iliaca block was noted every 2 minutes using pinprick method. Patient is positioned for spine anesthesia 15 minutes after the fascia iliaca block. The analgesia provided by either of the local anesthetic was assessed by visual analogs for 15 minutes after the block. Subarachnoid block was performed in sitting position at L3 L4 space using 26 gauge Quincke needle with 3 ml of 0.5% heavy hyperbaric bupivacaine. The quality of patient positioning for administering spine anesthesia was recorded with numerical scores of 0 to 3. Here we can see the comfortable positioning of the patient for spine anesthesia after giving the block. Analgesia was assessed by visual analog scale. The time to first rescue analgesia, that is the total duration of analgesia, was noted when the VAS score exceeded more than 4. Patients were given injection tramadol 1 to 2 mg per kg IV as rescue analgesia when VAS was more than 4. Total dose of opioid required in 24 hours was assessed. Statistical data analysis was done using SPSS software. The demographic data among the two groups were comparable. There was statistically highly significant faster onset of fascia iliaca block in bupivacaine group compared to ropivacaine group. There was no significant difference in VAS during positioning and quality of positioning in both the groups. There was no significant difference in heart rate, mean arterial pressure, and SpO2 among both the groups at any time interval. There was no significant difference in duration of surgery among both the groups. Even though duration of analgesia was more with ropivacaine group compared to bupivacaine group, the difference was not statistically significant. There was no difference in 24-hour opioid consumption among both the groups. Our results were the following. Mean onset of fascia iliaca block in group B was about 6 minutes and group R was around 10.5 minutes, which was statistically significant. Time to first rescue analgesia in group B was around 409 minutes and group R was around 445 minutes, but the difference was statistically not significant. There was no significant difference with VAS, quality of positioning, and also 24-hour opioid consumption among both the groups. Coming to the discussion, fracture tumor is commonly seen following trauma in endometriosis and after a trivial fall in the elderly. While regional anesthesia have been shown to be more beneficial compared to general anesthesia, patient positioning for neurological blockade may cause severe pain in patients with femur fractures. Various systemic analgesics have been used, but these drugs comorbidities. Nerve blocks have come up as an alternative approach to provide pain relief in for positioning in these patients. Fascia iliaca compartment block was first described by Dallin et al. It has a simple, low-skill and safe technique which can be used in pre-hospital care, in emergency department and in the pre-operative setting, and also for post-operative analgesia. It blocks the femoral nerve, lateral femoral cutaneous nerve, and sometimes the obturator nerve. Since the injection is given away from the artery and nerve, chances of neurovascular injury is very minimal. Use of ultrasound also increases the success rate and further reduces the risk of neurovascular injury. In the study, we included the patients with extracapsular fractures, which included intratrochanteric, subtrochanteric, and cervical neck fractures. These patients usually undergo open reduction internal fixation. There is no manipulation of the capsule, the posterior part of which is supplied by the sciatic nerve. Hence, the pain management in these patients does not require blocking the sciatic nerve and can be achieved solely by blocking the femoral and lateral femoral cutaneous nerve, which can be done by fascia iliaca block. Performing block preoperatively provided the advantage of analgesia during positioning in sitting position for subarachnoid block. It allowed the assessment of sensory onset of fascia iliaca block without any doubt regarding the residual effect of subarachnoid block. However, this could affect the effective duration of analgesia. So we recorded the duration of the surgery, which was comparable in both the groups. Here is the review of few of the studies where the efficacy of fascia iliaca block was established. So we conclude that fascia iliaca block is a safe, easy to perform technique which provides effective analgesia without any hemodynamic instability and adverse effects. In our study, fascia iliaca block was given prior to spinal anesthesia, which provided analgesia and ensured patient comfort, which helps in easy positioning for spinal anesthesia, with bupivacaine having faster onset of action compared to ropivacaine, but provides comparable duration of analgesia and 24-hour opioid consumption post-operative. Here are my references. Thank you.
What is your name?
Good morning, ma'am. I'm Spurti, ma'am.
What is the rationale of this study?
Sorry, ma'am, I can't hear you.
What is the rationale of this study? Why did you perform this study? Any background?
Yes, ma'am. In old age people, the usage of opioid can be reduced and there will be pain. So the positioning will be difficult. So that will be a problem for positioning for spinal anesthesia. And also post-op analgesia will have to give more opioids and other systemic analgesics, which has more adverse effects. So preoperatively giving fascia iliaca block, it will performance of spinal anesthesia also will be easier, taking
less time, and also post-operative analgesia will be better.
Why did you compare bupivacaine versus ropivacaine?
These are the two most commonly used local anesthetics. So I wanted to compare which is better. Since ropivacaine is more cardio stable, I wanted to compare the most commonly used local anesthetics. For fascia iliaca block, it was not performed before, so I wanted to compare.
Used in bupivacaine group.
Ma'am?
Total dose of bupivacaine.
Ma'am, 0.25% 30 ml was used, ma'am. Ropivacaine 0.25 ml 30 ml.
And in intrathecally?
Ma'am? No, not intrathecally, ma'am. Locally.
Okay,
For
you have
block.
given intrathecally.
Intrathecally 3 ml.
Anesthesia with bupivacaine.
Intrathecally 0.5% 3 ml bupivacaine was used.
How many? Can you calculate the dose?
15 mg, ma'am.
15 mg plus?
Ma'am? Hyperbaric bupivacaine was used for intrathecal. 15 mg was used.
And for fascia iliaca block in B group, bupivacaine group?
In bupivacaine group, 30 ml 0.25% was used, ma'am.
Okay, then total bupivacaine? Total dose of bupivacaine?
30 ml, ma'am. Plus this 15 mg intrathecally was used, ma'am. 33 ml was used, ma'am.
Okay. Over to sir.
Okay, Spurti,
Yes, yes, sir.
your conclusion is that it provides analgesia which helps in positioning of the fracture femur patient, na?
Yes, sir.
Who are posted for the fracture surgery.
Yes, sir.
So, what was your experience regarding quality of patient positioning in both the groups, and was there any difference?
For positioning, there was not much difference, but onset was better with bupivacaine. So at the end of 15 minutes, with bupivacaine, there was better this one.
You mentioned onset 6.17, and with the regarding ropivacaine, you mentioned 10.51.
Yes. Yes.
So, and you mentioned that at the 15 minutes they were comfortable.
Yes.
तब तक तो spinal ही लगा दिया.
At the end of 15 minutes, I gave spinal, sir.
You gave spinal, na? So, बिना FICB, without FICB, if we give block,
Yes,
spinal anesthesia,
Ah.
what was the patient quality of the patient positioning for the spinal anesthesia? Would there have been a difference?
Yes, sir. Positioning would be difficult in proximal femur surgeries because patient will already have pain, and making them
Surgery नहीं, for spinal anesthesia.
for spinal anesthesia, making them sit.
बिठाते टाइम मरीज को दर्द होता है ना? ये कहना चाहते हो ना? इसीलिए तो अपन ने FICB यूज किया. That's why you use the FICB for these patients, ना?
Yes, sir. Yes, sir. And also has the advantage of post-op analgesia.
So what were your parameters to note the quality of patient positioning?
For patient, VAS scoring was used, sir.
What was the difference in your study in both the groups with bupivacaine?
At the end of 15 minutes, there was not much difference.
Not much difference, na? But at the time of onset, you mentioned it's at the 6 and 7 minutes, 6 and 10 minutes. Was there any difference?
Onset was.
अपन ने देखा ही नहीं ना? We directly noticed that at the 15 minutes. अपन ने direct 15 minutes पे देखा कि दोनों both are comparable. So the quality of positioning, patient positioning were comfortable in both the groups.
Yes, sir.
So it means FICB helps in the patient positioning.
Yes, sir.
ठीक है ना? Okay, thank you. Next.
Thank you, sir.
Okay.
Thank you, ma'am.
Warm greetings from KLE's Jawaharlal Nehru Medical College, Belgavi. Myself, Dr. Darshan Arul, presenting superior trunk block, an unorthodox alternative interscalene block for proximal humerus surgeries in patients with significant pulmonary disease. I would like to thank our co-guides, Dr. Rajesh S. Mani and Dr. Manjunath C. Patil, for for helping me with this case series. Here we involved 8 patients for proximal shoulder surgery. Proximal shoulder surgery in patients with compromised pulmonary function stipulates anesthesiologists to look for an alternative to interscalene block. Superior trunk block of brachial plexus visualized accurately through the ultrasound would steer effortless performance and achieving acceptable block characteristics. But with this interscalene block, it is found that the ipsilateral phrenic nerve paresis is inevitable, leading to hemidiaphragmatic paralysis, which would be catastrophic in patients with compromised pulmonary function, in patients with COPD, in post-COVID patients. To preclude hemidiaphragmatic paralysis, challenge the pioneered the use of superior trunk block to utilize distinct advantage of phrenic nerve sparing, allowing patients to execute normal respiratory function perioperatively. Proximal shoulder surgery involving arthroscopic shoulder surgery is very painful procedure. So interscalene block has been used commonly to provide anesthesia and analgesia, and it is the sole anesthetic procedure done for proximal shoulder surgeries. In order to decrease the hemidiaphragmatic paralysis, other approaches were introduced or investigated. One was superior trunk block, the other one is the anterior suprascapular block. So what did we do? In this study, 8 patients aged between 40 years and 80 years with significant reactive obstructive pulmonary disease and post-COVID patients who posted for proximal humeral surgery were included. Under ultrasound guidance with a 23-gauge needle, 1:1 local anesthetic mixture of 2% lidocaine plus adrenaline and 0.5% bupivacaine was injected with a total volume comprising of 15 ml. Outcomes, what we looked for was loss of shoulder abduction, numbness of shoulder and pain relief, numbness of the arm, oxygen saturation perioperatively, closed circuit measurement of tidal volume generated, and sonographic assessment of the diaphragmatic movement. Here, the first picture shows the visualization of the superior trunk of the through the interscalene approach. The patient is placed in supine position on the operating table and the head is turned towards the contralateral side. The linear probe is placed in the supraclavicular area. The supraclavicular brachial plexus is identified and the probe is moved proximally in order to identify the interscalene part of the brachial plexus, which is identified with traffic signal sign. The superior trunk block is visualized through the interscalene approach, and 15 ml was injected for local anesthesia to provide surgical anesthesia and analgesia for proximal humeral surgeries. Perioperatively, end inspiratory diaphragmatic excursion and end expiratory diaphragmatic excursion was measured in order to identify any hemidiaphragmatic paralysis which would have occurred due to the superior trunk block. 7 patients with superior trunk block achieved complete surgical anesthesia of proximal shoulder. There was solitary usage of dexmedetomidine for a patient with severe anxiety. 2 patients required oxygen supplementation due to their lower baseline saturation and extensive disease throughout the intraoperative period, extending to postoperative period as well. Sonographic assessment intraoperatively and postoperatively disclosed adequate diaphragmatic excursion in all patients. Postoperative pain scores relieved satisfactory pain relief. Coming to the results, in preoperative setup, 8 patients aged between 40 to 80 years of either gender with preoperative diagnosis of post-COVID status or COPD with PFTs of restrictive, moderative, obstructive as well as severe obstruction were included. The baseline saturation was well above 90%. Only 1 patient had saturation of 90%, whereas 4 patients had saturation of 92%. In the perioperative period, anesthesia of shoulder and arm was found in 7 patients, but 1 patient had partial anesthesia. Oxygen saturation was well maintained between 88% and 94%, with only 1 patient having 88% of saturation. Tidal volume generated was adequate, with only 1 patient having tidal volume of less than 400 ml. Diaphragmatic movement was adequate in all the patients and rescue analgesia was used in one patient. Coming to discussion, superior trunk block was a novel technique which provides surgical anesthesia for proximal shoulder surgeries with lesser degree of hemidiaphragmatic paralysis. The interscalene block has inevitable phrenic nerve paralysis, whereas supraclavicular approach provides up to 30 to 60% of phrenic nerve paralysis, leading to hemidiaphragmatic paralysis and worsening of the pulmonary function. It has the propensity to block the brachial plexus more proximally with the wider coverage. The superior trunk block hence can provide analgesia which is comparable with the interscalene block. It is more easier to perform than interscalene block and associated with decreased opioid consumption. Coming to the conclusion, effective surgical anesthesia and analgesia can be achieved efficiently with superior trunk block for surgeries of proximal humerus in patients with compromised pulmonary function by sparing the phrenic nerve, and it is an appropriate substitute for interscalene block.
Darshan, can you
Yes,
hear?
sir. Good morning. Yes, sir. Good morning, sir.
So you included 8 patients in your study, na?
Yes, sir.
And you had given this baseline SpO2. Why was so different in all the people, all these 8 patients, up 89
Sir,
to only 90%?
It was a mixture of patients. Sir. We included both the obstructive and restrictive patients. Sir. Patients who had come with COPD, obstructive patients who were post-COVID patients who had proximal humerus problems. Those patients were included, sir. So the baseline
They were
saturation. Yes.
post-COVID with the restrictive and COPD patients.
It was a mixture of
SpO2
patients.
was around 90%. Then have we conducted the ABG for these patients?
ABG?
क्या ABG कराई गई थी?
No, sir.
No. ABG क्यों नहीं कराई बेटा? When the saturation was around, सभी patients का baseline है जो around 90% है. Then why not ABG? We didn't go for ABG.
Yes, sir. ABG should have been considered.
और baseline respiratory function test also.
Yes, sir.
है ना?
Yes, sir.
ये नहीं कराई अपन ने इसके अंदर, ठीक है ना? And you mentioned that diaphragmatic movement.
Yes,
What was the diaphragmatic movement का अपन ने कोई टेबल बनाई है क्या?
Diaphragmatic movement, I've mentioned about this thing, sir, in the table. If it was partial or if it was complete, sir.
Only
we just comparison from the baseline.
Comparison was only the comparison with the baseline. Partial, yes, or complete only, huh?
Yes, sir. Yes, sir. If there was any excursion difficulties was obtained intraoperatively, perioperatively or not, sir.
No, it was sonological, na?
Yes, sir.
It was sonological. So we can go for the percentage paresis by 25% paresis, 50%,
25%, 75%. Yes, sir.
कितना paresis रहा होगा?
Yes, sir.
कितना रहा होगा लगभग?
It will be for those patients where the block acted partially, sir. It would be around 50%, or if the saturation of the patients were from the baseline was very low. If the patient had severe restrictive disease, then the paresis would have been more. But it depends upon the block characteristics, how the block was performed also, sir.
Post-COVID patients में even
yes,
tidal volume was not the problem.
Yes, sir.
Your patients have the TB around around 450 ml.
Yes,
they were
sir.
all adult patients. TB
yes,
was
sir.
around 450 ml.
Yes, sir.
The fibrosis.
Yes, sir.
So,
yes, sir.
Problem was the alveolar capillary perfusion.
Perfusion. Yes, sir.
It was the perfusion that was the problem.
Yes, sir.
है ना?
Yes, sir.
ठीक है ना? समझ गया बात को?
Yes, sir.
चलो मैडम को.
Hello, Harsha.
Yes, sir. Yes, ma'am. Good morning, ma'am.
What is the limitation of this which block? Truncal block over interscalary block?
The superior trunk block, at times they have anatomical variations, ma'am. Even we have to be careful about the subclavian vein or the thoracic artery, which we have to be important, ma'am. And also there's anatomical variations, and also the block might be performed superficially also, ma'am. There might be chances of partial action of the block. In interscalene block, the problem with performing interscalene block is the more volume that has to be given, and also the more diaphragmatic paralysis which can be caused. There is up to around 50 to 70% of diaphragmatic paralysis which can be caused by interscalene block, but that can be reduced with the superior trunk block, which we try to prove with this case series, ma'am.
So what is the result of this block?
Superior trunk block can be considered as an alternative to interscalene block, provided the suprascapular nerve is also involved, and we should make sure that long thoracic nerve and dorsal scapular nerve are all spared. Superior, because surgeries of the shoulder, the nerve supply is very complex. It would also need the axillary nerve block also, but superior trunk block provides an adequate anesthesia and analgesia, ma'am.
To make any conclusion, you need more than 10 cases.
Yes, ma'am. It was a short case series which was considered in the time.
It must be having more than 10 cases.
Oh, okay.
Thank you.
Oh, thank you.
Next participant.
Who is next?
They needed for case
Good
series.
morning, everyone. Today's my presentation is on ultrasound-guided low-fluorescence spiny plane block for postoperative anesthesia following gynecologic oncology surgery. This block was performed in 2016 for thoracic analgesia. Since then, it has been used for many surgeries. ESP muscle extends over a large area. This is novel interfacial plane block. Local anesthetic is deposited between erector spiny muscle and transverse process. Under ultrasound guidance, it results in early onset with improved quality block. Till date, there are no publications with regards to comparative study of using this block for open gynec surgeries. Only case series have been published. We aimed the study to investigate efficacy of USG-guided ESP block for postoperative analgesia for gynecologic oncology patients with primary objective of pain intensity. In this prospective randomized controlled trial, 60 adult females for elective open gynec cancer surgeries were posted. Those not suitable for this study were excluded. On the day of surgery, patients were educated about VAS code. Standard general anesthesia was used. At the end of surgery and before extubation, ultrasound-guided ESP block bilaterally and single shot was used. There were two groups, B and C. In B group, GA plus USG-guided ESP block using lignocaine plus bupivacaine 20 ml was injected on each side. In C group, only GA was used. For postoperative analgesia, paracetamol was given 8 hourly and tramadol was used when VAS score was greater than 4. Patients were placed in lateral position and high-frequency ultrasound linear probe was placed vertically on T9 transverse process, and overlying erector spiny and trapezius muscles were identified. Spinal needle was inserted in plane in craniocaudal direction, targeting T9 transverse process. 2 ml saline was used for hydrodissection. After that, 20 ml of study drug was injected. Outcomes were observed postoperatively for 24 hours. 4 PQ by E square formula was used for sample size calculation, and 24 patients were required in each group. We included 30 patients in each group to compensate for dropouts. Randomization with allocation concealment was used with opaque sealed envelope. Consult chart was followed. Demographic data as well as type of surgeries were comparable in both the groups. Static VAS and dynamic VAS were lower throughout the study period in B group. Postoperative tramadol requirement was less in B group with prolonged analgesia without any complications. In
In this meta-analysis, it was stated that most severe acute pain occurs in early postoperative period in gynec cancer operations. We have choice of many analgesics with different routes. Each one has its own drawback. So which technique should we use? For open abdominal surgeries, thoracic epidural analgesia provides very good post-op analgesia. But ERAS Society has not defined its clear role because of the drawback of hypotension. Erector spiny plane block provides extensive somatic visceral analgesia with single puncture without motor blockage. This block works by spreading drug in paravertebral space and blocking dorsal and ventral rami of spinal nerve. In this study, this block was used for thoracic neuropathic pain relief and acute postoperative pain relief. Injection was given at T5 level and analgesia was extended from C8 to T8. We also observed very good post-op analgesia. This is the same study where dye was injected in 2 fresh cadavers at T5 level and extensive spread of dye was seen on CT scan. This is a case series of ESP block for gynec onco surgeries where 12 and 16 hours of duration of analgesia was observed with single shot ESP block. In our study, 8 hours of duration of analgesia was there with lignocaine and bupivacaine. This is again a case series where ESP block was used for open or laparoscopic abdominal surgeries, and they concluded epidural catheter can be replaced with this block. These are the randomized controlled trials for cholecystectomy and percutaneous nephrolithotomy, where ESP block was given using bupivacaine and 12 hours of duration of analgesia was observed. These are the case reports where epidural was contraindicated and ESP block provided extensive and very good analgesia for acute and chronic pain. In this study, lignocaine bupivacaine mixture resulted in early onset of analgesia. Same was observed in our study. This is a single study where unexpected lower limb weakness was observed following ESP block. These are the randomized controlled trials where this block resulted in no complications. Same with our study. We use this block at the end of surgery to make intraoperative fentanyl doses comparable. Future needs are to be recommended for dose concentration and comparison trials with other regional anesthetic techniques. So we can conclude that ESP block provides effective somatic and visceral analgesia in patients undergoing open major gynec oncology surgeries. Here we can observe in this video that spinal needle is inserted in plane in craniocaudal direction with 2 ml of saline hydrodissection was seen, and after that 20 ml of study drug was injected. So it results in extensive craniocaudal spread with lifting up of erector spiny plane muscle. Thank you.
डॉक्टर रेखा
गुड मॉर्निंग सर।
गुड मॉर्निंग मैडम। ये बताएं आपने ESP ब्लॉक किस लेवल पे लगाया?
सर इट वाज गिवन एट T9 लेवल, लोअर thoracic level.
Yes. All patients, na?
Yes, sir, in all 30.
Okay. Question is this: when for the gynecological oncological surgery, we can go directly under spinal anesthesia, and this study includes there is a comparison of general anesthesia versus GA plus ESP block, whereas we can get the extended analgesia with the spinal anesthesia and with this gynecological oncology surgery. What is your opinion?
Sir, in our institute, we don't use spinal anesthesia for gynec onco surgeries because many times, sir, because of the adhesions to rectum or even urinary bladder, sometimes extension may be required, and it may be associated with omentectomy, even lymph node dissections, and spinal anesthesia surgeons might not be comfortable with it. Many times it happens, sir. We tried for it initially.
Gynecological surgeries are being conducted under spinal
Yes, sir.
since long,
Yes,
and
sir.
patients are quite comfortable. Or
Yes, sir.
with the bupivacaine, we get analgesia up to 3 to 4 hours.
Yes, sir.
3 to 4 hours.
So and these institute oncosurgery lasts for 7 to 8 hours.
Duration is even longer, and sometimes momentectomy is usually planned. And if the mass is adherent to intestine, then the under spinal anesthesia patients may not be comfortable, and surgeon becomes discomfortable in this situation.
Any complication have you observed?
No, ma'am. No complications were observed. It was very safe and without any complications.
At T9 level, it is more safer than the T4 or
Yes,
T5.
sir. Yes, sir. Yes, sir. Yes, it lower thoracic level, it's safe.
Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Please. Next.
Good morning. I'm Dr. Priyanka Kamalki, and the title of my study is Comparison of Preemptive Ketamine Nebulization with Intravenous Ketamine for Post-Operative Analgesia in Children Undergoing Tonsillectomy, a randomized controlled trial. Introduction. Tonsillectomy continues to be the most common pediatric ENT procedure worldwide. Post-tonsillectomy pain is the most common complication of this procedure. NSAIDs, systemic opioids, intravenous paracetamol, and local anesthetics have been commonly used for post-tonsillectomy pain control in children. Ketamine, an NMDA antagonist, blunts the central hypersensitivity caused by pain. Intravenous ketamine has been administered as an adjunct to fentanyl or intravenous paracetamol in tonsillectomy and significantly attenuated the postoperative pain. Inhalation of nebulized ketamine is an alternative new route of administration that is relatively easy to set up, and it is associated with high bioavailability. The aim of this study was to investigate the analgesic efficacy of nebulized ketamine 1 mg per kg administered 20 minutes before general anesthesia in children undergoing tonsillectomy in direct comparison with intravenous ketamine. Methods. After obtaining ethical committee clearance and parental consent, 64 children were randomly allocated into two groups. Both groups contained glycopyrrolate 5 microgram per kg IV. The first group received ketamine nebulization 1 mg per kg 20 minutes prior to the surgery, and the other group received intravenous ketamine 1 mg per kg just before shifting to OT. Children were anesthetized by standard technique using fentanyl 1 microgram per kg, propofol 2 mg per kg, atropine 0.5 mg per kg, and sevoflurane. Postoperatively, pain score using verbal rating pain scale was assessed immediately after shifting to PACO and 1 hour postoperatively, and time at which first rescue analgesia required was noted. Children were also assessed for parental separation score and levels of sedation using 5-point sedation scale when brought to the operating table. Three scales used in this study were 5-point sedation score, parental separation score, and verbal rating scale. Statistical analysis, patients of both gender belonging to the age group of 5 to 10, ASA1, undergoing tonsillectomy at KLE Prabhakar Kore Charitable Hospital and Medical Research Center. The sample size were calculated up to 32 per group. Inclusion criteria, patients undergoing tonsillectomy age 5 to 10, ASA grade 1, and child parent giving consent. Excluded from the study may be a child with cardiac, respiratory, or neuropsychiatric disorders, increased intracranial or intraocular pressure, and known allergies. Result, the first table shows a comparison between the age and weight between the two groups. The second table shows the comparison between 5-pointer sedation scale and parental separation scores between intravenous and nebulized ketamine. This table shows the difference between the verbal rating scale immediately after shifting to PACO and 1 hour between the two groups. Time for rescue analgesia between the two groups is shown in this table and graph. There was no significant difference in the VRS pain scores immediately after shifting to PACO, but there was a significant difference in the VRS pain score 1 hour post-operatively. The mean time for rescue analgesia was prolonged in ketamine nebulization for 300 minutes in contrast to intravenous ketamine 237 minutes, with a significant difference between the two groups. It was also observed that ketamine nebulization and intravenous ketamine produce similar levels of sedation and acceptable parental separation scores. Hence, nebulization is an effective alternate route of ketamine administration. Discussion. The demographic and pre-anesthetic characteristics between the two groups were comparable. Parent separation score and 5-point sedation scores were found to be comparable between the two groups. Time for first rescue analgesia between the nebulization group and the IV group was found to be statistically significant. The main finding in this study were, as compared to intravenous ketamine 1 mg per kg, nebulized ketamine 1 mg per kg significantly prolonged the time to first rescue analgesia, thus reducing the analgesic consumption. The administration of ketamine as nebulized inhalation is relatively low, and studies on nebulized ketamine are sparse. Ketamine administration by nebulized inhalation resulted in rapid absorption into the systemic circulation from the nasal and pharyngeal mucosa. 70% of the inhaled ketamine is absorbed directly by the alveoli into the circulation, that is a fast path, and 30% of the drug is absorbed slowly either by the gastrointestinal or pulmonary mucosa. Thus, higher bioavailability of the drug in the child who was given nebulization with ketamine resulted in better analgesia when compared to the intravenous route. Similar findings were found in the study done by Abdel. In another study, the intravenous ketamine 0.5 mg per kg was an effective adjunct to fentanyl in children undergoing tonsillectomy that reduced the post-operative pain without delaying the home discharge. Another study that used a combination of intravenous paracetamol and low-dose ketamine 0.25 mg per kg reduced pain after tonsillectomy compared to paracetamol-only analgesia. Conclusion: ketamine nebulization administered before tonsillectomy significantly prolonged the period of analgesia when compared to intravenous ketamine. Also, the parent separation scores and sedation scores were comparable between the two groups. Hence, nebulization can be used as an alternate route for administering ketamine. References. Thank you.
Hello. So you're not audible, sir.
Now we are audible?
Yes, sir.
Okay, Priyanka.
Yes, sir.
You use ketamine 1 milligram per
Yes, sir.
kg in children,
Yes,
na?
sir.
5 to 10 years old.
Yes, sir.
है ना?
Yes, sir.
You use with the nebulization 20 minutes before surgery, before
Yes, sir.
anesthesia induction, na? And
Yes, sir.
before anesthesia induction intravenous.
Yes, sir.
Data are comparable. That's why you
Sir, yes.
patient
Yes.
parental separation score and accept this duration of analgesia, na?
Yes, sir. Except for the duration, the results are comparable, sir. The main advantage over here was that because
Fusion is
of the
not this one
better
advantage. Fusion is, why is that difference because of between the nebulized ketamine and intravenous ketamine that it produced the prolonged duration?
Sir, because of nebulization, along with systemic, even there is topical anti-inflammatory and anti-hyperalgesic effect of ketamine in the site locally, sir. So since the route of administration was nebulization and the surgery is tonsillectomy, the local concentration of the drug was also more. So it helped in a better analgesia when compared to IVs. Both systemic effects are the same, sir. Only that since the topical anti-inflammatory and anti-hyperalgesic effect of the drug helped in nebulization group was had a better analgesic effect. Sir.
So can we recommend topical ketamine after tonsillectomy surgery before recovery?
Sir, again, the drawback of ketamine is that the side effect is there is increased secretion, sir. So just before extubation, we cannot be sure as to what would be the effect later, sir. And giving it in nebulization even improved the parental separation, and so those were advantages of the
consideration in a parental separation. If we put a swab ketamine after removal of the tonsil, we put it there for 5-10 minutes and we reverse the patient. Then would it give help in the post-op analgesia?
It would help, yes.
It would. Okay, thank you. Madam, please. Madam.
Okay. Priyanka.
Yes, ma'am.
What is bioavailability? You said bioavailability is more with nebulized ketamine.
Yes, ma'am.
What is
Bioavailability, it is the fraction of the absorbed drug, the administered drug that reaches the systemic circulation, ma'am, is the bioavailability.
Okay. And for nebulized ketamine, bioavailability is how much?
Bioavailability, like there is no numerical value exactly, ma'am. It is said that about 70% of it is available, ma'am. The studies are not adequate to say the exact percentage, ma'am, but around 70% of the drug is available in the site for action.
For intravenous ketamine?
Exact value is not still defined, ma'am, as such, but they say
In bioavailability, there is no difference in bioavailability.
yes, ma'am. The action difference is there, ma'am, but the exact numerical value of the both are not assessed yet, ma'am.
Next participant.
Thank you, ma'am. Thank you, sir.
Next.
Good afternoon, everyone. I, Dr. Mohammad Hamad Mohsin, junior resident, third year, is going to present my paper on the topic effect of erector spiny block and PEX block on quality of recovery and analgesia after modified radical mastectomy, a randomized controlled double-blind study. The affiliation institute is King George's Medical University at Lucknow, and my co-author being Dr. Ritu Verma ma'am. Coming to the introduction, the cancer of the mammary gland or breast cancer is the most common cancer in women worldwide and in India. Modified radical mastectomy accounts for 31% of all breast operations performed, that is MRN. The pectoral nerve block, a novel and less invasive nerve block, has gained popularity in recent years. One of the newer interfacial techniques with potential applications is the erector spiny block. Aims and objectives being: the aim of the study is to compare the efficacy of PEX block and erector spiny block for post-operative quality of recovery and analgesia after modified radical mastectomy. The primary objective of the study is to compare the quality of recovery, that is QOR score 40. The secondary objectives are to compare total consumption of analgesia in first 24 hours in post-operative period, as well as VAS scores in first 24 hours. Materials and methods used. The study area designated was Department of Anesthesia at KGMU, Lucknow. The study design was randomized controlled double-blind study. The duration of the study was approximately 1 year and the sample size was 90. The inclusion criteria were: age was approximately 18 to 70 years, ASA grade 1 and 2, patients, those who were giving written informed consent, and the female patients who were undergoing unilateral modified radical mastectomy for breast cancer were included in the inclusion criteria. The exclusion criteria being endocrine disorders, including type 1 and type 2 diabetes mellitus, and the patients allergic to local anesthetics were excluded. Methodology: total 90 patients underwent unilateral modified radical mastectomy for breast cancer were included as per inclusion-exclusion criteria. The patients were randomized into group 1, that is PEX block, which used 20 ml 0.25% bupivacaine, the sample size being 30. Group 2, the electrospiny block, 20 ml 0.25% bupivacaine, that is sample size is equal to 30. And group 3, that is control group, and the sample size was 30. Along with clinical demographical data, the requirement of the first dose of rescue analgesia, the total amount, VAS score, and quality of recovery were compared. Anesthesia and surgical interventions were done as per standard protocol. The results showed no significant differences in demographical data as seen in the tabular form of age, that is approximately around 43 years in all groups. In group 1, the hemodynamic parameters were much lower at each follow-up as compared to group 2 and group 3. However, there was no statistical significant differences were observed. These graphs showed approximately around 120 minutes duration, and these showed mean pulse rate, mean systolic blood pressure, mean diastolic blood pressure, mean saturation throughout the surgery, as well as mean arterial pressures. These graphs compared intraoperatively as well as post-operative hemodynamic parameters, that is approximately around 120 minutes. The rescue analgesia which was used in the study was 100 milligram IV tramadol, which was used in post-op. The mean first rescue analgesic requirement was significantly delayed in group 1, followed by group 2 as compared to controls, that is group 3. And the p-value was significant, that is less than 0.0001. As seen in this table, in the group 1, the mean first rescue analgesia required was approximately at the time of 6 hours. In the group 2, it was approximately at the time 4 hours, and in the group 3, approximately at 2.15 to 2 hours. In the second table, there was a mean total rescue analgesia was compared, and it was much lower in group 1 and group 2 as compared to group 3, and the difference was statistically significant, that is p-value that is less than 0.0001. The total rescue analgesia, the total used was approximately 137 milligram used in group 1, followed by 189 milligrams approximately in group 2, as well as 229 milligrams of tramadol was used in 24 hours post-operatively in group 3. The difference was statistically significant, p-value less than 0.0001. The mean VAS scores were also much lower in group 1, followed by group 2 as compared to group 3 at different follow-ups, and the difference was statistically significant. After 4 hours, the VAS score comparatively increased in group 1, group 2, and group 3, but it was the mean VAS score was at different follow-ups was statistically significant. The global QR recovery score was compared for 24 hours and showed significant better outcomes group 1, as shown in these tables and the graphs. Concluding, the both PEX and ESP block can be used efficaciously for providing analgesia for modified radical mastectomy for breast cancer. However, PEX showed much better outcomes. Thank you.
Can you hear me, Mohammed?
Yes, sir. Yes, sir.
Good
morning, sir. Good afternoon, sir.
You mentioned that mean first rescue analgesic requirement in all the 3 groups. Even in control, it was 2.5 minutes, no?
Yes, sir.
With the ESP, it was around 4 minutes. And with
no, sir, it is it was 4 hours, sir. 4 hours.
4 hours, no?
Yes,
first rescue hours only, hours. And with the PEX, it is around 6 hours.
Yes, sir, approximately, sir.
You mentioned that they differ to each other, highly significantly different, na? P-value less than 0.0001, है ना?
Yes, sir.
है ना? इसका मतलब तीनों डिफर करते हैं. इसका मतलब होता है कि
सर ओवरऑल कंपैरिजन सर.
हाँ, तीनों ज़्यादा डिफर करते हैं.
Yes, sir.
But we talk only absolute values. We can't say. There must be standard deviation. Then only we can come to conclusion that they differ to each other.
Yes, sir.
Got it? And
Yes,
you
sir.
haven't mentioned even in your abstract, in your slide, the standard deviation.
Okay, sir.
Okay? You mentioned, you gave the bar diagram. Better, it would have been better you would have mentioned in the tabular form with the values,
Okay,
so
sir.
that we can say that yes, the values differ from each other. Otherwise, we can't say.
Okay,
6, 4, 3. 6, 4, 3 को numerical, how can they be different? It doesn't come to it statistically significant difference. Same likely be regarding mean total ratio analysis requirement, है ना? समझ गया?
Yes, sir.
Got
Yes,
it?
sir.
Okay, thank you, madam.
Hello.
देखो उसके आवाज तो बंद है।
Yes, sir. Yes, ma'am. Yes, ma'am.
Any complication have you noted in your study?
Pardon, ma'am.
Any complication have you noted?
No, ma'am. Because all the procedures were done under USG guidance, there was no complications, ma'am.
Not a single complication.
Ma'am, in ESP block, there might be possibility of pneumothorax. In PEX block, it might cause difficulty during surgery due to filled spaces in between the pectoralis major and minor. There might be IV injections that might be given into pectoral branch of thoracoabdominal artery when needle transverse is high in the axilla, and IV injection might be given in cephalic vein. Also, ma'am, in PEX block, pneumothorax is possible, and upper limb fistula is also possible.
But you didn't notice any complication.
Pardon, ma'am?
I have not noticed any complication.
No, ma'am, I have not encountered any complications, ma'am. Most of them were obscured because these complications were because of blind blocks, but we used because ultrasound, so there was no complications which were seen.
Oh, thank you.
Next one.
Thank you, ma'am.
Good morning, everyone. I'm Dr. Himani Patel, third-year resident doctor from SSG Hospital, Vadodara. My title is Evaluation of Efficacy of Superficial Cervical Plexus Block for Surgeries in Head and Neck Region, a comparative randomized control study. My co-author are Dr. Nihasha, Assistant Professor, and Dr. Swati Bhatt, Professor and HOD, SSG Hospital, Vadodara. Introduction. Superficial cervical plexus originate from anterior rami of C1 to C4 spinal nerves and give rise to 4 terminal branches: greater auricular, lesser occipital, transverse cervical, and supraclavicular nerves, and provide sensory innervation to skin and superficial structure of anteronator, neck, and section of ear and shoulder. Unilateral or bilateral superficial cervical plexus block can be used as postoperative analgesia after a variety of head and neck surgeries such as mandibular, tympanomastoid, thyroid, submandibular, clavicular, and various other neck surgeries. It can also be used as sole anesthetic modality for external ear surgery. Superficial cervical plexus block can also be used as adjuvant block for shoulder, clavicle, breast, and upper chest wall surgeries, particularly by blocking supraclavicular branches. Superficial cervical plexus block is conventionally described as subcutaneous injection technique performed at mid portion of posterior border of sternocleidomastoid muscle, targeting superficial branches of cervical plexus, which can be performed using ultrasound or landmark. So after reviewing various references, we decided to analyze the efficacy of superficial cervical plexus block for providing effective analgesia in surgeries involving head and neck regions, such as mandibular, tympanomastoid, and clavicular surgeries routinely done in our institute. Our primary objective to note inter and post-operative requirement of total dose of systemic analgesic and observation of bar score, total duration of analgesia, and secondary objective to note vital parameter and perioperative complication. Type of study is comparative randomized control study in clinical setting. Sample size estimated using reference by taking parameter pain score at 12 hours using Metcalfe 19.5.1 with mean difference of score 3 and standard deviation 3.5 between two groups with 80% power, 95% confidence interval, 5% alpha error, and 20% beta error. Sample size for each group was 21. We took 30 patients in each group. Inclusion criteria: age 80 to 70 years, weight 40 to 75 kg, A723, Malampatti 123, duration less than 3 hours. Patient posted for mandibular and tympanomastoid and clavicular surgery. Patient able to give written informed consent. Patient able to understand bias regarding assessment of pain. Exclusion criteria: patient with coagulopathy, local infection, pre-existing neuropathy or any other neurological disease, hypersensitivity to local anesthetic drug, patient with significant history of drug or alcohol abuse or psychiatric illness. Patients were randomly allocated in two groups by sealed envelope method. Group B received general anesthesia and block. Group A received general anesthesia with systemic analgesic using injection fentanyl. Ethical clearance obtained from Institutional Ethical Committee for Human Research. Methodology: pre-anesthetic evaluation done. Thorough counseling regarding procedure and purpose done. Written informed consent taken. VAS-score explained. Anesthesia machine, oxygen cylinder, monitor all anesthetic resuscitation drug, airway equipment and suction apparatus check. All baseline parameter: ECG, heart rate, NIBP, respiratory rate, and SpO2 noted. Pre-medication: tablet intake, injection glycopyrrolate, ondansetron, midazolam, paracetamol, injection fentanyl 1 microgram per kg IV given. After pre-oxygenation, IV induction done and patient intubated, maintained with oxygen nitrous, sevoflurane, and biguranum bromide. Intraoperative: rise in heart rate and systolic blood pressure managed by giving injection fentanyl 0.5 microgram per kg in incremental doses up to 2 microgram per kg. Group B received block. All under all aseptic precaution, 10 ml of 0.25% bupivacaine injected using 1.5 inch 24 gauge needle at midpoint of line extending from mastoid to chest signet tubercle. Drug injected alongside posterior body of sternocleidomastoid muscle 2 to 3 centimeter in cranial and caudal direction in pen technique subcutaneously. Evaluation of block for satisfactory intraoperative analgesia done in term of requirement of IV analgesic by observing heart rate and blood pressure. At the end, reversal was given. Patient extubated. Post-operatively monitored for vital parameter, VAS-score, total duration of analgesia, total requirement of rescue analgesia in 24 hours, and complication. VAS-score more than or equal to 4 were given systemic analgesic in form of injection paracetamol 15 to 25 mg per kg IV. Statistical analysis done using statistical software. Data presented in mean plus or minus standard deviation. Parametric data analyzed by student test. Categorical data by chi-square test. Significance of t-test such as follow: p more than 0.05 not significant, t less than 0.05 significant, p less than 0.01 highly significant. Reason and discussion: all demographic data such as age, sex, duration, and type of surgery were comparable between two groups. As shown in graph, intraoperative fentanyl requirement was significantly higher in group A 38.63 plus or minus 12.61 than group B 10.66 plus or minus 13.11 with p-value less than 0.001. As shown in graph, two post-operative rescue analgesic requirement was also significantly higher in group A 2566.66 plus or minus 504 than group B 863.33 plus or minus 874.28 p-value less than 0.001. We found average VAS score significantly lower, 3.46 plus or minus 1.47 in group A and 2.46 plus or minus 1.19 in group B at 8 hours and 3.36 plus or minus 1.67 in group A and 3.36 plus or minus 1.18 in group A at 12 hours with p-value less than 0.01. Similarly, significantly reduced intra and post-operative fentanyl and nifopam requirement and lower bench score was also observed by 3 and 2 metal in that study, where they used bilateral ICBP in patient undergoing thyroid surgery. Pandit et al. Studied superficial cervical plexus block and deep cervical plexus block for cadaveric spread of drug and explained equal efficacy of superficial and deep or combined cervical plexus block for carotid and lateral. They found that deep cervical fascia may be porous and allow spread of local anesthetic, and it may explain the good analgesic effect of superficial block. They also suggested that superficial block carry fewer risks than deep or combined block. In our study, we found the time of first rescue analgesia was significantly earlier in group A, 32.33 plus or minus 38.29, then group B, 1092 plus or minus 396.55 with p-value less than 0.001. Similarly, Semedo et al. Studied bilateral ICBP in thyroidectomy patient and found the time of first rescue analgesia was significantly earlier in control group than block group. Other than two tympanomastoid surgery, we didn't observe vomiting or any other complication in our study. Conclusion: superficial cervical plexus provide effective perioperative analgesia as well as reduce the requirement of systemic analgesic and is side effects in tympanomastoid, medullary, and clavicular surgeries. These are my
So Himani?
Yes, sir. Good afternoon, sir.
Himani,
Yes, sir.
one observation: intraoperative fentanyl requirement.
Yes, sir.
How have you calculated it? इंट्रा या तो अपन ने लगाई या तो वो हो गया, तो मरीज की रिक्वायरमेंट क्या? हाउ हैव यू बीन जज? कैसे जज किया अपन ने कि मरीज की फेंटानिल की रिक्वायरमेंट क्या है?
Sir, we give 1 microgram per kg in all the patient, and during after block we see hemodynamic parameter, rise in heart rate and blood pressure, and more than 20% of baseline were given injection fentanyl 0.5 microgram per kg.
All the patients were given general anesthesia.
Yes, sir.
That would have included fentanyl?
Yes, sir. All the patients received fentanyl.
फिर अपन ने
Yes, sir.
इंट्रा ऑपरेटिव फेंटानिल रिक्वायरमेंट किस तरह से कैलकुलेट की? माइक्रोग्राम पर केजी और समथिंग अदर क्राइटेरिया?
Sir, 0.5 microgram per kg.
इंट्रा ऑपरेटिव फेंटानिल रिक्वायरमेंट ग्रुप ए में है 38.33, ग्रुप बी में है 10.66, है ना?
Sir, that was additional fentanyl requirement above 1 microgram.
आपने जज कैसे किया कि इसको जरूरत है फेंटानिल की?
Sir, according to hemodynamic parameter. नहीं sir, according to hemodynamic parameter.
What was that? Why?
Heart rate and blood
क्या
pressure.
डिफरेंस था दोनों ग्रुप में?
Sir, hemodynamic parameter were more met. Hello.
For example.
Sir, in patient not receiving block control group, hemodynamic, we observe more tachycardia and hypertension, and it may be due to pain, and so we
नहीं हो सकता? क्या और कोई रीजन नहीं हो सकता कि अपन ने ड्रग इनहेलेशन एनेस्थेटिक एजेंट में कमी रही हो?
Yes, sir, it could be. That is a
could be ना?
limitation. Yes, sir.
है ना? So that is the problem कि इंट्रा ऑपरेटिव रिक्वायरमेंट मरीज की क्या है? How can we judge? भाई अपनी जो फार्मा है वो कहती है इतना माइक्रोग्राम पर केजी या इतना मिलीग्राम पर केजी, ठीक है ना? मरीज की क्या रिक्वायरमेंट है वो उसी हिसाब से डिसाइड होती है ना, ठीक है बेटे?
यस सर।
बेटा प्लीज।
यस मैम।
Thyroid patients are not included.
Ma'am, actually due to COVID time, thyroid surgery were not more performed in our institute, and so we did not take that in our study.
You said that you conducted the randomized control trial. What is randomized and what is control?
Ma'am, patients were randomly divided in two groups by seal envelope method. So one received only general anesthesia and group B received general anesthesia plus block.
Which is the study group, which is the control group?
Ma'am, study group is one which received a general anesthesia plus block, and control group was only receiving general anesthesia with systemic analgesic.
Okay, thank you.
Thank you, ma'am.
Who is next? Pradeep.
Yes, sir. Good morning, sir.
Good morning, everyone. I'm Dr. Pradeep, Professor and Head, Department of Anesthesiology, Kodagu Institute of Medical Sciences, Karnataka. And my topic is effectiveness of superficial cervical plexus block in anterior cervical spine discectomies and fixation surgeries under general anesthesia. Coming to introduction and background, cervical spine discectomies with or without fixation are often painful and done under general anesthesia. These patients fall in geriatric age group with or without comorbidities, and hence abolition of pain is very vital. This prevents adverse hemodynamic changes secondary to skin incision. This also serves as intraoperative and postoperative analysis technique. This is commonly used in thyroidectomy surgeries, however less frequently used in cervical spine surgeries. Coming to aims and objectives is to assess the effectiveness of superficial cervical plexus block in patients undergoing elective anterior cervical spine discectomies and or fixation surgeries under general anesthesia. Process intraoperative and postoperative hemodynamic changes to skin incision. Process the quality of intraoperative and postoperative analgesia. Coming to methods, Institutional Ethics Committee approval was obtained. Written and informed consent were obtained from all patients. 68 class 1 and 2 patients scheduled to undergo anterior cervical discectomies and or fixation surgeries. General anesthesia were included. This was a randomized single-blinded intervention study conducted over 1.5 years. This was done in teaching hospital of PS Institute of Medical Sciences, Andhra. Patients were randomized into two groups. Group A received ipsilateral cervical plexus block using 10 ml of 0.25% injection bupivacaine. This was post-induction of general anesthesia with intratracheal intubation. Whereas patients in group B received no block but received supplemental IV analgesics to respond to skin incision in many. Induction and maintenance of anesthesia and supplemental analgesics were standardized. Sample size was calculated based on a previous study by Huang et al. Using a formula below. Sample size calculated was actually 20. However, we included 30 patients in each group. Inclusion criteria include AC class 1 and 2, of either gender aged between 18 to 70 years. Exclusion criteria for class 3 and 4 of either gender with patients with a history of allergy to peptide or any other local anesthetics, patients bleeding diastasis and clotting abnormalities, local infection at the site of superficial cervical plexus block. The brief anatomy of superficial cervical plexus consisting of lesser occipital nerve, greater auricular nerve, supraclavicular nerve, and transverse cervical nerve. This is the point of injection. This is at midpoint of the posterior part of the sternocleidomastoid mastoid muscle. This is a fan-shaped infiltration. This is an ultrasound picture showing cervical plexus behind the posterior part of sternocleidomastoid muscle. Coming to methods, ipsilateral cervical plexus block was administered using ultrasound pair with a linear probe of 6 to 13 Hz. A 1.5 inch needle of 25 gauge was used and 10 ml of 0.5% injection bupivacaine was injected. Intraoperatively, patients were assessed for heart rate, systolic and diastolic blood pressure before skin incision and after skin incision and 5 minutes thereafter. Rescue analgesia, if administered, were also noted. Complications of patients were followed up for complications. Rescue analgesics standardized to injection paracetamol 1 gram IV. Post-operatively, patients were assessed for changes in heart rate, systolic and diastolic blood pressure, VAS scores, rescue analgesics administered dosage and frequency. Post-operative analgesic was standardized to injection paracetamol 1 gram IV 8th hourly and injection tramadol 2 mg per kg SOS. Coming to statistical analysis, socio-demographic parameters were compared between the study and control groups. Categorical variables were presented in frequency and percentages. Quantitative variables were presented in as mean and standard deviations. The post-operative mean VAS at different periods were compared between the two groups. G-score test and Sloan test were used appropriately to test the statistical significance of the parameter. The trend of hemodynamic parameters and post-operative VAS were compared by plotting trend diagrams. After results, both groups were comparable with respect to age, gender, BMI, body mass index, baseline heart rate, systolic and diastolic blood pressures. However, following skin incision, there was significant rise in heart rate, systolic and diastolic BP, and these patients needed supplemental analysis in Group B when compared to Group A. Statistically insignificant changes in the heart rate, systolic and diastolic BP from the baseline were noted in Group A. Patients in Group B had higher VAS scores post-operatively, needing more supplemental IV analgesics when compared to Group A. The graphical representation of higher heart rates and systolic and diastolic blood pressure in Group A when compared to Group A. Patients had higher VAS scores in Group B till 10 hours when compared to Group A. These patients, Group B, needed more IV analgesics in Group B when compared to Group A. Coming to discussion, ipsilateral cervical plexus block resulted in good intraoperative and postoperative pain relief as noted by lesser variations in heart rate, blood pressure, rescue analgesics administered, and VAS scores. No adverse effects were noted. Findings in our study were against that of Huang et al., where they noted the general anesthesia alone to be superior technique. Findings of our study are in accordance to those of Ramamani Mariappan et al. However, the intraoperative and postoperative hemodynamics were not monitored in their study. Limitations of our study were that it was a single-blinded study and patient group did not receive any other method of preemptive analysis than routine. Hospital stay and recovery were not assessed. Future scope of this study remains various adjuvants can be assessed for their effectiveness in superficial cervical plexus block. To conclude my talk, ipsilateral cervical plexus block is a simple, safe, and effective preemptive analgesic technique in patients undergoing cervical spine discectomies and fixation surgeries under general anesthesia. Heart rate, blood pressure changes are less noted in these patients. Patients receiving superficial cervical plexus block. Intraoperative patient needed lesser dose of rescue analgesics. Post-operatively, patients had lower VAS scores and benefited from block. These are my references here.
Pradeep?
Sir, very good morning, sir.
Can you hear?
Yes, sir, I can hear, sir.
Okay. You had two group now? One
Yes,
group
sir,
with the superficial cervical plexus block, other without the cervical superficial
Yes, sir.
plexus block.
Yes,
Na?
yes, sir. Yes.
You use in both of them the same standard general anesthesia technique.
Yes, sir. Both
same,
both groups received general anesthesia.
है ना? दोनों को एक ही स्टैंडर्ड जनरल एनेस्थीसिया टेक्निक अप्लाई किया ना आपने?
Both groups have already received general anesthesia.
है ना? दोनों को दिया ना जनरल जीएचओ?
सही है सर, सही है
है ना? Then why was there this requirement of analgesic supplementation in group B, who were not given super plexus block? जिनको एसीबी नहीं दिया उनको सप्लीमेंटर एनाल्जेसिक की रिक्वायरमेंट क्यों थी?
Hello, sir. Both groups, yes, I got, sir. Actually, both groups received injection propofol, vecuronium, and fentanyl 3 microgram per kg. Okay, but however, in spite of receiving 3 microgram per kg of fentanyl, the response to skin incision was found following changes to skin incision.
The problem is with the problem is with the fentanyl, which was not able to control the heart rate.
Yes, yes, sir, definitely, sir.
So that's why we are able to. So we can increase the dose of the fentanyl.
Yes, sir. That's why what we did. One group received superficial cervical plexus block, whereas those which did not receive block, in case if there was any response to skin incision, those patients received injection paracetamol as rescue analgesics.
No, trust me, but a supplemental analgesic intraoperative you gave.
Yes, sir.
If there is a rise in heart rate because of the skin incision.
Yes, yes, right.
है ना? तो प्रॉब्लम कहाँ हुई? प्रॉब्लम तो अपनी फेंटानिल में हुई ना, कि अपन ने पूरी नहीं लगाई.
3 microgram is what I meant to say is we have used regular standard dose of injection.
इसका मतलब standard dose गलत है. It means according to you, standard dose should be more than the you use in group B.
No, some patients do need, some patients will not need also, sir. No. So only those patients.
Standard drug dose की है. So should we increase it?
That depends on the patient response. No, sir. Some patients would be benefited by 2 microgram. Some patients would be benefited by 3 microgram.
What about the books? क्या कहती हैं? Books क्या कहती हैं? Anesthesia books क्या कहती हैं? Anesthesia books में क्या लिखा हुआ है?
2 to 3 microgram per
कितने माइक्रोग्राम पर किलोग्राम फेंटानिल लगानी चाहिए?
2 to 3 microgram per kg, sir.
2 to 3 na? So you had used 3 microgram per kg.
Yes, yes, sir. Yes, sir. For the same reason.
Why
yes,
was
sir,
there
right,
need for the supplemental analgesic? Question is this.
No, that depends on the patient variability, no, sir. The patient sensitivity also varies.
तभी तो किताबों में लिखा हुआ है 2 से 3 मिलीग्राम माइक्रोग्राम पर केजी फेंटानिल लगे.
Yes, yes, sir.
है ना?
Yes, yes, sir. So in spite of that, patients will have a response to skin incision. Or, for example, if we consider endotracheal intubation response to 3 microgram per kg body weight, so in those patients also hemodynamic changes will be there even in spite of 3 microgram fentanyl. In the same way, individual variation as a response to skin incision will be there, sir. So that is the reason it was supplemented. Yes, ma'am.
Nice presentation.
Hello.
How do you assess the skin response?
Man, I can't hear you, man.
How do you assess?
Can't hear you, man.
Lot
of distance.
How do you assess the skin response?
Assessment of pain response, madam.
Skin response. You studied in your topic.
Actually, not able to hear you, man.
You are just now we are talking to the start. Skin response is studied.
Yes, madam. You mean to say skin response? I mean, response to skin incision. How was it assessed? Yes, madam. Intraoperative. That was by. Yes, madam. That was by 2 methods, like intraoperative and postoperatively. Intraoperatively, patients were assessed for hemodynamic changes to skin, like heart rate, systolic and diastolic blood pressure, intraoperatively, and postoperatively, patients were assessed by VAS scores. and the requirement of dose of rescue analgesics.
Okay, thank you.
Okay, madam. Thank you, madam. Thanks a lot. Thank you, sir.
Okay, complete. ज्यादा रिकॉर्ड मत करो।
Thank you everyone for joining this session.
और नकल कर देते हैं आपके खिलाफ।
Afternoon. Good afternoon.
Good afternoon, Said.
Oh, thankfully they did not change it today.
Yeah. I hope they have the movie, movie file available. That is another problem which comes in.
No, yesterday the same thing they happened. They were not finding my recorded file.
Yeah.
मैंने तो अपना ओटी अभी खत्म करा.
अच्छा, मेरा तो अभी चल रहा है, अभी कहाँ से खत्म करूंगा.
मैंने क्या वैसे कर दिया, थोड़ा सा शॉर्ट कर दिया.
यहाँ नहीं कर सकते, प्राइवेट सेक्टर में वो नहीं कर सकते.
Actually, otherwise I would have taken leave. I
Yeah,
do
correct.
this way or that way. At least I could do 3 cases. Otherwise, I would take leave. I am supposed to get leave because of the conference. Despite that, I'm not taking leave. I'm doing the conference along with the OT. That is fair enough.
For us, there is no leave for conference. It is just the same.
नहीं सर, वो तो देना पड़ेगा.
नहीं होता ही नहीं है, प्राइवेट सेक्टर में नहीं होता.
नहीं, टीचिंग इंस्टीट्यूशन है ना ये, विदाउट दिस से चल नहीं पाएगा ना.
नहीं, आपके यहाँ तो होना ही पड़ेगा. आई नो, आई अंडरस्टैंड दैट. बट आई एम सेइंग हमारा तो प्राइवेट सेक्टर है ना, तो यहाँ कुछ भी नहीं है.
Sir, can we start the session?
Let people come now.
Okay, sir. Okay.
Hall is full.
No, sir.
The first, Mohit, the first one is of Dr. Chakra Rao. He's sitting there, he says.
Yes, sir.
That is what I'm saying.
He says he's sitting there, he doesn't know what to do. He's sending message to me.
He's not virtual, na? He has to be on the offline.
Yeah, he's physically there.
Sir, he has to deliver his lecture. Did he record his lecture?
Yeah, his lecture is recorded. I only uploaded his lecture.
So then he'll sit down. They'll play the file.
Correct. He'll be sitting there. I think then we can start. Ask this person to start off.
Let us see whether this at least audience को दिखाए ना कितना audience है, ये तो पता चले.
नहीं मालूम नहीं पड़ता इसमें. वो इनको मालूम पड़ता, हमारे को नहीं मालूम पड़ता.
चक्कर आपको पूछ लीजिए कि कितने लोग हैं, है कि नहीं कोई लोग, तो हम स्टार्ट कर दें. 2 तो बज ही गया.
हाँ,
2 बज गया.
I think he's already there, so we can start away. ISM में तो बहुत ऐसी होता है. All काम.
ठीक है, स्टार्ट कर दीजिए.
Excuse me, yeah, you can start off, please. We have the first talk. Should I say talk if somebody is not introducing? Excuse me, who's managing the show?
Event manager, who's there in the event manager? Gurmeet?
Yes, sir.
Gurmeet, is it Gurmeet?
No, sir.
Should I introduce sir, or is somebody introducing from that side? I'm not seeing.
Who's introducing the speaker? Event manager, who's managing the room?
Otherwise, he can start and I will introduce, sir, if he puts me online.
कोई तो आया नहीं.
Tarlika told me she'll ask Rashish to introduce her. I don't know whether Rashish is available also. Sir is getting annoyed there.
Must be.
I'm getting his messages, so I can see.
Is he putting it in the group? No.
Yeah, he's putting it in the panel actually.
Panel, acha. This is an insult for our efforts. We are sitting here, don't know what to do.
I think whoever is managing the hall, could you please put on sir's slide? I'll introduce him.
वही मैंने भी लिखा वहाँ.
Excuse me, who's managing the hall?
Sorry, sir. Please give me 2 minutes.
Okay.
Sorry for the late. Now we are going to start our IRC session. And for that, I would like to invite Dr. SSC Chakra Rao, Dr. Mukul Kapoor.
Okay, thank you very much. Can you put on Chakra Rao sir's introductory slide? No. Dr. Chakra Rao slide, please. No, you are putting my slide. You please put on Dr. Chakra Rao's slide, please. Yes, make it full. Okay. May I introduce Dr. Chakra Rao? Dr. Chakra Rao is the prime person in the Indian Resuscitation Council. He is our chairman. He is a member of the Constitutional Committee of the WFSA. He was formerly the Additional Director General Health Services of Andhra Pradesh. He has been the president of ISA, also been secretary earlier. And one of the major contributions to ISA has been his foundation of the Family Benevolent Fund, which is even existing till date. As on date, he is very aggressively involved with the Indian Resuscitation Council in spreading the message of resuscitation across the country. Sir is actually the backbone of all events which have taken place as far as Resuscitation Council is concerned. May I request the organizers to please play his lecture now, talk now.
Good afternoon, everybody. This is the presentation from the Indian Resuscitation Council, an initiative of the Indian Society of Anesthesiologists. This is actually a Make in India program, as our Prime Minister, Mr. Modi, says. It is really a Make in India program, most suited for the Indian circumstances. So here I will go through how we have progressed with our own Indian guidelines. And these are the people who have actually assembled on 2017 April at Hyderabad to form these guidelines. These people were invited by me, and these are the people who are the intellects who have done it. And it is a common mission. Every citizen is a lifesaver, and every citizen in the world is a lifesaver. But in India, less than 2% of the population know about CPR, and that's why we have facing a lot of sudden cardiac arrest deaths. So actually, for each 1 lakh population, 4,280 people are getting sudden cardiac arrest, and because they are not resuscitated, they are dying. And when we wanted to start the resuscitation program in India, with the help of the Indian Society of Anesthesiologists, we made a survey. How many trained persons are available, how many paramedics and medics, and how many mannequins are available. So it is very meager, and the Indian Society of Anesthesiologists has come out, buy one, get one free from ISA, and they have distributed 180 mannequins, and that has laid the pathway for a successful resuscitation program in India. And Dr. Vinay Nadkarni, a person of Indian origin, is always constantly encouraging, and we are meeting him often. And with all these things, in 2018, we trained about 2,25,000 laymen and school children. And in 2019, we trained about 4,65,000 school children and laymen. But our message has gone to about 50 lakhs people, or even more than that, 5 crore people. So this has made us a very good success, and everybody has appreciated us, and that has brought us to the present scenario. In 2019, the National Medical Commission has made it mandatory to teach BCLS program as a foundation course to 80,000 medical students joining in MBBS. And some of the medical and health universities in AP and other places, they made them mandatory to have a BCLS training before they are leaving their institution. And with all our efforts and trials, the CBSE, Central Board of Education, has made it a compulsory and implemented it in the curriculum of 9th standard, and now it is going to be practiced. So these are the few steps we are taking, and this is our Vice President releasing the BCLS book, and our Vice President making a trial of compression on the mannequin. And our vice president, when he came to Kakinada for a platinum jubilee of the medical college, he has actually felicitated me with his own hands. And this is Vinay Natkarni with the blue shirt man. He is in the center. And this is Nitin Naik. We all met him whenever he comes, and he has encouraged us a lot. This is even the army people also taking the IRC courses, and it is going on. And this is all what we did and where we did. And it is about 4,67,000 people, but roughly it is 5 lakhs. And we did it in 2019, and it is a grand success. See here, Brent Whittaker and Dr. Andrew Lockie, who are at the helm of affairs of the World Restart a Hard Day, and they have made an applause for us, and they have prized us. This is our photo at South Africa at Gandhiji Square. We are just teaching the African students about the Indian CPR. And 2000, we could not do much work, but we did it online. And we have also invited the people from US and Europe, and we have asked them to inaugurate the first day cover of the Indian Resuscitation Council and a postal stamp in presence of our President and Secretary of IRC, ISA, and the local ministers and the other people. These are the various photographs how our people have done the trainings pan-India. So it is all the publications. We have asked to concentrate more on the social media, and we have been doing it. See, this is how they are addressing the local TV, and I am addressing the Radio Mirchi and other things. So not only me, this is only some of the photographs that I am showing, but every part of India has participated in these programs, and we brought a very good success. Now, Indian Resuscitation Council has come out, and we wanted to work closely with the pediatricians, neonatologists, cardiologists, critical care people, and emergency medicine, dental and nursing associations, and paramedical associations. So we made it a Companies Act we have formed, and we have registered it, and now we are calling it as the Indian Resuscitation Council Federation. So we have done most of the trainings, and we have almost reached about 30 crore population by creating the awareness. We have 35,000 ISA community members and 180 city branches in every state, and we are going ahead with a training of 1 million lifesavers in this year. And this is our Kalam Ji on the 27th, when we have declared it as a National CPR Day, and we are doing everything on his the day when he had the cardiac arrest. These are our publications and broadcastings, TV things, and everything is there. And we have conducted about 6 TOTs with various dignitaries of the, like Dr. Sunil Kumar Ji, Director General of Medical and Health Services, Dr. Mayank Kumar Agarwal, the Director General of Doordarshan, and Dr. K. Shankar, the Registrar of the NTR University, Dr. Swasthi Saran, Additional Deputy Director General, and Pavendra Lal is also an Executive Director and CEO of the National Boards of Examination. All these people, they have come and participated in all our activities, and they have encouraged us, and they have also told the Director General of Doordarshan has also told and instructed the people that let us do it and propagate this in all the regional languages. So from January, we are going to the regional languages. We are very well known on Facebook, Twitter, WhatsApp. Instagram, and even by YouTube. So these are the things we are creating awareness, and the creating awareness is more important as good as the training of the people. So the NMC has made it a curriculum as a foundational course for the newly joined MBBS. The Central Board of School Education has made it, kept it in the curriculum of 9th class students. The Kerala government has recognized IRC course training in all their schools. The NTR University has made it mandatory for all the house surgeons to undergo BCLS, and then only they will release the degree certificates. And Tana Foundation is conducting course in the villages of their origin, and they have appointed some people to conduct the course around the year, and they are doing a wonderful job. And this is our MP doing practicing CPR. This is our Deputy Chief Minister and the Minister for Medical and Health of Andhra Pradesh. He is doing CPR. And this is our previous Health Minister, and Dr. Harshvardhan. He is also very active. And this is our GC member. So every day, even the Global Association for Indian Medical Students, they are also doing. All the medical students are engaged, and they are also doing the CPR every day. And not only that, the Lupin company has actually participated in the propagation of CPR, and as a result of sudden cardiac arrest, and they have actually gone to the clinics of the cardiologists, 3,200 cardiologists, and reached them, and they promoted CPR in their clinics, in the waiting room halls of the doctors, so that it will be shown to everybody. So all our videos were telecasted, and they were shown in the this thing, and our people have done in many places, many important places. We conducted trainings, and very important heritage places we did trainings. And this is also, we conducted a survey on the cardiopulmonary resuscitation in COVID-19 patients, published in the Journal of Anesthesiology and Clinical Pharmacology. This is a 5-star heart care by Shruti Ambati Pataki. She is having her own training institute for CPR, and she is doing a lot of good work in Mumbai. And this is a poster that we have presented in the recent World Congress at Prague, and it has got a lot of applause. And this is what we are doing with the help of the software from Lardell. We are every day we are conducting trainings, and not less than 1,000 people are trained both evening and morning, and it is going on. This is all the software that we can show how efficiently they are doing the CPR and all those things. This is our COLS algorithm. This is all what we are doing. Again, we are showing, and finally, everywhere, all the women are involved in training of COLS, even for the marriage parties, the kitty parties, even on the 11th day of the death ceremony, even on every place. Even we wanted to keep a demo at the immunization places, but we could not do it. We have brought some automatic kiosk, where one can come and train themselves. And this is the first time it has been operated in, engaged in Kalinga Institute of Medical Sciences, Bhubaneswar. And this is also a representation of the 3 types of things, that is COLS, BCLS, and CCLS, and how we are doing in India. It is all with the support of the Indian Society of Anesthesiologists. This is a change, actually a petition and for all those things. And these are all our people doing different things. This is the calls that are encouraged by the Thana. They're all Telugu people. The people who have left for America, they wanted to see that no deaths will occur as a result of cardiac arrest. So they are training with their own people. So this is all the things. And here, the children, Kids Saves the Life is one of the programs that is instituted by the ILCAR, and this is also being tried in India. We are not away from anything. We have all brought the whatever technology we have and everything. So this is again, this boy is doing CPR. Everybody is trained, and even in the pendals in Karnataka, Lord Ganesha is doing CPR and saving. So I tell you, this has gone to a stage, to a level, even the lay people wanted to appreciate themselves by participating in mythological stories. This is the chain of reaction and chain of survival that is done by one of our important colleagues for Dasra. These are all the Rangoli that is done. Dr. Talika has done this. And this is the recent 2021 October 16th results. Already we made 6,23,000 trainings, and even Jammu Kashmir has participated in this. And not only that, by this time actually for today, we have already exceeded more than 7 lakhs. This is our Minister for State, Dr. Parveen Ji. She is a medical doctor. She has actually came to inaugurate the CRTC in Safdarjung Hospital. This is our DJHS. This is our Nikki Sabharwal with a lot of interest she has taken. And so this is where the logo of IRC is hanging with the logo of 3 lions of Government of India. And we did it, and we could establish, and the government of the Director General and the Minister for Health have taken a lot of interest to introduce the Indian Resuscitation Council guidelines into India, and they are doing it. And this is, she is talking. She has asked us to come and establish one training center in her town. We will be going by January. And this is our
to bring a law or guidelines
Vice President, who is talking and encouraging us. And this is all what I wanted to tell. And thank you very much. Thank you, sir. Thank you for giving the opportunity.
Could you please play the now the panel discussion?
Yes, sir.
No, please don't show these. Please, it's already recorded in the panel discussion movie. Don't show them separately. You can't get the file? Yeah. Good afternoon. We now have a panel discussion on the Indian Resuscitation Council. And the topic of the panel discussion is the Indian Resuscitation Council is the prime force in resuscitation training in India. I'll first introduce the eminent panel who's going to speak in this important panel discussion. We first have Dr. Baljit Singh. Dr. Baljit Singh is the professor and head of anesthesiology at the SGT University, Gurugram. He's a very experienced teacher. He has been the past vice president of ISA National, has been a past governing council member of the ISA also. And of course, he's the CEO of the Indian College of Anesthesiologists. We have Dr. Nikki Sabharwal, who is professor and consultant at the Vardhaman Medical College and Safdarjung Hospital, New Delhi. She's a very experienced teacher with a lot of interest in ATLS, in resuscitation, is an instructor for IRC as well as AHA, and of course is a prolific examiner. We also have Dr. Paul Raffel, who is the professor and head of department at Amala Institute of Medical Science at Thrissur. He's a very experienced teacher again. He has been interested in resuscitation and has been an AHA instructor for BCLS, ACLS, and today is a very important proponent and a very proficient person in resuscitation for the IRC. He has received multiple awards from the ISA National and is very involved in awareness of resuscitation training for people. We also have Dr. Manisha Katikar. Dr. Manisha Katikar is the current president of the Maharashtra State Chapter of ISA. She's the chief anesthesiologist and intensivist in Solapur, and she's also the associate editor of the Indian Journal of Anesthesiology. She's the national ISA coordinator for the Cultural Club. She's presented multiple conferences, has been very active in ISA Maharashtra. We have Syed Mohid Ahmed. Syed Mohid Ahmed was earlier the chairman of the Department of Anesthesiology at Jawaharlal Nehru Medical College, Aligarh Muslim University. He's presently professor in charge of the ICU. His area of interest is airways and CPR, and he has been one of the prime forces in the formation of the Indian Difficult Airway Guidelines as well as the Indian CPR Guidelines. He has received multiple awards and is a very prominent figure. We have Dr. Rakesh Garg. Dr. Rakesh Garg is one of the most active people in the Indian Resuscitation Council. He's an additional professor in the Department of Onco-Anesthesiology and Palliative Medicine at the All India Institute of Medical Sciences. He has got tremendous number of publications, more than 260. He's authored more than 25 chapters in books. And also has been the associate editor of JOSCP, of Journal of Medical Case Reports, is an editorial board member of multiple journals, and has received multiple awards. We also have Dr. Simantika Ghosh. Dr. Simantika Ghosh is basically a worker in liver transplant programs, health organization at Kolkata. She has received multiple awards from ISA for her various academic activities and has more than 25 publications, out of which 5 are international. My last panelist is Dr. Chetna Agarwal. Dr. Chetna Agarwal is a very well-known personality in Gujarat in particular. Dr. Chetna Agarwal is a very accomplished anesthesiologist whose interests in anesthesiology are very diverse. She is again very interested in resuscitation training. Apart from this, she's the cultural ambassador for our country, having represented India in the Mrs. India competitions abroad. My first question is directed to Dr. Baljit. Dr. Baljit, you have been a part of the Indian Resuscitation Council right from its inception. You've seen the progress of the Indian Resuscitation Council. Are you happy with its growth and the spread of the resuscitation guidelines across the country?
Dr. Mukul, if you like me to answer this question in one word, I would say yes. And to say how much satisfied I am, I think we'll have to look back at the history of Indian Resuscitation Council. It was early 2017 when Indian Society of Anesthesiologists asked the present chairman, Dr. S.S.C. Chakra Rao, to popularize the resuscitation movement in India. Having accepted this offer, his first task was to develop guidelines which are suitable to Indian setup rather than copying the guidelines from other countries. So he called a meeting of some like-minded academicians, and they set about the task of publishing these guidelines, which were published in the November issue of Indian Journal of Anesthesia. And with regard to the formation of these guidelines, some of the notable names, Dr. Kesh Garg and Dr. Mohit, were there, apart from a few others who developed these guidelines. And these guidelines have been kind of the torch bearer for Indian Resuscitation Council. Now these guidelines have been endorsed by various associations, and a lot of countries have recognized it. And using these guidelines, there's been a lot of public awareness which has been created, particularly with regard to compressions-only life support, which is only for lay people and outside the hospital. So more than 110 lakh of people who have been made aware of these guidelines, and more than 14 lakhs have been trained with compressions-only life support, and more than about 60,000 people have been trained for basic cardiopulmonary life support. So the work is going on, and a lot of people are interested in having this training. From all over the country, there are calls which are received by Indian Resuscitation Council for having these guidelines to conduct these programs of awareness as well as of training. Now, these guidelines have also been mentioned by the worthy Honorable Vice President of India, Shri Venkaiah Naidu, and of course, Minister of State of Health and Family Welfare very recently at Safdarjung Hospital. So I would say that these guidelines have made a lot of difference to the resuscitation activities in India, and to look at other associations like American Heart Association, which has its own guidelines. They started their work somewhere in 1960s, and they have taken nearly 60 years to reach this place, to reach this level. And in India, these Indian Resuscitation Council guidelines have taken just 4 years. And out of those 4 years, let's not forget, there have been about a period of 1 year where it was kind of a lockdown. So it's nearly just only 3 years in which we have made this much of progress. And to end my answer with a question, I don't know, I mean, do you know of any association which has made this much progress in just 3 years? Not me, not according to me.
Yes, you are very right, sir. Not many people could, I mean, it's not very easy. And it has been a lot of drive of the prime members of Indian Resuscitation Council that has helped us progress so much. Dr. Baljeet, one more question to you. How do you feel about our Train the Trainer guideline sessions? Are they very effective? What do you feel about them?
Well, they are very effective. They are effective because these programs, Train the Trainers program, there is a pre-test, there is a post-test. In the pre-test, the skill and the knowledge base of the candidate is can be made out, and in the post-test that is further assessed, and the data shows that there is a tremendous improvement in the skill as well as the knowledge base of the candidates who who participate in these programs. Apart from that, having attained the skills of resuscitation, they impart training to other people in their vicinity or in their close group or among their family members. So I think these trainings, these programs of Train the Trainers have been very, very effective with regard to propagation of the core activity of Indian Resuscitation Council, that is to popularize resuscitation, that every citizen can be a lifesaver and be with just two bare hands can make a difference between somebody's life. Two bare hands can save a life. So that is the motto of Indian Resuscitation Council.
Thank you, sir. My next question is directed to Dr. Syed Mohit. Dr. Mohit, you have been in the forefront for writing the guidelines. You have been, you have seen the challenges which we have come across. So what do you feel, what were the challenges and what is the way ahead, in your opinion?
A very pertinent question, sir. I would say that actually, whenever you make anything new, you will always face some hurdles, especially in a situation where you have already an established guideline. And it is very difficult to replace that guideline which is there with the terminology of those guidelines, especially which is being so much taken by the people of our country. And then replacing that by our guidelines, it's always been a challenge. So the second component is that data. The data itself is a challenge because we really did not have any data with us. So anything which we will make will always always be put up in a format that probably are we remaking it, something like that. So there will be a lot of questions amongst the the takers or the people population. I mean our population. And secondly, whenever you make any guidelines which is based on the target group which you are targeting. So there are different categories of people in our society, a different level of people, level of understanding. So we have got to come to that level and then frame guidelines according to the level of our people. So where obviously you have to categorize that guideline according to those people and then frame guidelines. So that itself is again a problem which you have to face and which we faced. And then further implementing those guidelines. So once you frame a guideline, then implementing it again is a very difficult because now it's your responsibility to take it from one door to the other door and one state to the other state, tell them, motivate them, teach them every aspect of that guideline, the concept of the guideline, the queries of the guideline, and then let them accept it. And when you're developing a guideline, it itself was such a difficult job for us, especially because if you remember those days, it was very difficult to meet together and then frame guideline. We have really gone for a video, Skype, and everything we did, and then we framed the guideline. And as I said, training the people pan-India, going from one door to the other, one state to the other state, everywhere. It was really a Herculean task for us. So, further, especially again, further developing the subsequent guidelines is again a challenge for us. So one is we've already done to a certain extent. Now the further challenge which is awaiting, it's not that end of this, we have miles to go. So we have to again frame further guidelines, which is again a difficult job for us. So overall, if you see, it is really a difficult because replacing the guideline which was existing and then coming to a new guideline is very difficult and was a very difficult task for us. Yeah.
Mohit, one more thing. I'm aware that you have recommended to the NMC about how the MBBS students should be trained in resuscitation. Can you elaborate a little bit about what you have done?
Yeah, actually, what I did is actually, if you see the new the concept of NMC, the curriculum, they have changed their concept to a skill-based training or outcome-based training or teaching. So that is what I took that opportunity to push our guideline and frame and then put it forward to the NMC. So that was one thing which, especially what NMC has now trying to implement is that from the very first go or very first day of the career of an undergraduate, they would like to start a skill-based training. That means they have an orientation program. So on the first month of the induction of the undergraduate students, they have an orientation program where the first year students, undergraduate students, they will take all the skill-based training. So there I tried to push the COLS, right? And I taught them the COLS. I pushed it forward to the NMC and obviously that was again accepted. The second component was now NMC has made a draft. It's yet to be made it in the Gazette format that the postgraduates are supposed to get training, at least certified BCLS course before they go to the subsequent year. That means from the first year to the second year. That is going to be mandatory because that is what has been put forward. So that again was something which I pushed forward. I recommended it from our institution, from our MU, because they had asked us NMC has asked us to to change the curriculum in a form of outcome-based training. So that is what I recommended and I put forward to them, and I hope it will be further accepted in future. So that is what we did, and probably some component is already there in the new guideline, curriculum. They have said that what I have seen in the draft is that first year of PG must take the BSLS certification course. So that is what is something which we did, and probably with the help of the others, teachers, institutions also, we'll be able to do it. Yeah.
Thank you, boy. My next question is directed towards Rakesh sir. Rakesh, you have been a prime member again of the IRC, and you have been very much involved in publicizing what IRC does and working towards international recognition of the IRC. Can you please elaborate what efforts IRC has done as far as the media is concerned, social media as well as the TV media?
I think there are two aspects of creating awareness about any new thing. It may be just creating guidelines and publicizing into a national journal, which gives a credibility. But we have seen many guidelines are just under the cover of various journals, various books, and they have not become so popular. So just to make it popular, we have to create some awareness. And this awareness is basically a multi-pronged. Our big umbrella of Indian Society of Anesthesiologists, with such a huge number of anesthesiologists across India, with various district branches, city branches, state branches, and with the national headquarters, we are getting a good support with awareness of it. So this is one aspect. The second is IRC has taken the first step across the world. It's a proud moment to say that they have created the specific focus guidelines for layperson, which was COLS, calls guidelines. And the Indian population, we had a survey where they mentioned that hardly 1 to 2% of people are trained. And we have seen big dignitaries collapsing on the dais, on the playgrounds, and they're collapsing it. So this means we cannot create a manpower of health professionals at these places. And we need to create a pool of layperson, which we can say our ambassadors also, across the whole population across India. And for this, we need to create sensitization. And we have used social media very efficiently, whether it was a print media, whether it was through radio format, or whether it was through TV format. And it was really good to see that when we contacted those people, they are really very much emphasized, they are very much enthusiastic to take this session forwards to create awareness. So this social media is helping us a lot. And not only this, I would urge all the delegates who are listening to us, it is responsibility of each one of us to use our platform, whatever social platform, whether it's Twitter, Facebook, Instagram, whatever they are using it, to create awareness for creating people learning CPR at various platforms. And I think IRC is doing a great job, but we need to have our more pool of such people who are very fond of the social media, and we need to have more face value of IRC so that we can create more awareness and create more training.
Thank you, Rakesh. I think we have got a face on the Doordarshan channels, we've got the face on the private TV channels, and I think we have been able to generate a lot of publicity for IRC and resuscitation in particular. Rakesh, one more thing, you have also been involved in getting the IRC guidelines onto the school syllabi, that is in the CBSE. Can you elaborate a little bit about the importance of that?
Absolutely. If you see any of the awareness programs, if we can rope in the school students, they are good ambassadors for us. A young budding brains, if you can just modulate their brains, they are the real heroes for us. They are the real ambassadors for us. So that is what we have taken the opportunity, and we were lucky that CBSE was very proactive. At that point of time, CBSE was planning to create a new syllabus for the healthcare into the CBSE for 9th, 10th, 11th, and 12th. So I, being a part of team, we decided that why not to have the CPA program itself into the curriculum, and they wanted that it should be there. And it was a good support from the Deputy Director and Director CBSE along with Ministry of Health and Family Welfare Corporation, that this was incorporated into the CBSE curriculum. And then once it was incorporated, the other thing is how to create the pool of trainers. And then subsequently CABC allowed, they called 2 teachers from each school across India. And we have done a lot of training, 3 or 4 training programs, which every training program has more than 80 to 100 teachers from different schools, and we could train them. So we were successfully able to transmit the importance of CPR. We were able to create the pool. And I think these school students are real heroes for us. We could see a lot of enthusiasm in them. And the thing is, if we teach somebody a 9, 8, 60, 70-year-old guy to become a trainer, why not to make this 12, 13, 14-year trainer who will be in the community for next 6, 7, 8 decades? So I think that's the pool that we are looking at. But having said that, we need to have more pool of trainers to have more awareness and more training.
Thank you, Rakesh. Yeah, the children in the schools right now are the future of the country, and that is what is important to tap. And I think it's a great effort by all of us to get CPSE to include it. Thank you, Rakesh. And my next question is directed to Dr. Manisha Katikar. Dr. Manisha Katikar, you are a very senior executive in the Maharashtra ISA. And the Maharashtra ISA has been very active in organizing different types of training programs across Maharashtra. How do you feel? How were the trainings? Were the trainees enthusiastic? Were the people attending the training also enthusiastic? And what was your take home?
Yes. Thank you so much for giving me opportunity to represent Maharashtra. Sir, as far as my colleagues are concerned, Indian Resuscitation Council has definitely created a significant impact on the enthusiasm, and anesthesiologists all over in Maharashtra are really enthusiastic about IRC, and they are actively doing course activities all over Maharashtra. You all know that Maharashtra is a dynamic and enthusiastic branch of National ISA, and we have many active members who are working for the society. What I feel is that everyone who practices anesthesia cannot become an academician, but they want to express themselves in front of the public. They want themselves to teach the skills that they have acquired over the years. And Indian Resuscitation Council has given them a way to express themselves. And all enthusiastic members of Maharashtra State Chapter ISA are coming on the common platform, and they are doing course activities. Members are getting recognition in front of a common man as life skill performers, life-saving skill performers and trainers. This is very important for us. The role of anesthesiologist, that is the role that is behind the curtain in the operation theatre, is expressed by his skills in front of a layman. And this IRC has done this. His recognition in the public as a lifesaver is really satisfying. I personally feel that this satisfying motivates them, inspires them to reach and they go on with more and more CPR programs. Sir, I can tell you that few of them are so zealous that they carry their own mannequin in the operation theatres and their cars and teach laymen who are present in the outpatient department of the hospital after finishing their role. The equation of IRC for Maharashtra IRC is operation only life support activities. Because of COVID pandemic, the BCLS and the CCLS activities, there is less knowledge at the moment, but definitely the COVID restrictions are getting lifted up. Social activities are possible now. And recently, Maharashtra State Chapter ISA celebrated 3 weeks of public awareness activities along with course activities. Every single branch arranged maximum programs all over Maharashtra. The social media platforms and WhatsApp groups were flooding with all the activities of schools all over Maharashtra. I must tell you this, sir. On the occasion of World Anesthesia Day on 17th October, as it was a Sunday, we conducted course activities all over Maharashtra in 32 branches at one time in the morning. And myself and my secretary, our secretary, Dr. Avinash Bhosle, communicated with all the branches through the Zoom platform, and we encouraged all of them for the course activities. This was the first time that mega course activity was conducted successfully by Maharashtra. Regarding the enthusiasm of trainees in learning CPR, it is remarkable, sir. Young school children and the college students are more eager to learn, have many queries, and are always enthusiastic for the hands-on workshop for course activities. Adult population is also eager to learn when they realize that their efforts can serve someone's life. Many times we are getting invitations from common people. Someone who had attended our program invite us again for the course activities. This enthusiasm is necessary on both the sides. So I must say that both trainees as well as trainers are enthusiastic all over Maharashtra. Every member of Maharashtra State Chapter ISA is motivated and inspired to conduct CPR program.
Thank you very much, ma'am. It was excellent. Actually, Maharashtra is doing a great job. And it is because of the COLS activities in Maharashtra, the association activities, that we had a viral message going, which was covered across the country, in which one doctor who was trained by our people, he managed to save his neighbor. And that became a viral message. And I'm sure that is going to reap great dividends for all of us and spreading the message across the country. Thank you very much, ma'am. I'll direct my next question to Dr. Simantika Ghosh. Dr. Simantika, you have been involved with the first workshop of the IRC during Isacon, Kolkata. And what do you feel was the local impact in Kolkata of this workshop?
Good evening, everyone. Thank you for the question. It was really a very proud moment for all of us at Kolkata to be holding the first workshop on 24th November 2017, where the guidelines were formally launched. So most of the people here, most of the anesthesiologists were part of the program, and that has helped us create a lot of awareness, not only in the anesthesia community, but also in the non-anesthesia community. And such that we have done at least, at least 20 to 50 programs after that. And we have launched a Jeevan Dan project with Rotary International. And we have, under that project, we have been able to train at least, if not more, 2,000 school students in the duration from 2017 November to 2020 March, after which obviously COVID struck us. So the impact of this workshop being held in Kolkata was really, really great. And we are still working on it. Hope we do more.
Eastern India is very different from other parts of there are a lot of problems of geography in Eastern India, a lot of problems of transportation and other things. Do you think that IRC has been effectively reached the people of Eastern India?
Yes, I totally agree with you. Eastern part of India is quite different from the rest of India in many terms. We have been trying our best, both the branches of Indian Society of Anesthesiologists in West Bengal, like the ISA West Bengal, as well as the ISA Metro City branch. We have been trying our best to overcome all the hurdles that are there. And I think we are doing good. We have been doing a lot of PCLS and also a CCLS training program, the training of the trainer programs, also school programs. We have also been actively participating in radio shows. We on the occasion of the National CPR Day, we had a talk on the radio as well. So we are trying our best to overcome all these hurdles. What we have not yet been able to tap is probably a link in the government organizations. I mean the government per se, so that we can percolate into the or penetrate into the government institutions. That is somewhere where we are working at, and we are soon maybe we'll get a lead. So other than that, I think we are doing good.
Thank you, Dr. Simantika. So we come to the next panelist, and I direct my next question to Dr. Nikki Sabharwal. Dr. Sabharwal, you were the first person to form a CRTC in a CGHS-run medical college at Delhi after the sanction of the Union Health Ministry. There are multiple CRTCs in the country, but you are the first to get a sanction of the Union Health Ministry and set up this thing. What was your experience as far as that was concerned, and what is its acceptance today?
Well, very good evening to everybody, and thank you for having me on this August panel. Dr. Mukul, I'm very passionate about CPR training, And since 2019, I used to wonder why in Delhi we are not having our IRC training center, because it was a very, very proud moment to have the Indian guidelines launched in November 2017. And it was my dream project. And I had approached some members of the IRC in 2019. But because that time, the NABH accreditation, we were going for that, and we had to train the entire hospital in BLS. So, but it couldn't happen at that time, and we had trained around 3,400 people from the hospital. But then COVID happened, and this remained my dream project to start a CRTC in Delhi. And fortunately, we have a very proactive Director General Health Services, Dr. Sunil Kumar, and sir has also, he is very passionate about teaching and training all life-saving programs. And he has this vision of making all the 3 central government hospitals BLS certified hospitals. So he gave me this task, and that is the time when I took the opportunity to tell him that, till now we have been teaching the CPR, based on the American Heart Association guidelines, but we have our own guidelines, and we don't have a recognized EHS center either at our hospital too. So I showed him the advantages of coal especially, and our BCLS and CCLS, and the fact that it is our Indian homemade guidelines, which are being recognized internationally by ILCOR as well. And we had a presentation, and he agreed that we must have the CRTC center at Safdarjung Hospital. So with his blessings, and he arranged for the Minister of Health was not available, Mr. Mansukh Mandavia. So we had the Minister of State, Dr. Mrs. Bharti Praveen Pawar, come and inaugurate the center on 20th October 2021. And that is a really, really gratifying experience. We had a very positive response. In fact, the Honorable Minister, she's requested Dr. Chakra Rao, because as you know that Dr. Chakra Rao graced the occasion, and all of you who are the founder members of the IRC were there too, and we had the first inaugural course. And Madam Minister, she requested Dr. Chakra Rao that please open a center in my constituency too. So it has been very, very gratifying, and now we are working towards making the entire hospital BLS certified, starting with the emergency block. And COLS is going to come in very handy, because earlier we had trained all people in BCLS, which takes time, and it may not be so pertinent for the non-medicos. So now we have divided the people, the healthcare workers and the support staff for the BCLS and the COLS training. So it's been, a very, 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 I think, gratifying and a very pleasant experience. And it has, seen the light of day, and I couldn't be more happier.
Thank you, ma'am. Thank you very much. Yeah, being a part of that, I was one of the spectators who saw this inauguration by the health minister. And I'm sure there's a lot of, enthusiasm in the ministry also today. And I am sure that this is going to help IRC in propagating the message of resuscitation. Thank you, ma'am.
In fact, if you give me another minute, Dr. Mukul, I just want to also apprise you that the Director General Health Services has requested us to take this training to the ministry also, and train all the personnel in the health ministry in COLS and BCLS.
That's great, ma'am. That's really a great thing, and that's a great achievement for IRC and for you also, of course. And thank you, ma'am. My next question is directed to Dr. Paul Raphael. Dr. Paul, you have been in the forefront of IRC training in the state of Kerala, and you've been a very active member in training people across the state. What was your experience in Kerala? You're muted, Dr. Paul, you're muted, please.
Sorry for that. Thank you, Dr. Mukul sir. I'm very happy and proud to say that we could train a good number of people on our unique algorithm. What we have is calls. So that was a great achievement, and I'm very thankful to the national team for giving all the support led by our chairman, Dr. Chakra Rao sir. So I had the opportunity to attend the first TOT along with Dr. Samantika, and with all the senior leaders were there also there. And after that, what we planned in Kerala was to train the trainers. For that, actually, we got the help from Dr. Chakra Rao sir and Dr. Rakesh sir. Both of them came down within, and this was within 4 months of after this, and we could train 50 trainers. Next, our plan was to give training to the school children. For that, what we did was to have a collaboration with the Rotary and also with the Indian Medical Association. So we could do it. So before that, what we did for the school children was to meet the education minister of that time, and then convince him about the necessity of calls. And what he did was he put an order to train them in an assembly during the assembly session on October 23rd. That was the first time we did our World Restart Heart Day. So that was how the beginning. Then we later started training the laymen, the public, the police. And another thing, what we found that most of the people available on the road to treat them will be the drivers, mainly the auto rickshaw drivers. So we aimed them, and also the ambulance drivers, and we started teaching. So we could also do next year also in 2019, along with the district collector, we inaugurated. And what we did the next year was to give these mannequins to the school children so that they can take that home. They can study there and take that home and teach their family members. So that was a great achievement when we could train a good number of people with that. And we plan to continue our own aim, what our IRC has to train all the citizens with codes so that we can save everyone, each life.
Thank you, Dr. Paul. That's great. Actually, a lot of effort has gone in Kerala, in particular, whatever I am aware of, and especially I've been very regular in training the people who come for driving licenses, etc. And we are very, we are very fortunate that all of you have taken such a lot of interest in IRC activities in Kerala. Thank you, Dr. Paul. My next panelist is Dr. Chetna Agarwal. Dr. Chetna Agarwal is the country's brand ambassador in international pageants. She has taken part in many international beauty pageants. And not only has she been the ambassador for the country, she has been an ambassador for the Indian Resuscitation Council because she has been training people during the pageants. And I would like to ask you, Dr. Chetna, what was your experience about training people during the pageants? And also, what was the acceptance of the other contestants during of the IRC guidelines?
Sir, actually, COLS training and IRC has set really great standards across the world, I would say, because this has brought India across the world platform. And being the secretary of ISA Vadodara, so I felt that this training should be given to everyone. So this first happened during my pageant, Mrs. India Universe 2019, when I had to go to Mauritius for the pageant. And per chance, I was missing my activities on 16th October, which was World Anesthesia Day and World Restarted Heart Day. So that day, after the entire program of the pageant was over and after the dinner was over, we had a gap of about 15 minutes between the next session training for the next day. So I thought, why not use those 15 minutes for training of the finalists there. So luckily, all the finalists who were sitting there agreed immediately, and I didn't have the mannequin, so I gave the training on a pillow right in the dining area. So it was everyone who was there in the finals, everyone participated in the training, and everyone did hands-on training also. So it was really a great experience. And like I was basically feeling guilty that I was not able to participate in my city for the CLS training programs, but I could manage to do the CLS training in Mauritius. So it was a great feeling. Then after that, I went to Mrs. Universe pageant in 2019 December. And there also, after the pageant was over, so there also I did the training of the finalists and even the directors of the pageant. They also participate, and the relatives who had come with the finalists, they also participate, including a child. So like it was a truly very satisfying experience at pageant level. It was a totally new experience for me, and doing it at Mrs. Universe, which is considered the best among the Mrs. category of pageants. So it was definitely a great experience for me. And recently on 18th October, I did it on in Mr. Miss Mrs. Glam International Icon in Mumbai. So again, after the entire pageant was over, at midnight, I did this entire training with the finalists as well as the directors and the fashion designers of the pageant.
Thank you, Dr. Chetna. You know, you have been our brand ambassador of the Indian Resuscitation Council. You have been spreading the word. We want people to know about this word, and I'm very happy to state that you have been a great ambassador for Indian Resuscitation Council.
Thank you, sir. Thank you so much.
And I would like to ask you one other thing. You know, Indian Resuscitation Council training is taking place in lots of places in Gujarat, and you have been a part of that training. So how do you feel? Is the training effective? Are people getting trained? Are people benefiting from this training?
Yes, sir. Definitely people are getting benefit from this, because like we come to know from the some people whom we have trained, we get feedback sometimes that they have been able to help someone in such where CLS is required in such situations. Even the members, they have been able to resuscitate their family members. And one of the trainers had trained in a mountain like trekking place. So even there it was an experience for him. So like everywhere where we get a chance, we utilize that opportunity, and we get feedbacks from all the people we train, how the training was and whether it has been effective in saving somebody's life anytime later also.
Oh, that's very good actually. And how often are you training people in Gujarat or in Vadodara in your city?
So in my city, we regularly conduct programs. Recently, I prepared an entire PPT for the entire year. And in 2019, Vadodara was declared the best city in CLS training in Gujarat. We got the award for that in the Isacon 2019, which was arranged in Vadodara. So we have made a group, ISA Vadodara CLS group, and we have a Facebook page also where all the activities are updated from time to time. So our members are very active. Even in after the COVID, immediately we started the trainings even at physical level. So with obviously all the precautions taken. And in COVID times, we did virtual training also, even to the level of international level, like amongst the relatives, and even like I had done for the pageant people who were there in Mauritius. For their group, I had done online training. Dr. Arvind Patel sir had done it in his family group and relatives from USA and other places in the world. So we have conducted city level, we have conducted national level, we have conducted international level trainings, both physically as well as online.
Thank you.
And even in big groups like the police people, we had trained around 500 people. So everywhere the acceptance is very good.
Thank you, Dr. Chitna. It was great interacting with you and finding out about what all is happening in Gujarat and in your particular city, of course. It's great. Thank you. Because of constraints of time, unfortunately, I'll have to conclude this panel discussion. We had a very interesting panel discussion in which each and every eminent member contributed tremendously to the cause of resuscitation and to the cause of spreading the information about the role IRC has been playing over the last few years. Thank you very much. Thank you for attending this session. Any questions, organizers, please? So I don't see any questions here. So I think we should conclude this session with a big thank you to ISA for giving us an opportunity to interact with all of the delegates and spread the message of resuscitation, and also show how prime IRC has become in resuscitation training in the country, and how important it is, and how it has overtaken all other resuscitation training programs. Thank you very much. I thank the panelists once again. Thank you. Goodbye.
Thank you, sir. Now we are going to start our next session, complications in anesthesia and management. I would like to invite chairpersons Dr. Vijay Kumar H.M. and Dr. Savita Saini and Dr. Bharti Kondvilkar.
Hello. Hello.
Hello. Can we start the session?
Good evening. Am I audible?
Yes, ma'am. You are
Am I included in the group now? Hello. There's some. Good evening, everyone. बात नहीं बन रही. Hello.
Hello, Vikas sir.
Hello.
Hello, Vikas sir.
Hello. Am I audible?
Yes, sir. Yes, sir. Yes, sir.
Because.
Sir, Vikas sir, you are going live.
Yeah.
Okay, sir.
Shall I start?
Yes, sir.
Hello.
Hello. Yes, ma'am.
I am Dr. Savita Saini. Should we start the session, declare the session open, and invite Dr. Vikas for the lecture?
Yes, ma'am. Yes, ma'am.
So, I should speak now. Hello.
Yes, ma'am. Sure.
And you are audible.
Okay. Good evening, everyone. Welcome to this session after post lunch. Now I invite Dr. Vikas Karni to speak on the topic, and who is from Pune, Maharashtra, and Dr. Vikas is going to deliberate his talk now. Dr. Vikas, please.
Thank you, madam. Good afternoon, everyone. Respected chairpersons and dear all. I bring greetings from the city of Pune. This is the place where I work. This is Sayadri Group of Hospitals. This is our flagship hospital, which is situated at the heart of the Pune city, and this is one of the major neurosurgical centers in the western Maharashtra. So to begin with, air embolism, it is an array of clinical conditions determined by entry of gases like air, oxygen, carbon dioxide, or nitrogen into the bloodstream, driven by the pressure gradient which exists between the atmosphere and the vascular system. So it can happen outside the hospital also, and can be seen in those who are into scuba diving and aviators, and this usually happens because of sudden changes in the ambient barometric pressures. But the same can be seen in hospital setup where we may encounter it usually in operation theater, but not limited to. And nowadays we can see in endoscopy suits, we can see in the trauma patients, and we can also see it in the ICU setup. So whenever there is an air which is getting entrained into the bloodstream, it can happen either into the venous or obviously into the arterial system. Or there can be a paradoxical air embolism which happens from venous to arterial side because of the existing defect usually at the cardiac system. So vascular air embolism, potentially it is a life-threatening event. Routinely, we have seen it in the operation theater, but it is no longer restricted to the operation theater, no longer restricted to the neurosurgical procedures which are performed in the sitting position. And there is a diverse area of patient care and procedures where it can be seen. So in surgical procedures, it happens because there is a gradient between the operative site, which is above the heart, and there's a negative gradient. It can happen in neurosurgical patient. Number of neurosurgical procedures, including the spine, it can happen. It can happen in the procedure performed in the neck. Can happen in ophthalmic procedures. Can happen in the cardiac procedure, especially when patient is on a heart-lung machine. Can happen in the thoracic procedures. Orthopedic procedures, we have seen it happening during arthroscopy, especially the shoulderscopy. Can happen in obstetric and gynecological procedure, including cesarean section and PCRE. And in neurology, can happen during TRP or even during the open prostatectomy. So there is a vasculature which is explored in the surgical field, and there is a gradient between the operative site and the heart. This gradient needs to be as low as 5 centimeters of water, and through a 14 gauge cannula size, there can be entrainment of air of almost 100 ml per second. And if there is a coexisting hypovolemia and negative pressure, which is associated with the spontaneous respiration, can become an additional risk factor for the air embolism. So this is not only restricted to these procedures, but can happen with mechanical insufflators, which we are using during laparoscopic procedure to create pneumoperitoneum, and can also happen during gastrointestinal endoscopy, where we are using air for dilatation of the bowel. It can also happen with the pressure infusers, which we are using as an anesthesiologist or in the intensive care setup for fluid resuscitation, where we are using these infusers to push the fluids at a rapid rate, and it itself can contribute to vascular air embolism. In addition to this, there can be a direct vascular entrainment through central venous access related procedures, radial artery catheterization can happen during epidural catheter placement, especially when we are using the loss of resistance to air technique. So there are multiple risk factors. The surgical risk factors just we have discussed. In arterial, there can be cardiopulmonary bypass, ECMO, cardiac ablation, intracardiac shunt, and carotid aneuploidy, which can contribute to the arterial air embolism. In anesthesia, pressurized infusion that we have already discussed, and non-primed giving sets. So if there is no de-airing, it can contribute to either vascular or even venous or arterial embolism. So intraoperative vascular air embolism, which is reported as early as the 19th century in both pediatric and adult patients, and more than 4,000 articles have been published in the last 30 years. The most striking feature accumulated during this period is there is a myriad of clinical circumstances in which the vascular air embolism may present. And it is nothing but a result of increased technological complexity and invasiveness of modern therapeutics that we are using. So most episodes that happens are likely preventable, and that is why the name of the topic is the air embolism prevention and management. So the incidence, it is very difficult to estimate because it varies from venous and arterial air embolism. It varies from procedure to procedure, and obviously it is position specific. However, if you just have to put it in a range, it can have a very wide range from 16 to 86%. And in most cases, it has no relevant clinical manifestation. Every time we can have a different clinical presentation of the vascular air embolism. Coming to the pathophysiology, the impact and the clinical manifestation, they depend on two factors. One is patient-related factor, and the second is gas-related factors. In patient-related factors, whether it is a venous or arterial system which is involved, which side the air is getting entrained, what is the body's position during the embolism, and overall health of the patient. And gas-related volume of the air entrained, and at the rate at which the air is getting entrained, and what is the blood solubility. So if we are dealing with air, it is very problematic for us. But if we have gases like oxygen or carbon dioxide which is getting embolized, then because of its solubility, the impact may be comparatively less. So coming to the venous air embolism, whenever the air gets entrained in the venous system, they can have three impacts. One is the direct impact, which is subdivided into two. So if there is a small amount of air less than 50 ml, that can be removed by the pulmonary vasculature by gas diffusion. But if there is a large volume, it can lead to obstruction, and it can obstruct from the right heart outlet to the small arterioles into the pulmonary system. For clinically visible and fatal impact, 300 to 500 ml of gas needs to be introduced at the rate of 100 ml per second. Usually it happens through 14 gauge catheter, and the patient carrier should be more than 5 centimeters of water. The same can happen when there is a paradoxical embolism from where the venous air goes into the arterial system, and that it can directly cause an obstructive element. Indirect is because of the air embolism, there can be initiation of inflammatory response, and it itself can lead to non-cardiogenic pulmonary edema, bronchoconstriction, decreased lung compliance, increased airway resistance, and ultimately can lead to hypoxemia. Coming to the arterial air embolism, the impact again will be direct. It will cause obstruction to macro or micro circulation, and can ultimately lead to the organ damage. The most vulnerable organs for arterial air embolism impact is brain and heart. So other organs may be affected, including GI system and the skin. It is believed that 2 ml of the air is enough to cause a significant neurodeficit when it goes into the cerebral circulation, and as low as 0.5 to 1 ml in the coronary circulation can be fatal. Indirect impact will again be related to the inflammatory mediators that we have seen in the venous system. Clinical manifestations cardiovascular. If the patient is awake, obviously patient will have chest pain and palpitations, and otherwise there can be ECG changes. Coming to respiratory system, if the patient is awake, patient with sudden shortness of breath, there can be a substernal chest pain and there will be dry cough. In anesthetized patient, there will be sudden drop in ETCO2. There can be hypoxemia and hypocardia as a result of ventilation perfusion mismatch. So this is how the respiratory symptoms will present. It depends on the amount of air that is entering, small, medium, and large. Small will be less than 0.5 ml per kg, medium 0.5 to 2 ml per kg, and large will be more than 2 ml per kg. And there will be varied clinical presentation accordingly. Coming to the central nervous system, arterial air embolism will cause ischemic stroke. In awake patient, there will be sudden loss of confusion, dysarthria, hemiparesis, and seizures. And under general anesthesia, there will be failure to wake up. If the blood supply to the brain stem is interrupted, there can be associated cardiac dysarrhythmias and apnea. If there is a venous air embolism, there will be indirect deterioration secondary to the cerebral edema, and patient may land up into coma. In gastrointestinal system, there can be associated abdominal pain. Coming to the management of venous air embolism, because that is something which we commonly see. The management of air embolism is optimal management is nothing but attempts to prevent it. So whenever it happens, as we start managing the patient, there has to be a very high level of suspicion. There should be early diagnosis so that we treat the patient as early as possible and avoid the fatal complication. There can be attempts should be made to prevent further entrainment of the air. So coming to the diagnosis, new sophisticated monitoring devices, as we all know, can be used. The most sensitive investigation is transesophageal echocardiography, which can detect air as low as 0.02 ml per kg, followed by precordial Doppler, which is 0.05 ml per kg. So sensitivity is almost same. However, TE is invasive, while the precordial Doppler is non-invasive, and precordial Doppler availability even in a medium-sized center is comparatively better as compared to the PET. PA catheter is also sensitive, however, it is invasive. Another options that we have are end-tidal nitrogen monitor or end-tidal carbon dioxide monitor. End-tidal carbon dioxide is now commonly available. It is non-invasive and it has got a moderate sensitivity of 0.5 ml per kg. Other monitoring options like oxygen saturation, direct visualization, esophageal stethoscope, and ECG, they are very low in sensitivity. So once we diagnose, the principal goal of management of air embolism is to stop the continuation of the entrainment of the air. We have to avoid any further air going into the bloodstream, because once it happens, the risk increases with more and more air getting into it. The more the volume at a rapid rate will cause more complication, more fatality. So the principle will be prevention of further air entry, reduction in the volume of air that is entering. So we have to stop any further air going in. Whatever air has gone in, we have to try and attempt to take it out and provide hemodynamic and respiratory support during this phase. So the preventive measures in this particular situation, prevention of further entrainment of the air is by repositioning the patient, the surgical site and the right atrium. The gradient should be minimized, and surgical sites should be irrigated with a fluid. Can be packed with a package if we are performing a neurosurgery. And intravascular volume should be optimized, and if allowed, positive end expiratory pressure in a moderate level can be used. To stop the inflow of the air into the circulation, the minute we suspect that there is an air embolism, we should immediately announce so that surgeon stops performing this surgical procedure and starts flooding the surgical field with the irrigation fluid. And he can also try and assess and probably eliminate any entry site. For example, if there is a venous sinus which is open during the surgical procedure. And simultaneously, we should try and adjust the position of the patient to lower the air pressure gradient to minimize the more air entrapment and provide 100% oxygenation, and avoid using nitrous oxide during this phase. In literature, there is a mention about transient bilateral compression of the jugular veins, which is not performed because it's a controversial maneuver. It itself can increase the ICP, it can reduce the brain perfusion, and it can concomitantly compress the carotid arteries. So during the management of the air embolism, we should institute 100% oxygenation, make sure that the FiO2 is 100% to maximize the patient oxygenation during period of cardiovascular instability. This will also help in elimination of the nitrogen, and this will also help in reducing the embolus volume. Coming to the efforts to reduce the embolic obstruction, we should the head of the patient in neurosurgery should be repositioned and should be brought down at the level of the right atrium, and to relieve the airlock in the right side of the heart, the patient should be kept in a left lateral decubitus position, which is described as a Duran maneuver, so that the air bubbles move towards the right atrium and not into the right ventricle. And it becomes very easy probably to aspirate and also avoids the same air bubble obstructing the right ventricle. Tender position can be given if patient is hemodynamically unstable. If there is a central venous catheter, the air loss between SVC and right atrium can be attempted. To continue the efforts to reduce the embolic obstruction, recent literature in animal model has questioned the realigning of the position, like giving tendon position or giving dural position, because it has not shown to provide any additional benefit. Aspiration of the air from the right atrium, although it is intuitive, the success rate of appreciable aspiration of the air during venous air embolism are far from ideal. The success rate with the multi-lumen central line catheters that we use, or the Swan-Ganz catheter, is only 6 to 16%, and with the multi-orifice catheters like BA catheter, it is 30 to 60%. Average volume of air reported to be aspirated in literature is not more than 15 to 20 ml. There is no data which support that in such situation we should go for an emergency central line incision for aspiration of the air, because patient will be hemodynamically unstable, patient will require respiratory and hemodynamic support, and hence it is something which is not recommended. Coming to the hemodynamic support, the available literature discussing the hemodynamic treatment options in case of air embolism is limited. However, in multiple studies, they have studied the role of dobutamine to increase the contractility of the right ventricle, and also noradrenaline to increase the systemic vascular resistance to maintain the normal perfusion pressure, have been studied and found to be successful. Coming to cardiorespiratory resuscitation and chest compressions, rapid initiation of CPR with defibrillation if indicated, and chest compression have been demonstrated to be an effective maneuver in case of massive air embolism which results in the cardiac standstill. The rationale behind closed chest massage is to force air out of the pulmonary outflow tract into the smaller pulmonary vessels, thus improving forward blood flow. Substantiated clinical evidence of efficacy is there in the literature. Coming to the hyperbaric oxygen therapy, hyperbaric oxygen reduces the size of the bubble. It promotes nitrogen reabsorption and also improves the passage of dissolved oxygen into the bloodstream. Thus, the impact of embolism, specifically the arterial air embolism, can be reduced and the complications can be minimized. The use of the hyperbaric oxygen has been more common in arterial air embolism, especially in the brain. There are some other therapies which are of unproven benefit, like giving anticoagulation, giving glucocorticoids, and also using lidocaine. However, in the studies, there is no evidence which can support these therapies, so they can be clinically effective. The prognosis of venous air embolism is very difficult to define because it depends on the volume and the rate at which the embolism happens and the other factors associated during it. However, in past, the mortality rate was as high as 90%. Now, with the use of hyperbaric oxygen therapy, which is recently studied a lot, in recent case series, the prognosis is the mortality is 20 to 30%. So, what are the risk factors that lead to the death or a persistent neurological deficit in these patients? So, one is cardiac arrest at the time of the air embolism. Patient with geriatric age, presence of focal motor deficit or Babinski sign at the time of ICU admission. There is acute kidney failure, prolonged mechanical ventilation for more than 5 days, and simplified acute physiology score more than 33 at the time of ICU admission. So these are the factors which are the risk factors may define poor prognosis. Now coming to the prevention of venous air embolism in neurosurgical procedures and procedures of the head and neck. Patients should be monitored for venous air embolism with a high level of suspicion. Transthoracic or transesophageal echocardiography should be available, especially if the procedure is performed in a semi-sitting or sitting position. In patients who are high risk for venous air embolism, central venous catheter should be in place with a tip lying just at the junction of the SVC and the right atrium. And in these cases, if general anesthesia is given, nitrous oxide should ideally be avoided. Coming to the patient position, especially those patients who are given head-up position, they are at risk of venous air embolism. So in these cases, if we give good leg elevation and if we maintain leg and heart level at the same point, there is a good venous return and core circulatory volume can be maintained, which itself can reduce the risk. While giving the position, what we can do is we can, if the arterial line is in situ, then we can measure the pressures at the heart level and then at the surgical site and try to keep the gradient less than 5 centimeters of water. Maintaining adequate hydration is also another important and reliable preventive measure that we can use. This reduces the pressure gradient between the right atrium and the venous port of the entry. And in these situations, the RA pressure should be maintained between 10 to 15 centimeters of water. In these cases, nitrous oxide should be avoided as a preventive method.
Hello, sir.
Yes, ma'am.
Sir, due to shortage of time, we have to move on next speaker.
Just last 2 slides, sir.
Okay, sir.
Use of PEEP is a controversial and can prove to be problematic if there is a cardiovascular instability. Use of military anti-shock trousers has been recommended but not routinely available. So the take-home message is identify procedures which are at risk of venous air embolism. Plan appropriate monitoring, especially at high-risk patients. We should have transesophageal or transthoracic Doppler and ETCO2. There should be a high level of suspicion, 100% oxygenation with moderate heat in case there is a suspicion that an embolism has happened. Attempts to aspirate the air can be made, and in case of catastrophic venous air embolism, inotropic support and CPR should be initiated at the earliest. And if there is a paradoxical cerebral air embolism, patient can be considered for hyperbaric oxygen therapy. Thank you.
Thank you, Dr. Vikas, for the coverage of this such a vast topic in the given time. However, this is such an important topic for all persons to be having high index of suspicion, and that is important for the timely intervention and treatment so as to have a better outcome. So in your experience, you are doing neurosurgery.
Yes.
So, ever have had any chance of having such devastating problem?
Yes.
Okay. And outcome was like we could manage and it was fine, or you would like to say some other things to the resident participants if they are there in the audience?
Basically, we had almost 6 cases in last 15 years where we have seen air embolism happening.
Okay.
Out of these 6, 5 patients they recovered well. One patient had a long ICU stay, though she recovered. It was a long ICU stay and required multiple therapies for the recovery. This happened in first 5 years, and then slowly with the new surgeons coming in, the concept of sitting position started going down. Now most of our osteoporosis surgery we are performing in park bench position, and for every patient, what we do is a post bubble test who is posted for osteoporosis surgery to rule out presence of any defect, intracardiac defect. so that those patients are not given sitting position. So preferably now sitting position is avoided unless it is surgically mandatory. And when it is surgically mandatory, we do 4-bubble test, and we also have a centralized CT.
Right. Thank you so much. Thank you for the nice coverage of the topic. Anyone else, any other chairperson would like to communicate? Hello. Okay. Thank you, Dr. Vikas.
Thank you.
Can I talk with other chairpersons? Hello.
Can we move on to the next speaker? Hello, ma'am.
The other chairpersons can introduce the next speaker and we can move to next talk. Hello.
A 30-year-old Brooke Pranigavida, 39 weeks of gestation, presented to the obstetric emergency with the diagnosis of intrauterine fetal demise. There is no fetal movement for past 2 days. Our antenatal investigations are within normal limits. The first and second trimesters were uneventful. No other significant fast or family history. On examination, the patient is well oriented. The place, person, everything. Abdominal examination showed term site fetus encephalic presentation without cardiac activity and patient not in labor. She was posted for an emergency cesarean section and a subarachnoid block. Around half hour post-delivery, she had started having symptoms of hypoxia, such as irritability, sweating, and anxiety. On examination, patient tachycardia. There is a sudden drop in ETCO2 with a flat capnogram. Blood pressure drops suddenly and become unrecordable, and there is no evidence of PPH. Sudden drop in ETCO2, diagnosis and management by me, the Dr. S. B. Gangadhar, the professor and leader of the Department of Anesthesiology, Sri Siddhartha Medical College Research Center, Tumkur, Karnataka. Have you ever thought of this situation? It is a sudden drop in ETCO2. It is a matter of concern for us. We, the anesthetists, is a life-threatening or life-saver. And we, the anesthetists, what to do and what not to do at this junction. So for this situation, to come across this situation, once we are going to see this, there is no pulse, no BP, and no this thing. We have to start with a CPR. Then simultaneously we have to intubate the patient, start ventilating the patient, and we have to push the fluids, and automatically we have to give the drugs. Once we are come to know that, I think there is a response for this, then we have to start the brain. So the etiology can be classified into the organic causes and mechanical causes. The organic causes are decreased cardiac CO2 production, reduced cardiac output, and hypertension, hypovolemia.
Welcome all delegates to the Isacon 2021 at Ahmedabad, land of Gandhi Babu. As anesthetists, we all know complications in anesthesia are commonly moderate to severe in intensity and have less time for its management. So it's better to be ready continuously and alert for the management of any complication during the anesthesia. Objective of my today's session are, at the end of session, all delegates should be aware about the definition of TURP syndrome. Also, understand the pathophysiology of each manifestation of TURP syndrome and aware about the prevention, diagnosis, and treatment of the TURP syndrome. So, what is TURP? It is an endoscopic procedure using the irrigating fluid for the gentle dilatation of the mucosal bed, dissection of the prosthetic tissue, and removal of the blood and debris from the male urinary passage. Irrigation fluid is used for the gentle dilatation of the mucosal bed, removal of the prosthetic tissue and blood and debris, and it also enhances the visibility through the endoscope. Different types of irrigation fluids are available, but each one has its own merits and demerits. But the ideal irrigation fluid should be isotonic, non-toxic, transparent, electrically inert, inexpensive, and sterile. So whatever the irrigation fluid is going to use, small to moderate amount is going to absorb. But that is the main culprit for this TURP syndrome that we will see in detail in today's session. So let's see which are the other complications for the TURP procedure. They are the, other than the TURP syndrome, are the bladder perforation, hypothermia, bacteremia, and septicemia. The similar procedure like TURP are the PCNL, that is a percutaneous nephrolethotomy, and another is a TCRE, that is a transcervical resection of endometrium. In both the procedure, there is also endoscopic resection of the tissue using the irrigation fluid, and they also have same complication like the TURP syndrome. So also we should keep in mind during this kind of surgery also. So what is the definition of TURP syndrome? TURP syndrome, it is an aberration in the central nervous system, cardiovascular system, and other system which manifests due to the absorption of the irrigation solution during the TURP procedure. Common manifestations are circulatory overload, water intoxication, glycine toxicity, ammonia toxicity, hypertension, hypovolemia, hyponatremia, visual disturbances, and coagulopathy. So, for the better management of the TURP syndrome, it is better to understand the pathophysiology of each manifestation of the TURP syndrome. So let us start with the first, there is circulatory overload. Even the TURP syndrome occurs or not, small to moderate amount of irrigation fluid is going to be absorbed. The average rate of absorption is 20 ml per minute, and ultimately which increases the circulatory volume and overload, which reflects in the increased systolic and diastolic blood pressure and bradycardia. Because of the reabsorption, it also causes the dilution of the serum protein, and that causes the decrease in the serum oncotic pressure. This decreased serum oncotic pressure leads to fluid shift from the vascular compartment to the interstitial compartment, and ultimately leads to pulmonary edema or cerebral edema. Reabsorption fluid also accompanies the sodium movement from the intravascular compartment to the interstitial compartment also. So every 100 ml fluid shift draws 10 to 15 milliequivalent sodium with it into this interstitial compartment and ultimately leads to hyponatremia. The fluid reception is commonly depends on the three main factors, that is the duration of surgery, weight of the prosthetic gland, hydrostatic pressure of the irrigation fluid column. So duration of surgery, if it is lasts more than 60 minutes, then larger duration is available for the reabsorption of the irrigation fluid. So it suggests that it should be always limited to up to the 60 minutes. There is a weight of the prosthetic gland. If it is increased more than 45 grams is resected, then larger amount of the more number of the open cut venous sinuses are available for the reabsorption of the irrigation fluid. Another important point is the hydrostatic pressure of the irrigating fluid column. So whenever the hydrostatic pressure is more than the blood pressure, then the larger amount of the irrigation fluid is going to absorb. So it is suggested that it should be maintained at 60 centimeters above the patient's level. Second is the water intoxication. It occurs due to the absorption of the irrigation fluid. There will be the decrease into oncotic pressure and low osmolarity. Water retention occurs in interstitial space. This increased water retention also leads to the hyponatremia. Symptoms of the hyponatremia appears when the serum sodium level falls 15 to 20 ml below the normal level. Common signs and symptoms are: patient becomes somnolent, incoherent, and restless. Seizures, coma, and patient in this disarrhythmic condition are seen in the severe condition. Clonus and positive Babinski response are present, whereas the papilloedema with the dilated sluggish reacting pupils are seen. EG will be low voltage and bilateral. So how we can calculate the reabsorption of this irrigating fluid? The formula suggested gives a rough amount of the absorbed irrigation fluid, and that is the preoperative sodium divided by the postoperative sodium multiplied by the extracellular fluid, and the amount which we get should be minus by the extracellular fluid. Suppose the weight of the patient is 60 kg, then its extracellular fluid is a 20% of body weight, that is 12. Preoperative sodium if 140 and post sodium is 100, then if we put all the values in this equation, we will get the rough average fluid reabsorption, and that is 4.8 liters during this surgery. The third most important manifestation is a hyponatremia. Sodium is essential for the proper function of the excitatory cells, particularly of the heart and brain. So low sodium occurs due to mainly four mechanisms. First is dilution of sodium through the excessive reabsorption of the fluid. Second, loss of sodium into the stream of the irrigation fluid from the prosthetic bed, which is going to be cut. The loss of sodium into the pockets of the irrigation solute accumulates in the periprosthetic and retroperitoneal space also. And fourth is when the glycine is used as irrigating fluid, then the large amount of glycine stimulates the release of the arterial natriuretic peptides in response to the volume load, which further promotes the natriuresis. Common signs and symptoms are the restlessness, confusion, incoherence, coma, and seizures, also develop in severe cases. When serum sodium falls below the 120 milliequivalent, it leads to the hypotension and reduced myocardial contractility. Further decrease, and that is if serum sodium is less than 115 milliequivalent, leads to bradycardia and widening of QR complex, ventricular tachycardia, PPC, and cardiac arrest may occur. Glycine toxicity. Normal value of serum glycine is 13 to 17 milligram per liter. Absorbed glycine from the irrigation fluid leads to the toxicity of the heart and retina and may lead to the hyperammonemia in the body. It is an inhibitory transmitter in the spinal cord and brainstem. Glycine has depression effect on central nervous system and also causes a visual disturbances. Metabolite of the glycine like the glycolic acid, formate, and formaldehyde are also causes of visual disturbances. So common signs and symptoms are nausea, vomiting, and seizure in the severe cases. It also causes a slow respiration, spells of apnea, and cyanosis may occur. Hypertension, oliguria, and anuria also noted, where death in severe cases may occur. Ammonia toxicity. Normal value of blood ammonia is 11 to 35 micromoles per liter. Ammonia is one of the major byproducts of the glycine metabolites. So, how it is metabolized in the body? So, when ammonia is normally converted in the liver via the ornithine cycle, and arginine is one of the intermediate products necessary for this cycle. So, whenever there is a deficiency of this arginine in the patient, then ornithine cycle is not fueled with this, and that leads to the ammonia accumulation in the body. So, high ammonia concentration suppresses norepinephrine and dopamine release in the brain. Hyperammonemia may last 8 to 10 hours post-operatively also. Silent symptoms are nausea, vomiting, and may lead to coma. Hypotension and hypovolemia. Hypotension, it is the classical hemodynamic sign of the TURP syndrome. How it occurs? Hypotension is occur in response to the release of the precipitation substance and endotoxin into the circulation and also associated metabolic acidosis. Hypovolemia is due to the blood loss during the TURP. The significant blood loss causing decrease in the oxygen carrying capacity, leading to the myocardial ischemia and infarction in morbidly elderly people. Blood loss correlates the size of the prostatic gland which is resected, the duration of surgery, and also the skill of surgery. The average blood loss during the TURP is 10 ml per gram of the prostate gland that is resected. Visual disturbances and coagulopathies. Transient blindness, foggy vision, and hair around the objects are alarming symptoms for the TURP syndrome. The vision returns normally after 8 to 14 hours of surgery. Blindness is caused by retinal dysfunction due to mainly the glycine toxicity. Pupils remain dilated and unresponsive to the light. Accommodation reflexes are also lost, but the perception to the light is preserved, which differentiates it from the cortical blindness. Optics remains also normal. Another manifestation is a coagulopathy. So DIC or the consumption coagulopathy can occur due to the release of prostatic particles reaching tissue thromboplastin into the circulation that causes a secondary fibrinolysis. Dilutional thrombocytopenia can aggravate the situation. DIC can be diagnosed by the decreased platelets, increased fibrin degradable products, and decreased plasma fibrinogen. So it is better to prevent rather to treat the sequelae of the TURP syndrome. So prevention can be done by following method. That is, the preoperative hyponatremia should be diagnosed and corrected accordingly, particularly in the patients, those who are taking diuretics or on low sodium diet. Serum sodium estimation should be done half an hourly to hourly during the surgery in such high-risk patient. Prophylactic antibiotics should be given. Ideal height for the irrigating fluid should be maintained 60 cm to limit the reabsorption of the irrigation fluid with the ideal irrigating fluid. Duration of the surgery should be restricted to 1 hour. Suppose surgery which requires more time to reset, it should be done at the stage TURP. Prostatic capsule should be preserved and bladder distension should be avoided. Cautious fluid therapy and PCV therapy to maintain the optimum hemodynamics in the morbid patient. CVP monitoring or the pulmonary artery catheterization are also helpful for the cardiovascular monitoring in the morbidly elder patients. Maintain normothermia with the premium intravascular fluid and irrigating fluid. With this prevention, also the type of anesthesia is also matters for the diagnosis of the TURP syndrome as early as possible. So spinal anesthesia is preferred over the general anesthesia in TURP syndrome because the early manifestation of the TURP syndrome is better detected in the conscious patient in spinal anesthesia. Due to the peripheral vasodilatation and peripheral flooding of the volume, which avoids the circulatory overload, occurs due to the reabsorption of the irrigation fluid. Blood loss is also less during the spinal anesthesia because of the peripheral flooding of the joint. It also provides some degree of post-operative analgesia also. So, even though with this prevention, suppose TURP syndrome occurs, then it is better to diagnose as early as possible so we can prevent the fatal sequelae of that syndrome. So, yawning of the patient or inclusion of the talking of any patient during TURP surgery should not be neglected. Symptoms like dizziness, restlessness, confusion, nausea, vomiting, retching, headache, visual disturbances, blurring of vision, tightness in the chest and throat, shortness of the breath, and abdominal pain are seen. Signs are patient becomes lethargic or unconscious, hypertension followed by the hypotension, refractory bradycardia, pupils dilated, and sluggishly reacting to the light. Short episode of the tonic-clonic seizure may lead to the coma in severe cases are seen. Cyanosis are also in severe cases, whereas the easily changes nodal rhythm, U wave, widening of the QRS complex, and heart attack can be also detected. So, treatment of the TRP syndrome. It comprises of the correction of the each manifestation of the TRP syndrome. So, ideally, treatment should be initiated before the central nervous system or cardiac complication occurs. Surgical should be terminated as early as possible. Fusimide should be given 0.5 to 1 mg per kg IV, but it may further aggravate the hyponatremia. So 15% menthol has been suggested as its action is independent of the sodium excretion and increase the extracellular osmolality. Oxygen by mask should be given. Pulmonary edema should be managed with a tracheal intubation and 100% oxygen with a positive pressure detection. Seizure should be managed with a diazepam intravascularly. Whereas the barbiturate, midazolam, or muscle relaxant are also given during the severe, depending on the severity of the seizures. Blood loss should be managed by the Paxil volume instead of the whole blood transfusion. Arterial blood gas analysis, hemoglobin, and serum sodium should be estimated repeatedly. Correction of hyponatremia should be done with a 3 to 5% hypotopic saline at the rate of not more than 0.5 milliliters per hour correction or not faster than the 100 ml per hour. So approximately 200 to 300 ml of hypotopic saline is needed for the correction of hyponatremia. Rapid administration may lead to the pulmonary edema and central content myelinolysis. So always be cautious about the infusion of the hypotopic saline. It should be very slow and with a slow one. Slow amount is also required. IV calcium may be used to treat the acute cardiac disturbances during the surgery. In the case of DIC, fibrinogen 3 to 4 grams should be given IV, followed by the heparin infusion 2000 ml bolus and then 500 ml per hour. Fresh frozen plasma and blood juice may be also be used depending on the co-injection profile. So after managing all this manifestation, when the patient becomes stable, then patient's vitals and investigation should be closely and repeatedly monitored in the intensive care unit till the full clinical recovery occurs. Thank you.
Thank you, Doctor. Thank you, Dr. Vibhuti, for the excellent. Am I audible?
Yes, ma'am, you are audible. Yes, ma'am, you are audible.
Okay. Thanks, Dr. Vibhuti, for excellent coverage. Almost all the aspects of very important topic of clinical importance. So actually, this is every day, and now the day and night, these kinds of surgeries are being done. And I think everybody has to be well prepared for it. I don't think there are any other comments or questions in the box or somebody's asking. So thank you. And I hereby declare the session closed.
Thank you, madam.
Okay.
Thank you.